morning all. My name is Dr. Anteni Mutinta. I come from Zambia. I'm an Merck alumni, specialty of interventional radiology. I would like to welcome you all to this session, our speakers, the panelists, our esteemed audience out there, all the health professionals that are online. Welcome to this cancer awareness program, the Oncology Session. As Merck Foundation, we are committed to providing access to cancer care equitably, and we are so glad to have this session, and we hope that we will benefit so much from so many speakers that we have outlined for you today. I would like at this moment to introduce my co-speaker, Dr. Fatou. Dr. Fatou is coming from Gambia. She is a surgical oncologist, and with that, I would like her to say a few things, and she will welcome our first speaker as we get our ball rolling.
Good morning, all. My name is Fatoumata Jaita from the Gambia, also an alumni from the Merck Foundation. Did surgical oncology at Tata Memorial Hospital, now an orthopedic surgeon as well. So we'd like to call on, we're honored to invite our first speaker for the session, who's Honorable Professor Dr. Shripad Banuvali. So Prof. Banuvali serves as the Director of Academics and Professor in the Department of Medical and Pediatric Oncology at Tata Memorial Hospital, Mumbai, India. He's also a professor of the prestigious Homi Bhabha Institute, which is an annex to the Tata Memorial Hospital. So today he'll be sharing his insights on the vital and evolving area of cancer care, advancement in immunotherapy for pediatric oncology. Over to you, Prof.
Thank you, and good morning, everyone, and thank you for coming for this talk, and thank you, Merck Foundation, for giving us this opportunity to talk about a topic which is getting more and more interesting in the near future. So I'll be talking about advancements in immunotherapy for pediatric cancers. There's no disclosures actually, except that some of the treatments are not standard of care. So, as you can see, many of the cancers in the last 15 years in pediatric oncology, many cancers, there has been improvement in survival. But as you can see here, actually in the recent years, the advancement is not as good as was there in the previous years. Not only that, actually in cancers like acute lymphoblastic leukemia, which is one of the most curable cancers, you can see here, it's plateaued out now. The advancements in the last 10 years, actually the outcome is same or inferior to what was there in the previous years. And why has this happened actually? You can see the most important treatment that we use in pediatric oncology is still chemotherapy. And as we all know, chemotherapy works on dividing cells. So unless the cell is dividing, the chemotherapy will not kill it. And as you can see, there are various drugs which work in various phases of cell cycle. So those we can kill. So there's no problem with that. We can kill those cells. But very importantly, many of the cancers, especially the advanced cancers, actually have what we call the stem cells or the G0 cells. And these are the non-dividing cells. And as we all know, the chemotherapy doesn't work on non-dividing cells. Not only that, actually, after some time, many of these cancers get resistance to the chemotherapy. So both ways, you can see that after some time, chemotherapy does not work as much as it works in the newly diagnosed patients with cancer. And that is where the role of immunotherapy comes, because as we all know, immunotherapy does not need dividing cells. Most of the cells have receptors, and once you know which receptors are there, if we can target, if you have some treatment to target those cells, then you can basically use immunotherapy effectively. And as we can see here, actually, the immunotherapy starts with the chemotherapy itself. So when we give chemotherapy, actually the cells die. They actually let go of many antigens, which itself can work as basically vaccines. Not only that, actually they prime the T cells, and then these T cells, the active T cells, then home to the tumor, and once they infiltrate the tumor, then they can attack the tumor cells and kill the tumor cells. So immunotherapy is becoming an interesting and important way of treating cancer, more so in adult cancer. But as you can see, there are two important players in this field. The first is the tumor cell itself, and very importantly, tumors like to evade immunity. So many of these tumors, through various mechanisms, can evade immunity, and their tumors have two things. One is the antigen that they can present, and as one is the programmed cell that ligand 1 or PDL1 expression. So if both of these go up, then the immunity can get suppressed. And the other thing is the T cell, which has the T cell receptor and the programmed cell that one receptor. So these are important constituents in the field of immunotherapy. And why do we need immunotherapy? Is that first, like I told you, the frontline chemotherapy is getting maximized and further improvement is difficult. There are really no good new chemotherapeutic agents that have come in the last few years. I think the last blockbuster was the cisplatin and carboplatin. After that, we really don't have any good drug that has come out. Then the subset of high-risk patients continue to do poorly despite of chemotherapy plus even transplant. There is no improvement or minimal improvement over time in patients with refractory and relapsed cancers, especially so because as the initial treatments become more effective, patients who relapse, it's more difficult to treat them. And especially in low and middle income countries, if we further try to intensify the treatment, we lose more patients because of infections and other complications, toxicities of the chemotherapy itself. However, we know that for the immunotherapy to be effective, basically the tumor cells have to have a lot of mutations. Higher the mutation burden, more the effective the immunotherapy is. As you can see, the highest this thing is in the colorectal cancers, which have MSI, which is MSI high, and you can see they are the best. But most of the pediatric cancers are low. They are cold tumors, what we call, so they are really not effective. Chemotherapy is available for these tumors, that we have to keep in mind. But at the same time, we have to keep in mind that if we know where to use these immunotherapies in a subset of patients, they can be effective. They can be effective in patients with relapsed refractory disease. And more now, we are also using it in frontline therapy. They are better tolerated than many of the high-dose chemotherapies. Efficacy is improved, as I told you, in subset of patients, but the most important thing is most of these treatments are still in the patent period, so there's no generics available. India can produce thousands of generic chemotherapeutic agents, but still being in patent period, we don't have generics for them, so cost is a big problem in many of the patients where we want to use it. But still, I'll show you some areas where we have really helped the immunotherapy has helped us. The first is in ALL, especially the B-cell ALL, in neuroblastoma and lymphomas, especially the Hodgkin's disease. So I'll show you some examples of how it has helped us to improve the treatment. And first is the acute lymphoblastic leukemia. As we all know, that's the commonest pediatric cancer. And no, I think it's not showing here. But recent advances have been, first advance was to identify those cells which are more important in causing relapse, and that is the understanding of the minimal residual disease. So once we started estimating that, it helped us to improve the outcome. The genome-wide analysis helped us more to understand the biology of ALL. We have further, since most of the patients now get cured, we want to decrease the long-term side effects, so we have removed the radiation therapy in most of our patients with acute lymphoblastic leukemia. And very importantly, the last one is the use of molecular and immunotherapies in our patients with ALL. And this is the thing you can see here from that. It's important both in BALL as well as in TALL, and you can see we have been using multiple monoclonal antibodies like rituximab, inotuzumab, then we have blinatumomab. We'll talk about that later. But at the same time, we also have started using CAR T cells, that is anti-CD19 and now anti-CD22 CAR T cells in BALL. And even in TALL, we have daratumumab monoclonal antibodies. We have CAR T cells now coming against the CD7. So these are important. And as we see, more and more advances are happening in this field. So we are getting more monoclonal antibodies, more CAR T cells. and the field is still young. Yeah, so basically inotuzumab is one of the anti-CD19 monoclonal antibodies. Since it is not a continuous infusion like in blinatumomab, it is used more in the induction period where we can use this, and that's important for taking care of high-risk ALLs. And the blinatumomab, which is a bispecific antibody, that is I know is anti-CD22 monoclonal antibody. This is a bispecific antibody which on one side expresses CD3 and the other side it has CD19. So it brings the CD19 positive leukemic cell near the T cell which is CD3 positive. So it brings them together and then it can cause the tumor death. So blinatumomab is a bispecific antibody which has really revolutionized the treatment, especially the patient with high risk ALL. And this you can see here, basically we started using it like any new drug, which always we start using it in relapse setting. So in relapse setting, it showed us that if we use this monoclonal antibody, we can decrease the intensity of treatment. Like I told you, when you use more intensive treatment, we can lose patients because of side effects of treatment. So here you can see that when we use this in patients basically who then underwent transplant, patients who received the monoclonal antibody with reduced intensity chemotherapy, the outcome was much better than patients who received intensive therapy and went ahead to get transplanted. So this actually has now made it more easier to treat patients with relapses. And not only that, we are now using it more and more upfront, that is in newly diagnosed patients where protocols now are using inotuzumab as well as blinatumomab. And there's already this paper which was just published some months back where you can see that patients who received the chemotherapy plus blinatumomab, this is standard risk ALL. Not only in high risk ALL, now we have started using it even in standard risk ALL, and you can see here that the outcome was much better. The event-free survival was 88 versus 96% here. And you can see here now it was not only seen in overall in the cohort, but also for patients with average risk as well as patients with high risk standard risk ALL. So both basically overall it helps all patients with even standard risk ALL, and now we are using it more and more upfront in patients with standard risk ALL as well as high risk ALL. The next one is the CAR T cells. So, you know what the problem with the antibodies is that many of them have half-life which is very short. Like I told you, the inotuzumab can be used once every 8 days or 15 days. But here the blinatumomab has to be given as a continuous infusion for up to 28 days in a row. So it becomes impractical or difficult to use this antibody. So now what we have done is basically we have made the T cells express the CD19 itself. So what it's called the chimeric antigen receptor cells that we have produced, the CAR T cells, which these are cells which themselves we genetically engineer these cells to express the CD19, and then this CD19, the T cells, this genetically engineered T cells, go near the tumor cells and then kill it. So this important is we are becoming more and more better, so that these CAR T cells, once they are infused, they not only grow inside the T cell, inside the body, they kill the cells, the tumor cells, and again proliferate. So they proliferate more, and they remain in the body for months or sometimes even years, and still we don't know how long, but different CAR T cells remain in the body for a longer time. So this is like a continuous infusion of giving monoclonal antibodies. So this is the CAR T cell, which is the different types. So the commonest one is the anti-CD19 CAR T cell. So like I told you, CAR T cells are live drugs that engage, destroy, and proliferate inside the body, so they remain for a longer time. So we even at the Tata Hospital, along with the Indian Institute of Technology, IIT, what we call, we have produced our own CAR T cell, and very importantly, this is the world's first fully humanized CAR T cell. The advantage of a fully humanized CAR T cell is that it remains in the body for a longer time, and also it causes less side effects. So basically both ways, less toxicity and more efficacy. So maybe this will be a good CAR T cell. The future, we have recently, just a few days back, published this paper where we have showed that in pediatric, adult papers are already published, but even in pediatric, you can see those who got more than 3 million cells per kg, most of these patients are doing well. So very effective treatment for patients, not only with relapse, but hopefully in the future it will also be used more in patients with high-risk ALL. And this is just to show our data from Tata Hospital. If you see here, most of our patients with relapsed refractory ALL used to die. So hardly, very few of them used to remain alive. But if you can see here, basically after using various things like we have a BLINA patient program, the helping programs of BLINA, CAR T cell, stem cell transplant. Using all this, our outcomes in relapsed refractory leukemias have really improved a lot in the last few years. So what is the role of immunotherapy in ALL? It is already being used in patients with relapsed refractory disease to bridge for transplant or even in curative settings. It has a role in very high risk, ALL, like the hypodiploid ALL, MLL positive, or the infantile ALL, which was really difficult to treat, the TCF3 HLF positive ALLs, which again are very difficult to treat, the internal amplification of IM21, which is again difficult to treat. So all in this settings of high risk, very high risk ALL, it has become very important, and it is giving us really great results. Subset with poor chemotherapy tolerance, like the Down syndrome patients where they don't tolerate the chemo well, we can use this immunotherapy and improve the outcomes. And very importantly, all patients as upfront to reduce relapses, reduce treatment-related toxicities and late effects. Though this has not become as of today's standard of care, in the next few years, I think it will change the way we treat ALL, and this is just the way I think what will happen in the next few years is that we'll start with basically low intensity remission induction, not like the really 4-drug and 5-drug therapy, but 1 or 2 drugs like we are doing already for Ph positive ALL. We'll use low intensity like prednisone, vincristine, a few drugs there along, and then go ahead, actually decrease the tumor burden and go ahead and give the inotuzumab like monoclonal antibody, which is not to be given every day, but just once or twice in the induction. Consolidate this with the BITE or the blinatumomab antibody. Some patients who really have very high risk may even require CAR T cells, but using all this, then we can just go ahead and give low dose maintenance therapy and cure. Unlike what we are doing now, more and more intensive treatment, all this will not be required, and treatment will really become simple in the next few years. What about, so that was ALL. The other important area is the Hodgkin's lymphoma, and we already have multiple drugs which are already approved by the FDA. And the first one is the nivolumab, basically, which we started, again, like I told you, all new drugs have to be started in patients with relapsed disease, refractory disease. And when we use this in relapsed refractory setting as a single agent, you can see we had a good overall response, but the CR rate was very low, 17%, 9%. But if you see this, when we started combining this, the checkpoint inhibitors with chemotherapy, you can see the response rates improved. Not only improved, the CR rates improved from 15% to 57%, and even up to 95%. So very good response rate when we use this with chemotherapy. And again, like I told you, most of these drugs are really expensive, cannot be used in low and middle income countries, including in India. We are finding it difficult to use. So we started experimenting, seeing whether we can decrease the dose of this, the checkpoint inhibitors. And we have published various papers from India showing that we can decrease the dose, and this is still effective. And this our paper has just come last week actually, which has shown that when we use very low dose, that is a fixed dose, 1 vial is of 40 milligram. We cannot go lower than that. So we use 40 milligram of nivolumab, which is average was around 1.2 milligram per kg dose. This is as 1/3 the dose of standard dose of more than 3 milligram. So 1.2 milligram per kg along with bendamustine. And you can see most of the patients that we have given this, except one patient who was initially very early, there was a relapse and death. But otherwise, all other patients are doing well when we have used this treatment in patients with relapsed refractory Hodgkin's lymphoma. So not only, like I told you, it is used in relapsed refractory. This is again another paper which came at the beginning of this year, where in New England Journal, which showed that if you use nivolumab plus AVD chemotherapy in the Hodgkin's lymphoma, in high risk, imagine high risk Hodgkin's lymphoma, nearly 100% of the patients were doing well basically at more than 3 years follow-up. So very importantly, it will change the way we are treating Hodgkin's lymphoma in the near future, where we'll be using nivolumab or one of those the immune checkpoint inhibitors along with chemotherapy, and decrease not only the side effects but also improve the outcomes of patients with Hodgkin's lymphoma. So really important discovery for our patients. Next one, so I told you about ALL and Hodgkin's. These are the hematological tumors in cancers in children. The other thing is the brain, the solid tumors. Now, as we all know, the immune therapy works much better in hematological malignancies as compared to solid tumors. But still there are patients or subtype of patients where immunotherapy will be very, very important. And we'll start with the brain tumors. There are multiple treatments available now. Adopted cellular therapy is there, vaccines are there, viruses are there, antibody therapies are there. So multiple therapies are available. But one thing again you have to keep in mind, CNS is a very restricted site. So it is actually a tumor, cold tumor area where ideally, theoretically, immunotherapy should not work. And as you can see here, if you give all brain tumor patients immunotherapy, there was very minimal or no response in most of the patients. So if you see as a group, it had failed. But you then have to see subgroup of patients where it can work. And one thing is this patient, it's a small population, a small subset of patients, but you see these patients with mismatch repair deficiency, those who have that, or the SMARC CB1 deficient tumors. Here there is more basically cell kill with the checkpoint inhibitors, and here the T cells infiltrate, or the immune cells increase tumor immune infiltration is there in this subgroup of patients where both the immunotherapy will work. And this is that again showing the same. So replication repair deficiency subgroup of patients. Now who are these patients? Again, over years we have done multiple studies and then found out that patients with high-grade gliomas. Now first of all, in pediatric high-grade gliomas are not that common. So it's a small subset of patients, and even that, but if you see in high-grade gliomas, 82% of the patients can have this RDD defect. So that is one group of patients. Medulloblastoma, some of these patients, so especially the group 3 patients. So you can see that if we select the patients, then in that subset of patients, this will work well. And this is just to show patients with high-grade glioblastomas. You can see here, those who progress on after the standard chemoirradiation treatment, when you used to treat them further post-relapse, most of them will die. But now the same patients, when they were treated with the immune checkpoint inhibitors, you can see here, nearly 40% of them are alive at a significant, nearly 3-4 years down the line, which was not seen in the past. So there's definitely subgroup of patients where it will help. And the next one is basically where they used it upfront. So in glioblastoma multiforme, those who had basically the RDD, like this thing, if you see low immune and genomic this profile, they will see that it doesn't work. But those who have a high immune and genomic profile, you see nearly 75-80% of them are doing well. So you have to select the patients that it may work, and that it will be important the way and improve the outcomes in that group of patients where the outcome as of now is very poor. So the other thing that is going on, again, CAR T cell in hematological malignancies, even in brain tumors, we are using now CAR T cell therapies, which is not only in hematological, we give only peripheral infusion, but here the CAR T cells are given peripheral, intraventricular, and even in the intratumor cavity. And you can see here now the anti-GD2, again GD2 is expressed in, especially in high-risk gliomas. You can see anti-GD CAR T cells are already being used. And you can see here that when you are given, especially this is diffuse midline gliomas, and basically where there was no effective treatment, you can see it has really helped us. So sequential intravenous followed by cerebroventricular GD2 CAR T cells induces response and benefit both in diffuse intrapontine gliomas as well as the diffuse midline gliomas, where there was no effective treatment as of now. Still, this is basically this is in evolution. We still don't have really it has not become standard of care, but it will become in the near future. So again, still like I told you, the standard therapy is surgery followed by radiation plus minus chemotherapy. That is still the mainstay of treatment. But most pediatric CNS tumor, like I told you, have low mutational burden, so they are immunologically cold. But if you find out a subgroup of them which have, like the RRD gliomas, which exhibit remarkable response to the immune checkpoint inhibitors, then in selected group of patients, this treatment would work very well. And then next is the last is the neuroblastoma. Again, neuroblastoma is a group of tumors where the outcomes are really, in high-grade neuroblastomas, outcomes are poor. And you can see the standard of care already is maintenance with the monoclonal antibody, the anti-GD2 antibody, but we are improving further. So you can see here in the neuroblastoma, we start with induction chemotherapy, then we do the surgery, follow it with the high dose, that is the autologous stem cell transplant. If required, give radiation after that, and then give maintenance therapy. Initially was isoretinoin based, but now we use the anti-GD2 antibody along with isoretinoin. That has become standard of care. This is anti-GD2 antibody. Basically, it's a tumor-associated antigen. So GD2 is expressed very highly by neuroblastoma cell lines. So we use an antibody against that. It's both are available. The chimeric human murine anti-GD2, which is a CH14.18, which is commercially available, and this is a murine 3F8, which is produced by or developed by the Memorial Sloan Kettering group, which again is in use in certain experimental areas. But very importantly, it is used in many patients with neuroblastoma as consolidation already. But you can see that basically this has become standard of care. So after induction and consolidation, you either give maintenance with retinoin or with anti-GD2 plus retinoin, and then you can see that. So you can see that the outcome with immunotherapy is much better than with the standard therapy. So this was already there. So immunotherapy has significantly improved the outcomes. So again now, so we have gone ahead of that. We were using it as maintenance, but now we are using this antibody even as induction. So either MIBG alone or MIBG with the antibody dinutuximab, which is the antibody, or we are using it after in induction as well as post completion of therapy. Both we are using this, and this has helped. So it has, you can see it has improved the outcome even further here. So if you use it upfront, the outcome is better than if you use the antibody post completion of treatment. And this is our data from Tata Hospital, where we have also started using. This is a very, very expensive treatment. So really we have very few patients there, but where we have used it judiciously, it has really improved the outcome in that group of patients, subgroup of patients. It's useful if you have large solid tumor masses, it doesn't work. But if you have bone marrow involvement and all, it will work better. So along with that, we are we are also getting the CAR T cell therapies, which are now in use even in neuroblastoma. The same anti-GD2 CAR, which was used in brain tumors, is also being used in neuroblastomas. So already there's multiple data available now, but still again, this is also under evolution. So this is work in progress, and it may take some years before it becomes standard of care. And one of the reasons why this is important, because the CAR T cells are there, but unless they go to the tumor, they home in the tumor, it will not work. And I'll tell you why it is not working and how it will help. Okay. So this is, so up till now when we talked about immunotherapy, I already told you about CAR T cells, monoclonal antibodies, transplants. So all this is positive immunity. That means it is immunostimulatory immunity. So it will help to build up the immunity of the body and basically try to kill the cell. But very, very importantly in the body, there is the other type of immunity which nobody talks, and that is the immunosuppressive immunity. That means there are cells in the body like your T regulatory cells, your myeloid-derived stem cells, macrophages. All these cells are negative of the suppressive immunity. So unless you remove this suppressive immunity, the positive immunity doesn't work. And that is why in tumors where it is more important, when we have microenvironment which is full of this suppressor immunity, the stimulatory immunity doesn't work. And that is why if you see in most solid tumors, you get 10, 15%, 20% response rate with this. So can we improve this response rate? And this is what it is. So basically you have a Lamborghini, which is a very, very expensive car, as you know. Same way as your CAR T cell, your immunotherapies, which are very expensive, but if they are, make them drive on the road which is full of potholes, they get stuck and they don't go forward. And this is a Lamborghini in one of the Kerala, actually a state in India, where this was really stuck in a in a pothole there. So it didn't move and it had to be removed physically there. So this is what it is. So if you use along with your immunotherapy, this thing, if you checkpoint inhibitors, if you use metronomic therapies. Now metronomic therapies, as we all know, is low dose therapy which give us continuously, and it takes care of most of your suppressive immunity, that is your T regulatory cells, myeloid derived stem cells, macrophages. So if you use this together, then it will work, the checkpoint inhibitors will work better. And then if you see here, basically if you use just the standard therapy, you are somewhere here. If you use the standard therapy with checkpoint inhibitors, you are somewhere here. But if you use that along with your metronomic therapies, or you combine both this thing, then you can achieve much better outcome. And that is where we hope of. This is one of our papers where we had used low dose basically immunotherapy, that even less than the previous, so 20 milligram in adults, along with the metronomic therapy. We have oral triple metronomic therapy. When we use that, you can see the outcomes were much better. So this already we have shown that it may work, and we are trying to do multiple trials now using this strategy. Next one. And then once you do that, if you smoothen the road, then you use your Ferrari or Lamborghini, it will run very well. So this is what we hope to do in the future, that combine the metronomic therapies with the immunotherapy, the checkpoint inhibitors and CAR T cells, and see if we can improve the outcome. So this is basically to conclude. So we did a survey with all the pediatric oncologists in the country to find out what they think about immunotherapy. And this is what we found out, that first is, as we all know, use of immunotherapy is very limited in pediatric for various reasons. Still it is not standard of care. It is very costly, so limiting factor was cost and availability. Many of the drugs are not even available in India. And very importantly, actually, the remarkable interest regarding IT among oncologists. So there is interest, but it's still not. And basically, first we have to make the generic available, then we'll be using more of this drug. It will become more cost effective, facilitate access to various programs, cost cutting is important, so we are doing various ways to do that. Locally relevant research is important, like I told you, low dose immunotherapy, combining it with metronomic therapies, modifying the tumor environment. So if we do all this, maybe we may improve the outcomes even in pediatric cancers. Last one. So basically this is our pediatric oncology team at Tata, and I think this is just the beginning. There's a lot of work to be done, but in the next few years, I think in one of the next program, it may find to be very, this may become frontline therapy in pediatric cancers also. Thank you very much.
Thank you so much for the insightful presentation. So, any questions for now? Do we have any questions? It was really insightful, so I expect questions.
Thank you for the nice presentations, and you gave us a lot of information that can be seen in the near future. So my question is, how was the cost of treatment? The Blina, tumab, and the CAR-T, which one is expensive on the cost?
Yeah, at present we have to import blinatumomab, it's not available. We have a patient assistance program through St. Jude's, actually, through which we get free Blina. For us, Blina is more cost effective because it is free. So we are using that. CAR-T, we have produced the CAR-T, which is 1/4 or 1/5 or 1/8 the cost of what is available in the US. So for that also for us is cheaper, much cheaper, but compared to Blina, this is more costly because we have to buy still that, and whereas Blina is totally free for us. But in the long run, Blina, the CAR-T will be basically, see the problem with CAR-T is it is a patient specific. That means you have to remove the cell, send it somewhere, expand them, this thing, then it becomes more impractical to do. Whereas Blina, once it comes in the generic form or something, cost comes down, it will be more easy to use. So in the long run, Blina will be used more. CAR T, we will keep it for patients who really have MRD high or more high-risk disease at the end of initial treatment. There we'll be using. CAR T may not become the standard of care upfront, whereas Blina and inotuzumab will become standard of care in the next few years upfront in ALL treatment.
Thank you.
At this moment, it gives me a pleasure to introduce our next speaker. Our next speaker is Professor Honorable Dr. Bamon, who's a professor and head of Department of Gyn Onco at B. Barao Cancer Institute, which is a constituent unit of Tata Memorial Center over there in Mumbai, India. And he'll be discussing the topic, role of surgery in the management of advanced ovarian cancer. Welcome, Professor.
Thank you. Good morning, everyone. At the outset, I would like to thank Merck Foundation for giving us this opportunity today. And thank you, Banwali sir, for the wonderful talk. Such a difficult topic, and you had made it such a lucid presentation. So, as you know, I'll be talking on role of surgery in the management of advanced ovarian cancer. So, okay. So, you see ovary, majority of the cases, even in the Western countries, are detected at a fairly advanced stage. It's only 25% of the patients will be detected in the early stage with a good survival. And most of these early patients, they go to the medicine specialist or the gastroenterologist with some vague symptoms, and when they are detected. But when we get these patients in the OPD, mostly they are in the advanced stage, and they are very difficult to treat. So let us discuss how we treat this sort of patients. So as of now, surgery remains the mainstay of treatment for advanced ovarian cancer or ovarian cancer. So now, let's go back to the history. You see, the first ovariotomy was done by McDowell in the year 1809, and this was the patient, and her name was Todd Crawford. So this was the first how it all began. Then Meg was a gynecological surgeon at the Massachusetts General Hospital, and he was the person who described the term debulking surgery for the advanced ovarian cancer. So this is the term it was described by Meg, and it was Griffith who has given us the concept of the completion of the surgery, how complete you have done your surgery. It is said that the amount of residual tumor left at the end of the surgery determines our survival. The lesser is the tumor left behind at the end of the surgery, the higher is the survival. This concept was given by Griffith. So now, what are the key developments? So I'll be speaking on the radical surgeries, how it has evolved. Then the concept of interval debulking surgery means you give an NSCT followed by the surgery. And then I'll be speaking on what is the role of lymphadenectomy at this point of time in this group of patients in the advanced ovarian tumor, and then the role of HIPEC which has come in, and secondary cytoreduction and MIS in C ovary. Okay, so now, as of now, we know that surgery is the gold standard. Quality of the surgery we know now. The better is the better is the surgical quality, the higher is the survival. Now the timing of the surgery. So since we are talking on advanced ovarian cancer, so you need to know whether you go in at the first setting or you want to give her chemotherapy and then reduce the burden of the tumor and then operate on her. So now this is the real enigma. So now let us see how we decide. So we should always remember that in advanced ovarian cancer, surgery is not for everyone. It is not for everyone because we need to see the patient about her general condition, what is her albumin level, what is the extent of the disease she has, not by everyone. It should not be opened by everyone. He or she should be expert in that field. He or she should have very good knowledge of the upper abdominal surgical expertise, because that is very important in ovarian cancer surgery. And if you don't have that expertise, but if you have it in the hospital, then also it is okay. You have to discuss in the tumor board beforehand. These are the things I'm expecting when I open up. So this is the thing which you need to do. So these things you should be clear before you put your knife. Then not to be done everywhere. Sometimes this surgery may run at 8 to 10 hour surgery, and then you should have a very good ICU backup to start this surgery. Okay, so now these are some of the risk factors you should look at, that what is the age of the patient, the frailty of the patient, if there is any multiple chronic conditions he has. The albumin status is very important, ascites sometimes, and BMI index, stage of the patient, and of course performance status. So this is also important. You should also examine assess the patient, how is their resiliency to recover. Sometimes you do a long surgery and then you end up with a long morbidity, and ultimately you cannot start chemotherapy for this group of patients, and then ultimately the recovery is not good, and ultimately the survival suffers. So now, when do you suspect it's advanced disease, So first is clinically you see her, and then we have two things which you can look at. The radiology helps us, and also sometimes you can put in the laparoscope and see what is the extent of the disease. So now there are some scoring patterns which has come, the Nelson criteria, the Bristow criteria, and if you see what they look at, that's basically, you see, extensive upper abdominal disease that you should see in the imaging, whether there is any diffuse peritoneal carcinomatosis, there is encasement of the celiac trunk or hepatic hilum, liver parenchymal metastasis, or you can see a diffuse small bowel serosal involvement, or if there is a tumor infiltration of the mesenteric root, or if there is extensive gastric or bowel infiltration, or a bulky paraortic node above the renal hilum, and sometimes the thoracic. These are the things you should look in the ear, and if you see these are the things which you get in the ear, then your chances of achieving a RGO resection is very less. In those patients, you are more biased towards giving chemotherapy, and then look at it after 3 to 4 cycles. So now next, so this is the next way, from the imaging you see these things, and in the laparoscope, if you do, Anna Fagotti has done a lot of studies on this, and she has developed this modified Fagotti score, where the 4 things they look at. You put the scope and you see if there is a stomach serosal involvement, if there is diaphragmatic carcinomatosis, or if there is a mesenteric retraction or liver capsular metastasis. For each thing she gives 2 points, and if your score is more than 4, then these are the patients where chances of achieving RGO resection is very less. So in these patients, you have to go for NSCT followed by irreversible debulking surgery. So now these are the things you put there. These are the whole abdomen. You start from the upper abdomen, see the diaphragm, see the stomach, see all the area which I have told. You check everything and give a score, and then you decide. So this is another way how you can decide. Okay. Now next, if you are planning to go ahead with the surgery, so incision, very important. Always, when you are trying to open an advanced ovarian cancer, the incision should be always longitudinal incision, and it should extend beyond the ideal incision is up to the Jiffy sternum. Okay, that is the incision you should start. Once you open, then again you recheck whether it is really operable. So you look for these things specifically, the diffuse deep infiltration of the small bowel mesentery, diffuse bowel involvement of the small bowel requiring multiple bowel resection. Then this is the patient you should not operate. If you feel that she requires multiple bowel resection. Involvement of the porta hepatis, again, you cannot go ahead. And multiple liver metastasis, diffuse dense involvement of the stomach, duodenum, or pancreas. So these are the things which you should look at and you should decide on the table. So basically, you have some guidelines by ASCO criteria or the trust criteria. All of them revolves around these findings. So basically, if you see these things on opening, then you have to decide, take a call, whether you close it down or you go ahead with the surgery. And these are the things how you can look at the infiltration of the root of the mesentery or ileocecal involvement, multiple bowel involvement. So these are things you look at. This is how, again, you have to do a good bowel run and check each and every nook and corner of the intestinal to see where the diseases are and whether it can be resectable or not. So now, what are the things that you can do? Well, you can see you can do a bowel resection if needed. You do it. Splenectomy is achievable. Partial gastrectomy can be done. Diaphragmatic resection can be done. Indeed, it's a solitary liver lesion that also can be done, or a lobar excision of the liver that it can done, and sometimes the exenteration, it may require a anterior exenteration, posterior exenteration, total exenteration, whatever it is, or modified radical exenterations that can be achieved. So these are things you can do it. So these are various things that you can do: peritonectomy, intestinal resection, using a stapler, resection, by diaphragmatic resection, pelvic lymphadenectomy, paraortic lymphadenectomy, and also now the role of VATS. The video assisted thoracoscopy has come in. You send it, you can, if you are suspecting some disease in the thoracic ear, then you can put the thoracoscope and then see if there is small resectable disease, that also can be taken out of the same sitting. So this is very important. And sometimes you see, this is a study which we did. We got patients with pleural effusion. We did a cytology for the pleural fluid, but it was negative. 3 times we did, all time it is coming out to be negative. And we compared this group of patients, pleural effusion, cytology negative, and other group where there is no effusion. Stage-wise they are same, but this group of patients, they did not do good. They are not, the survival was less in comparison to the other group of patients where pleural effusion was not there. So it again brings out that whenever there is pleural effusion, even if the cytology comes out to be negative, I think it's better to go in a thoracoscope and see for yourself whether you are really, there is some disease which are missing. And this is how it looks like after you give chemotherapy. Sometimes this bowel, the metastasis, small it resolves like this. There is fibrotic type of things. So now the timing, again coming back to our timing of the surgery, whether do a primary debulking surgery or the interval debulking surgery, what is the evidence? So as of now, we had 4 randomized controlled trials, the URTC trial, the CORAS trial, Scorpion trial, and the JCOG trial. Out of these, except the Scorpion trial, which is a superiority trial, all the other 3 trials were inferiority trials. So these are the trials, and if you see, there was no difference between the median OS and PFS. There is no difference between all these 4 trials, whether you are doing a primary debulking surgery or interval debulking surgery. But there are some criticism about this trial. They showed that the number of chemotherapy cycles are not uniform. The patient selection was not, sometimes it was biased. And they also pointed out regarding the quality of the surgery, as they showed both the studies, in all those trials, it has shown that the R0 resection was around 19% and 17%. So, taking all care of all these things, they have designed another trial, that is the TRUST trial, where all these things were taken care of. And the TRUST trial results has come just now, just last month. It was published in the ASCO, where they have shown that if you are doing a primary debulking surgery versus the interval debulking surgery, the median OS, there was no benefit. They could not achieve but then in PFS, median PFS, there was some advantage if you are doing a primary debulking surgery, but provided your primary surgery is absolutely R0 resection. That is most important thing. So this is another study which we had done in our institute way back in 2014, where we have shown that PDS and OS, we had no difference if you are doing a primary debulking surgery versus the interval debulking surgery. We also did not find any difference. So this is another study which we did, which we wanted to find out what are the clinical pathological factors affecting the survival in women whom we have given NSCT, and we have seen that the predictors include absence of ascites. Suppose the patient had ascites and we have started with chemotherapy, there was an absence of ascites before the surgery, and there is R0 type of resection if you could achieve, and maximum tumor burden in the ovary or colon. Post-treatment mean CA-125 less than 33. These are the patients where we did very good. So these are another thing which we found out that in our group of patients, what happens if you give NSCT? We saw that in our group of patients, when you give NSCT, around 43.6% of the patient had complete remission of the disease with no evidence of disease on histopathological examination at the end of the surgery. So this is what we got in our group of patients. You also can try in your set of patients how your patients responds to the chemotherapy regime. Okay, so now any guidelines? We do have a guideline by the SGO and ASCO where they have shown that if we get a fit patient with potentially resectable disease, either NSCT or primary surgery may be offered. If it is a high likelihood of resectable disease with acceptable morbidity, you go ahead with primary reconstructive surgery. If it is a fit patient but deemed unlikely to achieve optimal resection based on your CT imaging or laparoscopic finding, then you can go for NSCT followed by debulking, interval debulking surgery. So now about the lymphadenectomy, what is the current status? They have said that we have got 2 trials. One is the LION trial, where they have done after primary debulking surgery, one group of patients they have done complete lymphadenectomy, other group of patients they have done only bulky nodes they have removed. If there is nodes are not palpable, they didn't do lymphadenectomy. And the mean OS and PFS was same in both the group of patients. So we know that in the primary debulking surgery, if we do not have any bulky nodes, it is good enough to leave the lymph node behind in the normal In this group of patients, LION trial, they got 53% of the nodes that are microscopically metastatic positive, but survival-wise, there was no difference. So, at the same time, the side effects or the morbidity was more in those group of patients where they had systemic lymph node. So, they say that in primary debulking surgery, lymph node can be left in there. And what happened to the interval debulking surgery group? Again, another trial came, Karoka trial, where they also found that even in the interval setting, when you are after given chemotherapy, you have opened the patient, you are imaging also you have done before the surgery, there was no enlarged nodes, and even after opening, you could not feel any palpable nodes. Leave behind the ovary, no problem, because the survival-wise, it was same. We also did this was the study in the Lion trial, where they have shown the median OS was 65.5 months in the lymphadenectomy group versus 69.2 months in the low lymphadenectomy group. As you can see, there was no difference between the two groups. We also did a study, basically in 2019, that time. We did it in the interval debulking setting, and we saw the same thing. There was no difference between the OS and PFS between both the groups in the interval debulking surgery, which was confirmed now by the Korako trial, which has shown the same thing. So now another thing which has come is the HIPEC. What is this? Basically, we introduce chemotherapy after the end of surgery. You have done a primary debulking surgery or interval debulking surgery, R0 resection, no visible disease at the end of the surgery. Only when you can give you can start this procedure. It is we give intraperitoneal heated chemotherapy. Mostly cisplatin is given, and the temperature is around 39 to 42 degrees centigrade. And we keep it for 60 to 90 minutes. It is a machine, HIPEC machine. We give it there, and then we see. After that, we give chemotherapy. After the procedure, the normal chemotherapy the patient receives. So, what is the guideline? NCCN has given a guideline that HIPEC can, with cisplatin 100 milligram per meter square, can be considered at the time of IDS, as of now, not with the PDS setting. In the interval debulking surgery, HIPEC can be given for stage 3 disease. Sodium thiosulfide may be administered at the start of perfusion. It protects the renal protection, because we know that in HIPEC there is a renal toxicity. So this can be given. So now there are 3 techniques for HIPEC. One is the closed technique, open technique, and semi-open technique. Basically, what we do is that we perform the surgery, and after the end of the surgery, you just give the heated chemotherapy, and then you wait for 60 to 90 minutes, and then wash it, and then close the abdomen. The other group is the closed technique. You close once you give insert the chemotherapy, and then you close the abdomen and wait for the time, 60 to 90 minutes, and then come on. Other one is the semi-closed, semi-open. So they said that if in the open technique, there is some fumes and all those exposures, so people have stopped doing that. Closed technique, again, you don't know where the chemotherapy is going. It may be stuck in one compartment of the abdomen, so that then there people have stopped, means avoid nowadays. The semi-open, you just put a cellophane paper over the and then make a small hole, and through that hole you can see whether the fluid is going to all the compartments. So that is a good technique to do. So that we are also following that technique. So basically, it has what is the procedure? Basically, you as usual, you look for the feasibility of the surgery. Once you have seen that okay, this patient is okay for surgery, you do the surgery. You achieve a R0 resection or CC0 or CC1 maximum, and then you can do your cytoreductive surgery. Once you have achieved your R0 resection, then you start the HIPEC. The HIPEC you do, and then once you finish it, and then you close, and then the same process starts. Okay, so we do have a HIPEC exposure in our institute also. We have been doing for the last 1.5 years, and we'll be presenting publishing our paper soon. So we have done approximately 20 cases as of now. So we are mostly doing the semi-open technique. So basically, once we do the surgery, and then we cover it with the cellophane, and then a small hole, and we try to see. This is how we are doing it. So what is the guideline? They say that for PDS, it is not recommended as of now, because trials have proven it is still in the clinical trial phase. For in the IDS setting, it has become a standard of care. You can do, provided you achieve a R0 resection. And for the secondary cytoreductive surgery, in the recurrent setting, if you are doing a surgery, whether the HIPEC has any role or not, as of now, it may be an option, but is not a standard of care. So now, again, suppose you don't have a HIPEC, whether you can put intraperitoneal normothermic chemotherapy. That is one thing which we were doing when we hadn't had that HIPEC machine with us. So now we did this feasibility study with 20 patients, and we saw that it also works. Suppose in our group of patients, suppose you have done a very good surgery and you put normothermic intraperitoneal chemotherapy, and then, so this way we are doing a RCT on this currently. We are recruiting patients for RCT just with the normothermic chemotherapy. Then just one slide on PIPEC. It is another new thing which has come, pressurized intraperitoneal chemotherapy. Basically, it is done in the recurrent setting. It can be done every month for 2 to 3, 4 settings maximum. And only in the, but provided you have a peritoneal carcinomatosis, this sort of recurrence, where the disease burden is very less, the small nodule, there it works. It works for some time. So basically cisplatin is used with a high pressure injector here. So what is the last part of my talk? What is the role of the surgery in the recurrent setting? So what we tell as a secondary cytoreactive surgery. So, so what are the patients you look at? So first thing is that at the first surgery should have a R0 resection. These are the patients you qualify for secondary cytoreactive surgery. There should be a platinum sensitive, it should be platinum sensitive, means there should be a gap of at least 6 months from the last cycle of chemotherapy. The patient should have a good PFS, and you should be sure that you take out all the macroscopic disease that is there once you go in there, and optimal CRS at first. So these are the few things which you look at. Once these are fulfilled, then you go ahead in this group of patients, in the recurrent setting, you go ahead with the surgery. And there are 3 trials, desktop 3 trial, GOG 0213 and SOC1. So they have taken this basically platinum sensitive recurrent tumor, AGO score positive, the things which I have told. Once they fulfill these criteria, go ahead with the cytoreactive surgery plus chemotherapy, other group only chemotherapy. So these are the trials they have done. But unfortunately, current evidence shows improved progression-free survival only, but mixed results for overall survival. And all these 3 trials have shown. Median progression-free survival is improved in patients undergoing surgery, 19.6 months versus 14 months. Complete gross resection is associated with better overall survival, 56 months versus 37.8 months. And overall survival benefit is not consistently observed across these studies. Desktop 3 trial showed improved progression-free survival, as I have told. So this is what the results. Now, whether HIPEC can be added in this group of patients. You have done a complete cytoreactive surgery at the recurrent setting, and that setting whether HIPEC can be added. So we have 2 trials, either the CHIPO trial and the MITO-18 trial, but the results are conflicting as of now. So it has not become a standard of care. Now, last part, MIS in advanced ovarian cancer. It has got a limited role. One role is that where you have got advanced cancer. Now I told you, you can put in the laparoscope and see the access to the operability, see for the operability. Again, sometimes you can take a biopsy, see for the disease, and you see it is not operable, and let me take a biopsy so that patient can be put for chemotherapy, NSCT. And sometimes in IDS setting, people have tried doing MIS surgery. So these are the initial studies where they have shown that MIS is not associated with higher mortality than laparotomy after NSCT. In good well-chosen cases, you can try chemotherapy. Patient has got very good response after NSCT, and in imaging you can see there is no evidence of any disease. Those patients you can definitely go in and try MIS surgery if you are expert in the field. Again, minimally, this study, the international mission study, where they have shown that minimally invasive surgery was associated with 96% rate of R0 resection at interval surgery, which is quite comparable with the laparotomy group. The rate of intraoperative complication when performing minimally invasive surgery was 44.7%, and minimally invasive interval surgery may be considered in the setting of complete or partial response after neoadjuvant chemotherapy. And this is another trial, the LENS randomized clinical trial, where they have concluded that results of this lead-in pilot study indicated the feasibility of LENS RCT to compare the oncological safety of MIS versus laparotomy. So the RCT is going on now. So now, if you see MIS in IDS shows similar overall survival rates compared to laparotomy in well-chosen cases. MIS is associated with lower 30 or 90-day postoperative mortality, and patients undergoing MIS have shorter hospital stays and lower residual disease rates. MIS results in few additional cytoreactive procedures compared to laparotomy. A proper patient selection, that is the most important thing in if you are planning a MIS in interval debulking surgery. So basically, if you conclude, quality of the surgery is the most important predictor for survival in ovarian cancer. Surgeon should be well trained, experienced and skilled to decide which patients I will go for surgery, which patient not. Timing of the surgery does not alter the prognosis as of now, which the trials have shown that. Routine lymphadenectomy not non-palpable, so you may avoid in advanced ovarian cancer. Limited role of MIS in advanced ovarian cancer as of now. With that, I would like to conclude. Thank you so much.
Thank you so much, Professor Berman.
So one of the questions is, how should BRCA status and homologous recombination deficiency influence the decision to pursue aggressive surgery upfront?
Okay, so we know now the BRCA and the HRD status is a very important thing. Nowadays it is recommended that even all in high-grade cancer we should do BRCA and ER because we know the PARP inhibitors has come. But as far as surgery is concerned, there was a study where they have shown that in BRCA positive patients, HIPEC works better. In those patients, you should take the opportunity of doing a HIPEC surgery because there are studies which have shown that if in BRCA positive patient, if you are adding HIPEC along with the surgery, this patient has a very good survival which is statistically significant. So that is one study which I am aware of as of now. Madam, if you can.
So presently, we don't know how much is the additional benefit of HIPEC when we are using PARP. So currently, of course, if a patient is HRD positive or BRCA positive, we would put them on maintenance PARP inhibitors. And in addition, of course, if we achieve a CC0 in advanced ovarian cancer, we would do HIPEC. But if we were to separate the two and figure out, in addition to PARP, how much HIPEC is benefiting, that answer we don't know currently. Maybe I think the retrospective audit of our ongoing RCT may give us that answer, but as of now, we don't have that answer.
Yeah. There was one, I think, one case series where they have shown that in BRCA positive cases, if you are doing HIPEC, they got some advantage. Otherwise, there is no other as of now.
Yes, and that is very likely because BRCA positive are the ones who are likely to benefit from cisplatin. Yes, because of
that is the only explanation.
Yes, I'm Othniel Musana, a gynecologist in Uganda.
Okay.
What has been your experience in using a diagnostic laparoscopy for assessing resectability after neoadjuvant chemotherapy?
Yeah, so nowadays, if it is, whenever first option is our imaging, and if you have doubt in the imaging, definitely we put the case for OT, we put the laparoscope, and we try to see. And almost in 30 to 35% of the patient, 1/3 of the patient, we do that. As a routine procedure in our OT, put the laparoscope and see at the final year, and then we go ahead.
Because one of the challenges, I think, in the low-income countries is that many of our radiologists are not adept at reading the CT scans and other things. So in a center like ours where we have the laparoscopy,
that is a very good.
I think that then becomes possible an option to see.
Yeah.
Okay.
Yes.
I just wanted to mention, because you said that it is sometimes difficult to see on the CT scan, and the radiologists may have challenges, and one of the things that we have learned is through the multidisciplinary clinics, because when the radiologist and the pathologist are there with us in the clinic, and sometimes what we see and then we discuss that back again, that has really helped us learn the radiology and the radiologist interpret better. So if you at least one day a week have that MDT, that would be helpful, I think.
Thank you very much for that very enlightening session. My name is Gloria, an oncology fellow. I wanted to ask about the patients who have a recurrence, and the recurrence looks resectable, but unfortunately, it's probably in the time you're doing your adjuvant treatment. You mentioned that for re-resectability, you need to consider that the patient needs to be platinum sensitive.
Yeah.
Please expound more, because we're usually tempted to push the surgeon, just go and remove this part that's not responding. Really, what do you consider? And what do you recommend further?
So basically, suppose you have completed her chemotherapy cycles, 6 or 8 cycles, whatever was planned, okay? And then now your patient is on follow-up. So if the 2 follow-up, 3 monthly follow-up is okay, patient is there is no evidence of disease, then these are the patients where you can go ahead, and then after that you detect a recurrence, oligometastatic disease, resectable disease, there we go ahead, we are more biased towards doing a secondary circulative surgery followed by chemotherapy. If the disease comes within 6 months, in those group of patients, we go ahead with the second line chemotherapy. There we don't operate generally. So this is what the platinum free year of 6 months. This is what they try to tell. You have completed the treatment. Okay?
Yes.
So now patient, you are calling them for follow-up every 3 monthly, 2 to 3 months. Ideally, we call them every 3 months. So first 3 months, you check on her. There is no complaint. The CA125 level report was previously raised. Now it is normal. It's running normal. And there is no other indication for doing imaging. Clinically also, she is nice. Again, after 3 months, she comes. She's good. And in the third checkup, she comes with a disease. Then this patient fits into our secondary saturative surgery inclusion criteria. Apart from that, the other things are also there. But this is one of the, by the term what you told, the platinum sensitive of 6 months. So anything more than 6 months, we say it is sensitive. If it is less than 6 months, the disease comes back, we no longer tell it as sensitive. Then it is refractory or, no? That is what, yeah.
Sorry, Prof, let me just squeeze in a quick one in 2 minutes. In low resource settings with limited access to HIPEC or targeted therapies, can maximal cytoreduction surgery compensate and improve survival? In other words, can cytoreductive surgery be considered adequate in the low resource setting?
Yeah, that has been, we are all doing that only. HIPEC has come new. Even in a center, many centers in our country also do not have HIPEC currently. So the most important thing in managing an advanced ovarian cancer patient is how good you are doing your surgery. HIPEC won't help you if you are not doing an R0 resection. HIPEC is not going to help you. It is an added armamentarium. Basic thing is that how good, what you have left behind at the end of the surgery. If you are not leaving behind a single evidence of any disease anywhere in the abdomen, that patient will definitely do better than the other group of patients where you have left behind surgery, even if you give HIPEC in that group of patients. So the best and the most important thing is the quality of your surgery. That is the most important thing.
Thank you, Prof. So we'd like to welcome our next speaker, who is Professor Devayani, who is a thoracic surgical oncologist at the Tata Memorial Center. We are honored to be with her today to share her expertise and perspective in the field of thoracic surgical oncology. She will be discussing the topic pulmonary resection for lung cancer, surgical approaches and techniques, thoracic surgery. So over to you, Prof.
Thank you. Thank you for the kind introduction, and thank you for having me here. It is indeed a privilege. What we'll be looking at a broad overview about surgery in lung cancer, and we will cover the indications, the approaches, and a little bit about the techniques that we use. So this is the lung cancer spectrum, and this is a very sobering statistic that we need to look at whenever we think of lung cancer, because as the stage increases, the survival precipitously drops. So essentially, when we talk about curing lung cancer, we are looking only at stage 1, 2, and some stage 3 disease. And like you can see in the pie chart over there, it's only a total of 20%, that is only 1 in 5 patients that we see will actually be amenable to curative intent therapy, which is something that we need to keep in mind. So if we put this in perspective, this is the data at our hospital at the Tata Memorial. The number of lung cancer patients that we see per year is actually 2,200, which is a huge number. But how many come up on our operating table? It's only 120. That is 5.4%. So as surgeons, we need to look for opportunity in every case that we see, and only if we do that do we come to 120 cases. So that's something that we need to keep in mind if we are surgeons dealing with lung cancer. So we stage them pretty aggressively. We use a PET-CT, we use an MRI brain, and we use invasive mediastinal staging, which is either an EBUS, which is bronchoscopy guided, or a mediastinoscopy. The reason why we add this additional procedure in lung cancer as opposed to other cancers is because of the graph that we saw in the first slide. The minute lung cancer becomes node positive, more importantly N2, that is your mediastinal node positive, the survival drops to half. So it is extremely important to identify these patients and thereby improve their systemic therapy components. Preparation is extremely important when you take up a patient for lung cancer surgery. Most of our patients are old, they are smokers, they don't have good lungs to begin with. So if we have to give good outcomes with surgery, we need to optimize them well. These are the tests that we do: pulmonary function tests, a 2D echo. A very low resource test but extremely useful is the 6-minute walk test, where we simply ask our patient to walk for 6 minutes at a high speed, and we see the distance that he or she has covered, and if there was any drop in saturation during this test. It gives us an eyeballing of whether this patient is fit for lung surgery or not. We optimize their comorbid conditions like diabetes or hypertension, and prehabilitation, which we will again talk about at the end of the day today, is something that we make all of our patients go through to make them fit for surgery. And although the surgeon is the person performing the surgery, a successful lung cancer surgery is not possible without a team. And this is the component of the MDT that each and every patient undergoes before they come up on the operating table. So lung resection is of 4 types. It could be a wedge resection, which is non-anatomical. It does not follow anatomical principles. It could be a segmentectomy. It could be a lobectomy, or it could be a pneumonectomy. And over the next few slides, we will see what the evidence favors. So this was the trial, the landmark Ginsberg paper that came out in 1995, which showed that even if your tumor is small in size, that is, even if they're T1 tumors, lobectomy was still the gold standard because it was the surgery that gave maximum local control and decreased recurrences. Anything less than a lobectomy led to 3 times the number of local recurrences and a 30% increase in overall death rate. So from 1995 till around 5 years ago, this was a no-brainer. There was no debate that lobectomy is what you need to go for, no matter how small your tumor is. But then sublobar resection started being explored more and more. And the reason for that is we had better imaging. We had 64 slide CT scanners in almost all the centers, which showed up smaller tumors as well. Ground glass opacities became defined, and people started seeing more and more, especially when COVID came in. And then we had the screening trials like the NLST and the Nelson, which again picked up these tumors in extremely small sizes. And then the question came up that if we are seeing a tumor which is 0.5 centimeter, 1 centimeter, less than 2 centimeters, why should we go and remove the entire lobe? Can we do something smaller than that? And these were the 2 trials which actually addressed this question. The first trial is the JCOC trial, and this trial deserves special mention. Like we were speaking the other day, that surgical trials are very hard to conduct because the sample size is simply too large. And here is a trial from the Japan oncology group which managed to accrue 1,200 patients, which is pretty astounding. And the second trial, which looked at sublobar resection, is Dr. Altorki's trial, the CALGB trial. And while the first trial looked only at anatomical segmentectomy, the second trial included wedge resections as well. And this is what the trials showed, that segmentectomy is absolutely safe for tumors that are peripheral, which are less than or equal to 2 centimeters in size, and which are node negative tumors. And as of today, this is the standard of care for this tumor profile. But again, if we look at the tumors that we see in India, or I would assume that you guys would see where you come from, hardly any patient fits into this category where the tumor is less than 2 centimeters, is peripheral, and is node negative. We see less than 2 or 3 patients that fit this criteria in a year. So unless India or we start a screening program, I don't see that this trial would affect the way we manage our lung cancer patients anytime soon. Doing a smaller surgery came with its own caveat. So even in the JCOC trial, and the Japanese are known for their absolute attention to detail while operating an excellent oncological surgery, but even they had twice the number of local recurrences when they did a segment. And the lung function improvement that they expected by doing a laser resection wasn't as good as they thought it would be. They expected the lung function to be better by 10%, but they actually achieved only 2 or 3%. In our setup, where follow-up is questionable, because these patients have to come for a 6-monthly CT scan. And if we can't do that for the patient, then I think it's better to stick to lobectomy even in smaller tumors. Continuing in the same gist of parenchymal preservation, we come to sleeve resections, which are also becoming increasingly popular, and their safety has been demonstrated in lung cancer surgery as well. The reason this comes up, it's mainly for central tumors involving either the bronchus or the major hilar vessels, is because pneumonectomy itself is a disease. When you remove a functioning lung of a patient, you increase the morbidity by 30% and the patient has a 6% chance of mortality. And this is just short term. If you follow up the patient over several years, they have death due to competing causes coming in because they have been living on one lung. So we try to avoid pneumonectomy as far as possible, but so long as we do not compromise oncological outcomes for this. And this is where sleeve resections come in. So if you have tumors like this, where you have the tumor blocking the right main bronchus in this case, and the tumor encasing the pulmonary artery like in this case, you can do sleeve resections, a bronchial sleeve where you cut out the involved bronchus and suture the remaining ends together, or a vascular sleeve where you do the same thing with the pulmonary artery and try and avoid a pneumonectomy while getting an R0 resection. But is it good enough? It is, because this is a meta-analysis of 12 studies, which says that the postoperative complication rate is the same, if not more, and there is no increase in locoregional recurrence. And it has a definite survival advantage, like you can see in all these studies here. In the forest plot, it shows an advantage with a sleeve resection as compared to a pneumonectomy. The next thing I would like to address is, how do you do all these resections? Do you do an open thoracotomy, which looks quite ghastly and definitely painful? What we do now is uniportal VATS wherever it is feasible. It is a 3 or 4 centimeter incision. The intercostal drain comes out through the posterior part of the incision, and our patient is up and about on day 1 of surgery. So uniportal VATS has come in. It's come since 2015, and currently in our center, when we perform minimally invasive lung surgery VATS, it is usually uniportal. It is a single incision. The main concept is no rib spreading. Because we do not use retractors on the ribs, the postoperative pain is much, much less. Another advantage over conventional minimal access surgery is all your instruments, including the camera, goes in through a single port. So it is right in the line of vision, and it completely mimics open surgery. So the learning curve is pretty short. And I have trained in uniportal VATS, and I can completely account for this. So VATS finally came up with its level 1 evidence in 2016. This is Bendixson's paper, which gave numbers to what we already knew, that VATS causes less postoperative pain and improves the physical quality of life indices for our patients. The Violet trial was a much anticipated trial from Eric Lim's group in the United Kingdom, which was a randomized controlled trial between thoracotomy and VATS. Every one of us was waiting with bated breaths, but the result was quite underwhelming, because it only showed that VATS decreased hospital stay by 1 day and postoperative pain scores on day 4, and we expected VATS to do much, much better than this when pitched against a thoracotomy. But what we see in practice is something different. So this is the incision of a patient 7 days after surgery. This is the patient walking around in the recovery room on postoperative day 0. And here he's actually playing a musical instrument 3 months later. So VATS clearly has its advantages over a thoracotomy, but when it is safe for the patient. Robotic-assisted surgery also helps because it is magnified, 3D vision, wristed instruments. The camera is controlled by the surgeon, and now with the advent of robotic staplers, even the surgeon is very, very comfortable doing these resections at the console. He doesn't have to depend on the bedside assistant too much. And this is how the ports go in, all in a single intercostal space, 4 arms, all of them docked. Now, whether we do it VATS or whether we do it robotic, MIS, like in every other subsite, has its advantages. Less pain, faster recovery, patient is up and about and discharged much quicker. Quality of life indices have been better in almost all the studies. Cost goes down in terms of hospital stay, but it might again go up in terms of consumables in countries like ours, so we need to pitch that to the patient before we take a call. And most importantly, it has shown oncological equivalence. So putting things together, for the first picture, you might want to choose a segment, you might want to go in minimally invasive. The second picture is a T2-ish tumor. You might want to do an open surgery or minimally invasive, but definitely a lobectomy, a segment will not do for this patient. And tumors like this, which probably involve the diaphragm, we might need to look at the nodal status, consider some form of neoadjuvant therapy, and then go in for surgery. When we come to nodal staging, which is very important in lung cancer, single station resectable N2, we have neoadjuvant therapy, especially if you're thinking of giving immunotherapy, and then go for surgery. Now, multi-station resectable N2 is a very exciting field today in lung cancer because till today it belonged to the radiation oncologists where CTRT was the standard of care. But with neoadjuvant immunotherapy coming in a big way, most of the trials have included multi-station resectable N2 in the surgical arm with outcomes which are much better than definitive CTRT. So this is where the surgeons today are very, very excited because we are getting more patients to operate. And unresectable N2 is definitely CTRT followed by durvalumab, and N3 again is definitive CTRT followed by durvalumab. Surgery in these cases is only in salvage settings, never as your primary plan of treatment. Surgery also comes in the oligometastatic spectrum, and it's not a small number. 15% of the lung cancer patients that we see are oligometastatic, that is, they have limited metastasis at presentation. So this is a window of opportunity that everyone needs to catch while the patient is being discussed in the MDT, because these are potentially curable patients. And after good systemic therapy, which again has improved significantly in the lung cancer space with targeted therapy, immunotherapy, and chemo, we ascertain the disease biology. After 3 or 4 cycles of systemic therapy, if we feel that our patient is doing well, they need to come up for local therapy, which might be surgery, which might be RT, but some form of local therapy is better than no local therapy. And these patients can actually have a 5-year survival of 48%, which is quite good in the lung cancer scene. Every once in a while you come across patients like this where the tumor size is quite small, but if you see the adjacent lung fields, they are quite terrible. And these patients do not make it to the operating table. In such cases, we look at SBRT or radiofrequency ablation as alternate treatments, which in this stage is almost equivalent to surgery. So it's not that we are giving our patients inferior treatment. So to sum up my entire talk, early stage and timely surgery gives excellent outcomes. So we have the ILCAP data standing in testimony to this, where if the lung cancer patients were operated within 1 month of diagnosis, their 10-year survival was close to 90%. So these are the outcomes that we can reach with early diagnosis and early treatment. But each patient is different. It's not just the tumor, it's also the lung function, the patient's fitness that needs to be taken into account while we decide what is the best treatment for this patient. Minimally invasive surgery, parenchymal preservation, good postoperative care definitely help us to improve outcomes. And most important is, as surgeons, we all know when to operate, but it is also equally or probably more important to know when not to operate and refer the patient to our radiation oncology colleagues. Thank you very much. I'll be happy to take questions.
Thank you so much, Prof.
At this stage, it gives me immense pleasure to welcome Professor Dr. Jaya Ghosh from Tata Memorial Hospital. She's a gyne onco, and she's going to be talking to us about the management of gynecological cancers in pregnancy. A warm welcome to you, ma'am.
Yeah, thank you. And yeah, I am a medical oncologist doing gynae onco. Yeah, thank you. I would like to thank the Merck Foundation for this opportunity. So the topic given to me is management of gynecological cancers with pregnancy, and of course, it is one of the rare but difficult situations that we have to deal with when a pregnant lady comes to us and she also has malignancy. So, of course, as we all know, fortunately, the incidence is low and it is less than 3 to 4 per 100,000 women and across all these cancers. So, I would just, just to prime up, tell you about a young lady who was primary gravida, had history of infertility. At 24 weeks was diagnosed to have a 12 centimeter large ovarian mass, and then how do we go about managing this patient or diagnosing these patients? So I think the most important thing is how do we investigate these people? So these ladies, I think the first investigation that we all do is an ultrasonography, and that gives us a clue that this patient does have ovarian mass. But how to characterize these masses further? So important that if we have pregnancy and we also have an ovarian mass, to characterize that mass better, of course, this lady had a huge solid cystic mass, but if you have smaller masses, to be able to characterize them better, MR is an investigation of choice. Important to remember is that whenever we are doing an MRI in a pregnant lady, it has to be a non-contrast MRI, because the use of contrast is associated during pregnancy with increased risk of a multiple rheumatological skin and fetal toxicity basically. So it is important that we use a non-contrast MRI. Another thing is that of course CT is definitely a big no-no because of the radiation to the fetus. But a chest X-ray with abdominal shielding is something that we can safely do for evaluation of the chest. Okay, so because this was a 29-year-old lady, and we know that borderline tumors, germ cell tumors, these are the ones which are going to be our first differential diagnosis. But important also to know that a lot of these tumor markers would be raised even in pregnancy. So we need to go back and check which tumor marker, what is the week of pregnancy, and the tumor marker level, and then see that is it raised for that particular week of pregnancy. Okay, so we have our surgeons here, but then of course important is that if there is a huge mass in the second trimester which is causing obstruction, so then when to do surgery for these masses. So especially in the second trimester after 22 weeks, it is safe to do surgery for these patients. Definitely first trimester it is difficult, but in the second trimester, if you have a huge ovarian mass, going ahead with at least a limited surgery, a unilateral salpingo-oophorectomy is something that is feasible, and a complete staging may be deferred to after the patient delivers. So in the second trimester, a large mass, go for surgery, limited like a unilateral salpingo-oophorectomy, and defer the staging for surgery for subsequent things. And of course, rarely we have patients with advanced ovarian cancers with pregnancy as well. In these patients, we do a ultrasound-guided biopsy or an ascitic fluid cytology and a cell block. And then in second trimester, we can put them on neoadjuvant chemotherapy and till in the second and third trimester, and then reassess them for, post-delivery, reassess them for surgery. So, this is just a gist of what I mentioned, that if you have a large tumor, then bottom line is surgery is safe in the second trimester, and then you kind of go ahead with that. So then we come on to the role of chemotherapy. And important is that, we are all concerned about chemotherapy during pregnancy, but I'll give you the evidence that multiple studies have shown that, chemotherapy, if you're giving it in the second and the third trimester, it is safe to give these patients, but we need to be in very, very close contact with our obstetrician and, check them regularly and plan the chemotherapy in such a manner that we are able to stop chemotherapy 3 to 4 weeks prior to the expected date of delivery. So therefore, start after 14 weeks, stop before 35 weeks, but be in touch with your obstetrician to know when to stop, because if she has, say at 34, 36 weeks, is less likely to go into labor earlier, then, we will not give that cycle of chemotherapy. So for an epithelial ovarian cancer, we know that both paclitaxel and carboplatin have been proven to be safe in second trimester of pregnancy. So, and though there is some degree of placental transfer, it is thought to be safe. Cisplatinum, especially in germ cell tumors, that is what is recommended to give, but occasional patients, children post cisplatinum have had the risk of ototoxicity. So carboplatin, when you have to use chemotherapy, is the drug of choice, except of course in germ cell tumors, especially when we have a pregnant lady with this. Okay, so if you look at, what are the outcomes of these patients? So large majority, whom these are, of course, you can't have very large studies in this setup. So about 80% of them had live births and they did well. Of course, there was a higher rate of preterm deliveries in these patients. But about, even if you have a late pregnant lady with cancer, they come so distraught. So it is important that we are able to reassure her that at least 80% of those times we would be able to achieve at least a live birth for that patient. So continued, this was of course the patient who had come to us. She had gotten operated outside at a peripheral center and then did not take chemo for the fear, and then actually landed in the ICU with eclampsia and a lot gross ascites. So finally, after establishing the diagnosis, we were able to treat her because she was so sick. We had given her weekly chemotherapy with carboplatin, and eventually she delivered. And we subsequently gave her adjuvant chemotherapy and did staging surgery for her. Unfortunately, as we were discussing, she did not have access to all the other targeted therapies at that time, this was 3-4 years back, so that time there were no generics available. And she lapsed in a span of 6 to 12 months, and with second-line chemotherapy, she unfortunately succumbed to advanced ovarian cancers after 1.5 years. The child, of course, we were able to follow up the child till she died, but till that time, the child was doing fine. Of course, we could not follow the child subsequently. Similarly, if you have, even with germ cell tumors, the outcome is better, but of course, we get this few and far in between. So most common tumor associated with germ cell tumors and pregnancies are teratomas, and next, of course, in line is the dysgerminomas, which are more common. And of course, teratomas and dysgerminomas, they are better, whereas non-dysgerminomas or the yolk sac tumors, they have the worst outcomes, even with pregnancy, and especially if they have advanced yolk sac tumors. Okay, rarely we see cervical cancers with pregnancy, and of course, I don't have a personal experience with using that, but we know that on cytology, they can mimic clear cell, and that's the area stellar reaction. And if you have a very, very early stage, that kind of a tumor, then a simple trachelectomy. But if you have a locally advanced tumor and diagnose it in first trimester, that is when we have to pragmatically discuss with the patient regarding termination of pregnancy. But in second trimester, if you have a little smaller tumor, presently we know there is a role of a neoadjuvant chemo. So whether you can give neoadjuvant chemo, deliver, and then give them definitive CTRT, that is one option for these patients. And this was, of course, a meta-analysis of patients who were given neoadjuvant chemotherapy for CS cervix, advanced CS cervix in stage 2, and they were able to take into term, and 80% of them delivered with healthy neonates. And this was a survival which was fairly good. So I think if you have to, summarize chemotherapy in pregnancy, what is important is that definitely no chemotherapy in the first trimester, because that's what is involved with organogenesis. And after 14 weeks, it is safe to give chemo, but we need to know which chemo and which chemo we should not give. So as I was discussing, that we can give it after 14 weeks, but definitely stop by 35 weeks or earlier if your obstetrician feels that she's likely to deliver. And another very important thing is that we need to dose based on her actual body weight. There is always a concern that the patient has gained weight. Do I take her, pregnancy weight or not? So but we need, because the volume of distribution of drug is different, so we need to dose the patient based on her actual current body weight. And so the drugs which have been used in gynecological cancers like cisplatin, carboplatin, paclitaxel, BEP have been safe, but of course we need to be careful when using bleomycin in these patients in germ cell tumors. And importantly, supportive drugs, very little literature on use of aprepirin as antiemetic, but 5-HT3 antagonist, dexamethasone, these are all fairly safe drugs to use. And what is most important is, of course, have a close collaboration with your obstetrician. And yeah, this is what I meant, is most of the organogenesis is complete by 14 weeks, but the brain continues to develop. So, one of the major concerns when giving these chemotherapeutic drugs is, do they have late neurocognitive defects? But that has not been found, and that is very reassuring. And even though there is risk of higher preterm births, but there is no really risk of delayed neurocognitive effect. And what is the most important is that, because many obstetricians fear that, okay, I have diagnosed a lady with cancer and she's now 30 weeks pregnant, so should we just deliver her by 32, 34 weeks so that you can give the rest of the chemo later on? But I think that is the approach which should not be followed, because what is most detrimental for neurocognitive development is early or iatrogenic preterm delivery. So if you've diagnosed somebody who's at 29 or 30 weeks, it is better to give 1 or 2 cycles of chemotherapy if she's, of course, not likely to go into imminent labor, and then deliver her by 35 or 36 weeks. So, and important is that, of course, the number of cycles did not have any detriment in outcomes. So, and this was various cancer, this thing they had treated, taxanes, platinum, and of course, we're dealing with gynecological, but even for patients with breast cancer and pregnancy, anthracyclines has been safely used. So, and as I said, that this did not have any detrimental in neurocognitive function, and this has been repeatedly shown in, different studies, even when they had looked at preschool toddlers. And what about anthracyclines? So even anthracyclines can be used, and especially doxorubicin. There is a large body of data for use of doxorubicin in pregnancy, and mostly coming from breast cancer patients. Their ejection fraction was in the normal range even when they measured it for children, even though it was maybe numerically a little lower, but otherwise they continue to have good cardiac function. And as I said, that if you had to use that is of course in breast cancer, when you use doxorubicin is the preferred regimen. With respect to supportive medications during pregnancy, as I said, 5-HT3 antagonists, ondansetron or metoclopramide and steroids, they are useful. And of course, if you are suspecting premature, then of course you give steroids for the lung development as well. And GCSF should be used as needed. It has not shown any detriment in the outcome of the child. And of course, one of the most important thing to give to the patient is MDT and a good psychological support to this lady, because she is dealing with both pregnancy and cancer. So to sum it up, if you have for cervical cancers, it is paclitaxel and carboplatin weekly. Now that we know that weekly use in cervical cancer has shown improvement in PFS and OS. And for ovarian cancer, we can safely use paclitaxel and carboplatin 3 weekly. For germ cell tumors, it will be BEP or EP, bleomycin, etoposide, and cisplatinum, or only cisplatinum etoposide, depending on the patient and her lung function. Of course, what is contraindicated is any VEGF inhibitors or PARP inhibitors or any other targeted therapies. These are contraindicated during pregnancy. So another very important thing is that her planning of her delivery, and as I repeatedly mentioned, we need to stop at 3 to 4 weeks prior to the time of delivery. And we plan the delivery as per the obstetric indication. And if for any reason it is preterm, we need to give them steroids for lung maturation. Important is that just because the lady has pregnancy, she should not go in for a cesarean section. Of course, except in the case where she has a cervical cancer. But if it is an ovarian cancer which has been previously, had a surgery for, or say for a breast cancer, so the indication for a cesarean section should be her obstetric indication, not because she has a cancer that she should undergo a cesarean. Of course, if we have a cervical or a vaginal cancer, then she would need a cesarean section. And we do send the placenta for histopathological evaluation, although the incidence of placental mets is barely 1 to 2%. And of course, if she is planned for adjuvant chemotherapy, we wouldn't want to give them, we wouldn't ask them to breastfeed. That is one, hindering factor, because if the child is born preterm and we don't breastfeed, but if she needs adjuvant chemotherapy, then we cannot breastfeed the child. And after delivery, it is important that as soon as possible, we should get back to the oncological treatment, meaning that suppose she was on chemotherapy, like in this patient for advanced ovarian cancer, she delivered. Post-delivery, we need to be able to start her on the subsequent chemotherapy as early as possible, like within 1 or 2 weeks, we should be able to start a treatment. So it is important that we also follow the child for any late toxicities. Of course, most of these studies have shown that they've not had a detriment in an outcome, but there is a certain protocol that at least up to in the first year and then every 2 to 3 years, they should have at least a mental evaluation and cardiac evaluation. I think that becomes a challenging aspect where, follow-up of these patients, especially if the mother is not there, becomes difficult, but important to follow these patients up. And so I think to sum it all up, that gynecological cancers with pregnancy should be managed in a multidisciplinary team, and at least a good ultrasound and a chest X-ray with shielding is a minimum that everybody could have. And of course, if we do have the facility, then a non-contrast MRI. And timing for surgery is around, second trimester, 22 to 24 weeks. And chemotherapy after 14 weeks, and of course, stop before 35. And iatrogenic preterm delivery should be avoided. So thank you. Thank you.
Thank you so much, Ma'am Jaya. A few questions have come for you. The first one is, how does pregnancy alter the biology or progression of common gynecological cancers, and what are the implications for prognosis?
So it has been shown that, the prognosis of patients, like for the ovarian cancer, would maybe not be altered by the pregnancy itself for gynecological cancers, but and the treatment outcomes, if you're giving them similar treatment, is not very different. So a patient with ovarian cancer with pregnancy, her overall outcome would be determined by like a stage of the ovarian cancer per se. So, and of course, whether she's BRCA mutated or not. And these are not very large series, so we don't really know whether a lady with pregnancy has a more aggressive biology. Probably we don't have complete answers, but whatever data we have from retrospective is that their outcome is determined basically by their underlying disease status.
Thank you, ma'am. We know in certain sectors, when a pregnant lady is found with cancer, the only option they have is termination. So in certain areas, certain sectors
Yeah.
of the globe.
Yes.
So when somebody is pregnant and has cancer, they just go for termination. Can you just walk us through your MDT thought process as you are deciding between progression or termination of pregnancy?
So I think the most important thing is at two things we take into consideration is what trimester is she on and what is the stage of the disease. Now, if if a lady has been, and of course whether she has a child or she is primary gravida. So those are the three things we take into consideration. So if I have a lady who is 30 years old, is primary gravida, has 6 to 8 centimeter ovarian mass, and no other disease elsewhere on ultrasound. So even if I don't have access to MRI, so I don't have any disease elsewhere, and I'm not sure, whether this is a malignant mass or a non-malignant mass, and tumor markers are somewhere in between. We would, discuss this because I know that she's a primary gravida and we just have a single ovarian mass. I'm not sure of the diagnosis yet. So probably I would wait till, second trimester, see how it is, and we would also get to know it's like a solid cystic mass, it's grown rapidly. And second trimester, go for a unilateral salpingo oophorectomy, because by that time the placenta has taken over the function of the corpus luteal. And then based on the histopathology, because for all I know, this ovarian mass could be a borderline tumor. She's 29, 30. So in that case, you're not worried and you can allow the patient to take the pregnancy to term. Or even if it is a high-grade serous, it's an early stage high-grade serous, and where, we could consider, because she's 30, after that she's not likely to have pregnancy. And these have good. Of course, if it is a germ cell tumor also, the tumor has a good outcome. So you'll look at disease biology and stage. Whereas if I were to have the same patient in the first trimester presenting to me with ascites, peritoneal deposits, there I would really discuss with the patient whether advanced high-grade serous ovarian cancer with early pregnancy, where I know she has 3 to 4 weeks to go, and even to start chemotherapy I have to wait for 3 to 4 weeks. That is a place where one would probably discuss termination. Or like a locally advanced cervical cancer, diagnosed in the first trimester, where I know even to start chemotherapy, I have to wait 3 to 4 weeks. That is a case where one would want to, discuss termination. But if we diagnose a pregnancy in second trimester, or where, if it is a very early stage, she is diagnosed at 10 weeks or 8 or 9 to 12 weeks, where we know that waiting for 3 to 4 weeks to start chemotherapy is not going to make a difference, that we could consider that, in second trimester we'll do surgery or start neoadjuvant chemotherapy and then take. So look at the trimester, look at mainly the disease biology and the likely, I think the stage and the disease biology is the two most important thing that one would consider. Because even if I have a advanced germ cell tumor, where we know outcomes are excellent, one would want to, give chemo and then take them to term, because for gynecologic epithelial ovarian cancers, outcomes are dismal. But if you look at, germ cell tumors, or even for that matter, breast cancer with pregnancy, where they have excellent outcomes, it is very heartening to see these patients come back with their children. And one other incident I would like to say, that before you diagnose somebody with metastatic disease, we have to be very, very careful, because we have some spots. So I don't know how much time or other questions we have. So, so because I'll just like to narrate an incident where, during COVID times, we had a pregnant lady with breast cancer, where she had done an X-ray and there was this lung nodule. So, and this was first trimester, and we were really debating as to whether to allow her to continue pregnancy with a tiny lung nodule. So it was a very difficult decision when, we did whole body MR, and we tried looking at previous, but then she was very keen to continue pregnancy, and this was a single nodule. Fortunately, we didn't intervene and terminate, and she went on to deliver, and of course we've not done more scans after that, now 5-6 years down the line. So important is that when we are, like I think somebody mentioned, that how discussing in that MDT really helped because we were able to review her previous X-rays, see that probably that tiny nodule was still existing. There's no way I can biopsy that. So important, like an MDT really helped us take that decision.
We'll still squeeze in before we go to the on-site audience here. 2 more questions here. What are the perioperative risks and complications associated with recent ongoing immunotherapy?
No, immunotherapy has really not been tried, and I will tell that with pregnancy, you have a lot of PD-L1 receptors in the placenta. The reason being that that is what prevents the mother from rejecting the child. So PD-L1 is a mechanism for preventing, the mother from rejecting the fetus. So it is immune tolerance of the fetus depends upon immunotherapy. Depends upon the PD-L1 receptors present in the placenta. So we do not use immunotherapy during pregnancy because that would cause the mother to reject the fetus, So it is, PD-L1 is a critical component of immune tolerance of the fetus.
Okay. The last question here, what is the effect of chemo on breastfeeding?
It is contraindicated, so we ask the patient not to breastfeed the patient.
Okay. At this juncture, I would like to ask if there is 1 or 2 questions on site.
Thank you, Dr. Jay. Where I come from, cervical cancer and pregnancy are quite common, though in the advanced stages. And of course, we never really considered the option for chemotherapy, but I think this is more enlightening. To maybe also to the team on that side, we also have a lot of cases where we diagnose early stages for cervical cancer and pregnancy. Is there a role for chemotherapy before? Because what we normally do is we wait until term, we do a cesarean hysterectomy, followed by a radical hysterectomy. So we do cesarean section, then a radical hysterectomy for most of those cases.
So if we have diagnosed it, that is what I should, that if we have diagnosed it somewhere in 2nd trimester, not an early, if it is a very early stage, I think Dr. Burman can tell about, what is the role for the trachelectomy at extremely early stage cervical cancer. Before 22 weeks, there is a role for trachelectomy. But if you have stage 2 or stage 3 disease, cervical cancer, and diagnosed during 2nd trimester, then just rather waiting for her till 32 to 36 weeks, you could use weekly paclitaxel and carboplatin, which is fairly safe. And of course, we have to explain to the patient that there may be a chance of, her going into preterm labor and of course discuss with obstetrician. But then that is an option because today we know that even for stage 2 disease, there is a role for neoadjuvant chemotherapy, even without, these were studies before the interlace study came into. So, but now we know that even without pregnancy, there is a role for use of neoadjuvant chemotherapy in stage 2 disease or, 1B with lymph node positive disease. So these patients probably we could bridge the gap by giving weekly chemo and then take them up for delivery and then follow them up with definitive CTRT. Anything you want to say, Dr. Burman, about
Yes. As you told, early case, stage 1, B1, less than 2 centimeter, there is a role of doing a radical trachelectomy. But the thing is that the margin from the internal loss should be at least 1 centimeter. And then you put a circulation, So the mode of delivery will be cesarean for that patient. And if the margins are negative and node negative, that patient remains like that, nothing to do. That is how we deal.
I have another question, but it's for Prof. Devayani. I have a question for you. So across the different surgical approaches, how do intraoperative lymph node assessment and sampling differ? And does minimally invasive surgery compromise staging accuracy?
Thank you for your questions. So whenever we do a segmentectomy or anything less than a lobectomy, we also do a lymphadenectomy. That has to be done. And the primary tumor and the lymph nodes are both sent for frozen section analysis. If any lymph node comes positive on frozen section, we have to do a completion lobectomy. So inferring from this, you should not be doing a sublobar resection if your hospital does not have a frozen section facility. So that is about that. And we still do a systematic complete nodal clearance. Though for extremely early tumors, there is an upcoming role for lobe-specific lymphadenectomy. But since the overall morbidity of a complete lymphadenectomy is not too high, we prefer to do it in all cases, for no matter how small or big the tumor is. And coming to MIS, all the minimally invasive approaches, whether it is VATS or robotic, have shown one thing consistently, which is improvement in lymph node yield. Because of the magnification and the increased precision, the number of lymph nodes that we manage to dissect in minimally invasive procedures is more than in open surgery. I hope that answers the question.
The person is online. Thank you. So just one small house announcement. So there is no coffee break, but there is cookies and coffee outside, so you could just walk out anytime to have some. Oh, sorry. Yeah.
Professor, thank you so much for the presentation. I have two questions for you. I work in a resource-limited setting where patients come in advanced stages of the disease. So first, I want to find out, you were talking about finding a pulmonary nodule which is maybe solitary or something like that. Sometimes our religious are not able to stick out their neck and tell us that this is metastatic lesion, or so they bring the report back and they are also doubting. And we don't have the capability of maybe going in to take a biopsy to confirm what type of lesion is in the lung. So in this situation, I want to find out from your experience, what can we do for this patient in terms of counseling them about the stage and what the intervention to.
So it is not only there, but even in our MDTs, we are forever debating these lung nodules which are too small to characterize. I mean, of course, this was a pregnant lady, so we did not do a CT scan, but otherwise also whenever we have these very small nodules, I think, so then, and which are difficult to biopsy or even on an X-ray. Of course, in an X-ray, when you see a nodule, it is generally like bigger. But if you have this very tiny nodule where you don't know, then you look at the overall picture. I mean, what is the other stage of the disease? How likely is it going to be? And knowing whether that nodule is positive or negative, is it going to make a difference in your management? So if I have, say, a lady with advanced ovarian cancer who has ascites, peritoneal disease, does it really matter whether that 1.5 centimeter nodule is a MET or not? No, because this patient would anyways go for neoadjuvant chemotherapy. And if she has a very early stage disease, so where if it is a 1A disease or is a borderline or is a low grade, then we could probably keep that lung nodule under close follow-up. So we have to, many a times, even if I have the best of imaging and I have a PET, I mean, of course, not in a pregnant lady, but even if I have the best of imaging, CT, PET, CT, there are always a small group of lesions which we are not able to characterize. So there we have to take a clinical call, and that is where your multidisciplinaries, get all her previous imaging, see whether that thing existed before, look at the overall biology of disease and ask ourselves a question, is that lung nodule going to change my management? I think that would answer most of the things, and then take a pragmatic call as to how you would treat. If there are, of course, multiple lung nodules, that is different.
All right, thank you so much. Last one. Stage 3 cervical cancer in pregnancy, postpartum. Mostly they will require concurrent chemoradiation. My center, I don't have the facility of giving radiotherapy. And usually the patients cannot afford for the concurrent chemoradiation if I refer them. How long can I give carbotaxol?
So see, if you have a postpartum patient with locally advanced cervical cancer, so she would need radiation. So even, the data from Interlace is that, okay, if I can't send her immediately, like the data from neoadjuvant chemotherapy is that, you give 6 weeks and the 7th week you have to start chemoradiation. So chemoradiation is an integral part. Now, important is that how far is that radiotherapy center from your center? 300 miles. So that's a difficult. So I think what we can do is that if I have a stage 3 patient with locally advanced cancer, and that is where, a lot of our patients who come from like poor socioeconomic status and, we face these difficulty is to rope in a lot of NGOs, CSR. That is what we do. So, you can maybe by that time, have some coordination with your center there. And generally what we do happens is that if I just send that patient there, they get lost in transition. But now with the advent of, I think the latest thing is the mobile phones, that we take some 3-4 numbers of different relatives and keep it, because then we ask them to go there and of course we have some collaboration with the center which is far away, because not giving them radiotherapy would be doing, not being able to treat them. But what we can do is probably by this time for 6 weeks, in the meanwhile, preemptively have some collaboration with your radiation center there, that, okay, when I'm starting here, I'll inform you, then you book a place for this patient, send one relative there to know that, and have the patient go there once or come back, I don't know how, and then allow her to go there. And of course, there are huge challenges of patient, because even for our general OPD, when they come from different areas, they have huge challenges in terms of place of stay. And I think Dr. Banavali will say that for most of children or women who come there, we need a lot of social support, not only for them to come and stay there, because there are challenges that they would leave some kid behind or they will lose their daily wages. So involve as many people as possible so that we are able to coordinate with that center and get them back, and that's all. And there, of course, if she has extensive lung metastasis, that would change our management. So.
Thank you so much, Prof. You can be seated. Thank you. It was really insightful. So the next speaker will be Dr. Vikas Ostwald, medical oncologist from Tata Memorial as well. So he will be talking about managing colorectal cancer in patients with familial adenomatous polyposis and then hereditary non-polyposis colorectal cancer. So over to you.
Thank you. Thank Merck Foundation for inviting me. And I treat GI cancers, and I'm a medical oncologist. So we see around thousands of or 1,000 to 1,100 new colorectal cancers every year, and about our database is about more than 10,000 colorectal cancers. So why do we need to look at this cancer, which are probably contributing to 0.5% of the. So these familial adenomatosis polyposis, this would contribute to 0.5% or less than that of colorectal cancer. But why do we need to know them? So these are the cancers probably we can pick them up early, we can cure, and we can actually provide a very good outcome in terms of cancer or the cancer related survival. Now I will tell you the story, one short case where a lady landed up in my OPD with desmoid fibromatosis in her abdomen, a mass which I was treating her for with sorafenib because it was unresectable, and she had the history of colon removed, total colectomy for her FAP, and she did not want to go to the genetic clinic and get it evaluated for her own family because she was scared, and she had 2 kids. So going ahead, we will, with this background, I would like to bring this up where, so this gene is located, which is a large gene with 5q21, which actually involved in, it's a tumor suppressor gene in beta-catenin. And it is almost 100% penetrance with autosomal dominant inheritance. It is diagnosed with RT-PCR or NGS, and it is, even though it is kind of a large gene, it's difficult to detect on NGS unless it is this comprehensive genomic evaluation. Yeah, so these are the diagnostic criteria. We know that, so more than 100 or more than that polyps, 100 to 1000 polyps, germline mutations with APC, most of them will present with the family history. So these are the cases who will bring their families, will evaluate in the genetic clinic, and then they will be looked at. So think of that, I see 1000 new cancers of colon and every year, and out of that only one will be probably related to this. But it is still very important because it is curative, and it is also will have extracolonic manifestation once you treat the colon. So these are the extracolonic manifestation which we need to look at it. We will definitely need to do upper GI endoscopies, but they will have likely to have polyps, upper GI malignancies, and the other extracolonic malignancies would range between 5 to 20%. Desmoid fibromatosis and thyroid malignancies, for that we need to do ultrasound, abdomen and ultrasound thyroid regularly, and the ampullary tumors are also very difficult to detect, so we need to also do upper GI endoscopies. So these are the typical, this is a pattern of 100 to 1000 polyps, and they usually would come with the kind of a symptoms between with the help because of pain or bleeding. No, that's not the common presentation. The common presentation, the family evaluation, the genetic clinic evaluation, and that would bring them to our clinic. Usually the colorectal malignancies is going to develop in 100% of patients if left alone, and these are the patients who should be picked up early in their second or third decade of their life, before they go for the before they have the high risk of malignancy. But it is not that they may not develop malignancies in their second or third decade of their lives. So what time we should start screening them? Typically between 12 to 14 years. Some countries follow 10 years, but it may be medical legal issue. So 12 is the standard time. Annual sigmoidoscopy or colonoscopy, preferably colonoscopy, and upper GI endoscopies typically at 20 to 25 years, and that should be annual. And as I mentioned, thyroid and abdominal ultrasounds, again starting at 20-25. So this would give a lot of burden in terms of cost to the patient and the family. The screening would require evaluation multiple times. But one question if I have to ask in my mind, should we not just, when we know that it is a 100%, it's a high penetrance, 100% malignancy, why not operate them at the diagnosis of 12 or 13 or remove the colon, and why to give that burden? But as we know that if we any surgical or trauma, this patient will be put to the risk of desmoid fibromatosis. So that is also one of the concern mentioned to delay the surgery. But yes, we have to take a risk vis-a-vis screening, compliance, and the post-op complication. We are removing the colon, so patient will also have the issues related to the total colectomy. So that is why the question comes when to operate, and when we have obviously documented or suspected colorectal cancer, we have significant bleeding or obstruction because of the large polyps, the size of the polyp, 6 mm, or increase risk of like number of polyps or high grade dysplasia. And most important in the countries like Asians or African countries, the compliance. Most of the families this would take as a financial burden. Bringing them to the clinic will be problem, so they do not want, the compliance is poor, then it's better to operate. Now surgical management, I'm not a surgeon, but I would probably just touch upon that very important 3 aspect. This total proctocolectomy with end ileostomy. Yes, it's easy, knock off the colon, but you have the complication related to it. But of course you can reduce the number of follow-ups required, or the procedures required after that. And if you're thinking of patient's compliance is poor, this is the best approach. Then their total proctocolectomy with ileal pouch, the conduit is made. Now if that is done, then you need to follow them up, because there is it's a complex procedure, it will have complication, but most important, you require surveillance of the adenoma and carcinoma in the ileal pouch. Now, if we consider total colectomy with ileorectal anastomosis, the rectal stump will require, or rectal segment will require evaluation again and again, and that would increase the risk of malignancy going up in 4th or 5th decade. Is there any non-surgical management? No. We cannot prevent the cancer. This is almost 100% possibility of malignancy if it has developed. So there are multiple drugs which have been tried, especially the aspirin has not shown any significant benefit. As a medical oncologist, if the surgeon has operated and there was a cancer, how do I treat? And I go by the standard, the colon cancer management, as we see with non-FAP patient. But more important is that their tolerance to chemotherapy may be a problem. They have a high risk of complications. Instead of capecitabine, you might want to use 5-FU infusion because the diarrhea risk will be less. And these patients probably would also require improved support, because in ileostomy, post-ileostomy, these patients may have high volume diarrhea, and those patients probably would might land up with electrolyte disturbances and significant amount of complications. So there are some FAP mimics. One is attenuated FAP, where you have less polyps, but then again the risk of malignancy is there. It develops a little later than the FAP. You have the others like Gardner's and Turcot, and mute YH associated polyposis syndrome. Again, this is another FAP mimic which can also have the risk of colon cancer, and these are also this is typically associated with multiple other malignancies, and we need to have surveillance in these patients. But again, this can mimic as FAP, and then we need to divide our management based on the surveillance based on the genetic evaluation. So going ahead with HNPCC, this is a very interesting topic, because recently in ASCO we had one plenary presentation talking about the adjuvant immunotherapy in MSI high patients. Now these are the patients who will be with MSI high, and they will be presenting with the colon cancer, and then we need to think of the immunotherapy in the adjuvant setting. So these are basically based on the DNA mismatch repair genes. So there are different nucleotides, and the nucleotides may have different lengths, and they may have a mismatch repair in terms of a repair defect in these nucleotides. Now if that is there, that makes the tumor full of antigen, and that will bring the tumor infiltrating lymphocytes. So that makes the tumor hot. Now one thing one should remember is that not all MSI high tumors are Lynch syndrome. They may be Lynch syndrome, may be with MSI high, but they are not the other way. So these are the important MMR genes. I hope you are able to see it. So the MSH2 and MLH1 are important, and the other two are also present in when we evaluate these patients with the IHC. Now one thing is essential, that when we look at the diagnosis of Lynch syndrome, we need to look at IHC and also the PCR. Now this is how the flow chart will go. If you have a patient who is presenting with MSI high situation, and there will be around 15% of the patient in stage 2 if it is cancer, but if it overall colorectal cancers will have 3 to 15% of MSI high presence based on the stage. Now if these patients are presenting with MSI high, they have MSS2 loss or MSS6 loss with combination of PMS2. We need to look at BRAF mutation, because BRAF mutation is going to tell us that it is not a Lynch syndrome, it is a kind of non-syndromic, that is isolated, or it is like somatic MSI high colorectal cancer. Now in these patients, if we have to once we diagnose them as a Lynch syndrome, we also need to send them for genetic counseling and germline MMR gene analysis. Now germline MMR gene analysis, if it proves to be Lynch syndrome, the family requires to undergo the screening. If they are not germline, there could be epigenetic, that is one I mentioned as MLH1 methylation, promoter methylation, and that could be other, it could be just the somatic alteration where you are unlikely to have Lynch syndrome. So this is very important when we look at, so simply as oncologists, if you are sending NGS and if it is your limited panel NGS, you are unlikely to pick up this MSI high status. You need a comprehensive genomic analysis on NGS platform or ddPCR, droplet PCR, where we can actually pick up this MSI high status properly. So we all know the criteria, but I just want to make it very simple that with Amsterdam criteria is quite stringent and probably it is difficult to practice in the day-to-day clinic, but we can look at Bethesda classification with age less than 50 with synchronous metachronous colon cancer in the patient himself or herself, or first degree relative with Lynch and less than 50 to begin with, or 2 or more first or second degree relatives regardless of age. And these are the simplified criteria. There are more, but I have just for me as a medical oncologist treating every day the colon cancer, I need to keep this in mind. The most of these patients are lost in the crowd of the routine colon cancers or the treatment of these colorectal cancers, and they are actually very important, so we should not miss them. Do we have other cancers associated with this? I have just tried putting it as percentage, but about one can remember that this endometrial cancer and gastric cancer are important, and the other ovarian or small bowel or pancreatic cancers also would require because these are the cancers when we keep in mind screening test will depend on these things, where we need to do upper GI endoscopy apart from colonoscopy, CT scan, urine cytology, all these, and skin evaluation. These are the important areas where we need to look at. So these are the timelines where we can start screening colonoscopy at 2025, or typically 10 years younger, 10 years earlier than the index case, and upper GI endoscopy can be postponed a bit, but there are guidelines which are talking about it ranging from 20 to 35 years. Of course, urine cytology I mentioned, and endometrial sampling, it's not universal. Pelvic examination, again not universal, but scopies and CT scans and cytology are important. Pancreatic cancer and gastric cancer are not picked up on any of these unless you do endoscopies and CT scan. I remember a case with Lynch who had refused to do CT and upper GI endoscopy. He landed up with first with gastric cancer. Then fortunately we could treat him. He landed with the pancreatic malignancy, and that was advanced because he refused to do CT scan. So these are the cases where we need to keep in mind. Now, as I mentioned, IHC is like about 89 to 90% concordance with the PCR. So even if you have, of course, we all know the criteria, more than 2 instability out of 5 is MSI high on PCR, but it is on IHC, it is 1 out of 4 is also considered for MSI high criteria. One should keep in mind that PMS2 alone loss can be a problem. It may not be a true MSI high patient, and one loss on IHC should be reevaluated with either with the PCR or the comprehensive NGS. Usually they are right sided, they are associated with BRAF mutations if they are not germline, but there are germline, so then BRAF will be excluded, that you should keep in mind, and there will be high tumor infiltrating lymphocytes, and if they are R0 resection, high cure rates. Now this is the thing which has come after the adjuvant immunotherapy trials. Now 2 days back on Tuesday I was discussing with my surgical colleague in joint clinic. There was a case of MSI high Lynch syndrome presenting with a left colon mass. Now the discussion was whether to give neoadjuvant immunotherapy or operate him and give adjuvant chemotherapy plus immunotherapy based on the atomic trial. Now what would I do? And the surgeon was excited to operate the patient because he said it looks like a small ball, I can just take it out. But I said we need to think about this. The niche trial says that if you give 2 cycles of immunotherapy, your PAT-CR rate is about 70% in these patients. And if you operate and this patient turn out to be stage 3 disease or high risk stage 2, you need to give 6 months of FOLFOX and 1 year of immunotherapy in the adjuvant setting. That is expensive. So think about it. Are you really sure that it is going to turn out to be a low risk stage 2 disease, or by any chance you are putting him at the risk of receiving 6 months of FOLFOX and 1 year of immunotherapy? I better give 2 cycles of immunotherapy and bring it down, give him a chance of 70% PAT-CR, and after that no treatment. So this is the discussion which comes now. So these are the patients who are going to come again and again in your MDT. This is going to be a discussion, and you need to understand the crucial management, because we have limited resources. We don't have n number of resources, n number of trials to involve these patients. Of course, these are the surgical approaches, and usual adjuvant therapy. Now this is, of course, I made these slides after the atomic trial because I was at ASCO, and before ASCO I sent these slides. I'm not included in this, but now the management would not be simple chemotherapy in stage 2 high risk or stage 3. Adjuvant treatment will be associated with chemotherapy plus immunotherapy. So in these patients, this is the niche trial which I was talking about, where we look at you look at this complete response, 68%, and this is only after 2 cycles of immunotherapy. Why do we get such a high benefit in these MSI high Lynch syndrome tumors? Because they are tumor hot, you already have the immune cells, you just need to allow them to work. Options are pembrolizumab, neo-AP based on the current trial, 8WH, and the 70 to 80% MSI high would have excellent outcomes with these immunotherapies, even if they present with advanced disease. So we have 3-year data or we have 5-year data, and their outcomes are excellent with immune checkpoint inhibitors. So familial adenomatosis polyposis and HNPCC are uncommon causes of colorectal cancer. Regular screening and early identification leads to high cure rate. Primary approach would be surgery, and HNPCC has the biomarker of MSI high for immunotherapy. Thank you.
So again the same thing, if you give chemotherapy or radiation, even 1 dose, the tumor may release antigens, and then the immunotherapy may work better. So I think that approach may be better in the long run of giving immunotherapy and then operating, rather than going in and just removing this tumor.
Any other question?
Thank you for the comment, sir. Yeah.
There are other questions.
Yeah. Thank you very much for this good, insightful presentation. Dr. Kazuma, surgical oncologist. I want to get your insights a bit on making a decision between permanent ileostomy and ilioanal pouch in someone who's growing. Are there any concerns of the ileum undergoing differential growth that they would not end up with ischemic fibrosis as opposed to the colon, or you just decide this one I'm going to do ilioanal pouch, this one I'm going to do in ileostomy? Is there anything related to the growth of one who is still growing or who has not achieved puberty?
Yeah, I think that's purely, you are the surgical oncologist, I'm a medical oncologist, you're purely your call, you can take that decision. But I would say compliance is a problem in our country. Not in our country, but probably Asian and African countries are like compliance because of the cost is a problem. So probably you may think of multiple medical reasons, but if the patient is not willing to comply with the surveillance and you leave a pouch there, conduit there, which is high risk for malignancy, I think we are doing harm than the benefit. I think wait and watch policy in rectal cancer, what we are looking at is hardly they follow up the 85, we had the survey of our patients, 85% of the patients do not follow after their first 2 follows. We need to call them. So I don't know whether you're going to consider these factors or just the compliance. Thank you.
Thank you so much, Dr. Vikas. For that, we can give him a round of applause, please.
Thank you.
It gives me an honor to introduce our next speaker. She's not with us on site, but she will join us online. This is Dr. Judith Kwaila. She's a chief specialist surgeon and head of surgery at Mzuzu Central Hospital over there in Malawi. And she's also a proud Merck Foundation alumni. And she'll be talking to us on the topic palliative care options for advanced esophageal cancer in countries without radiation therapy. Over to you, Dr. Judith.
Thank you so much for that introduction. Good morning. As introduced, I am Dr. Judith Nkwaila. I am a consultant general and oncosurgeon based in Malawi. And I head the surgery department at Mzuzu Central Hospital, which is a referral hospital for the northern region of Malawi. I am delighted today to discuss with you all and to meet you all and discuss palliative care options for advanced esophageal cancer in countries without radiation therapy, which currently Malawi is, but soon will have radiation therapy in the public service. Malawi is the country in the southeastern part of Africa, bordering Tanzania on the northern side and Mozambique on the eastern side and Zambia on the western side. We are bordered by a beautiful lake on the eastern side of it with beautiful beaches, and we are proud to have one of the major mountains in Africa standing tall at 3,600 meters above the sea level. I'll give you an overview about esophageal cancer in Africa. So in overview about esophageal cancer in Africa, the incidence is more in males than it is in females. And our peak incidence in age is about 40 to 75. However, we see younger presentations as early as 25 in some cases. I remember my youngest case of esophageal cancer was a 24-year-old. Data in 2018 showed an incidence of 28,000. Esophageal cancer has a high mortality incidence ratio, barely in Africa at 97.2%, which is higher than the worldwide mortality incidence ratio standing at 88.9%. However, you can see based on those mortality incidence ratios that generally esophageal cancer has a higher mortality. And Malawi is within what we call the African belt for esophageal cancer. The African esophageal cancer corridor that spans up from Ethiopia down to South Africa and passing through Kenya, Uganda, Tanzania, Malawi, and Zambia. Risk factors, generally exposure to polycyclic aromatic hydrocarbons is one of the risk factors, as we use commonly firewood to cook in enclosed spaces and also charcoal. Although literature speaks about cigarette smoking and alcohol, but in most of our patients, you see that they do have esophageal cancer without prior history of cigarette smoking and alcohol. Current thoughts are to do with dietary factors, and studies are underway to understand the risk factors in our region. And deficiencies, selenium, phenosine, and zinc deficiencies are also thought to be risk factors for esophageal cancer in our regions. Thermal injury, HIV infection, and thermal injury from hot beverages. We drink a lot of tea in our region. And also HIV infection is thought to be a risk factor, although there are some conflicting studies about this, but more and more is thought that HIV with immunosuppression could predispose to esophageal cancer. And also they thought that genetics is at play in risk factor for esophageal cancer. And the AFRIC-ES studies are underway to understand that. So in this country where there is a high risk in the population for development of esophageal cancer, mainly squamous cell carcinoma, screening would be one of those things that would do. But otherwise, currently there are very limited screening services currently in trial phase under the Afric endoscopic endosquamous esophageal squamous dysplasia screening study that was done in Kenya. About 3% of the asymptomatic population, they were positive for ESD. That brings looking that endoscopic services are not readily available in most centers in Malawi or in Africa, then there has to be some low cost effective measures to screen esophageal cancer in this high risk population. And the use of esophageal sponge cytology is one of that thought that has come up, and feasibility studies have been done in Tanzania to look at the acceptability and the feasibility of employing esophageal sponge cytology for screening. I think this would be a breakthrough in our region if this is all feasible and cost effective. The African Esophageal Cancer Consortium, this is a combination of the countries that are within the African Esophageal Cancer Corridor, coming down from Ethiopia to South Africa, that I've been mentioning about, and currently doing studies to understand the risk factors and the palliative care options for esophageal cancer in these countries. Currently, the focus is on provision of safe expanding metallic stents to palliate esophageal cancer, but also to do prospective studies to compare these stents and other palliative care options. And Malawi has 2 centers in our capital, Lilongwe, and Blantyre under Afric studies. Continue with the overview. Commonly, our patients who present, of course, at an advanced stage, so progressive dysphagia with unintentional weight loss, chest pain, and adenovirgia are very common. And most of these patients would have been treated for a gastritis or a gastroesophageal reflux disease for many years before their diagnosis of cancer is made. Commonly in my place where I am actually, as part of first-line diagnosis, an upper GI contrast study will be done. This is archaic. Most centers are not doing that, but barium sulfate, using barium sulfate and barium swallows is one of those studies that I would request, because I do not have endoscopy services within my hospital. However, in other parts of the countries, an upper GI scope will be done, but although these are only in central hospitals, and some pilot studies in other district hospitals within the central region, then do biopsy to confirm whether this is esophageal cancer and whether it's an adenocarcinoma or squamous cell carcinoma. However, as in most African countries, pathology services are also limited services that are there. Treatment-wise, curative, radical surgery, and chemoradiation therapy are the major curative treatments that will be offered for patients with esophageal cancer. However, in advanced disease, palliative care option is what is available, and that's the aim of this talk this morning. So, is this a familiar situation in your hospital? Do you see these? These images are from my hospital. So these are barium swallow images that I would do in most of the patients that are coming in with progressive dysphagia. And commonly, I would see both of these images in my practice with contrast sometimes passing through, as in the first picture, but with limited contrast passing through in this second picture presented. So Let's come down to palliative care options in advanced esophageal cancer. Before we do that, I need to understand we are talking about the same things by defining the terms that we are using. So as most of you are aware, is that palliative care is an interdisciplinary medical care approach that involves an active, holistic care aimed at improving the quality of life for both patients and their families. For those patients with advanced progressive illness, I would like you to underline, the words interdisciplinary, because this is not done by one specialty, and also an active holistic care. So beyond the physical needs of the patient, what are other psychosocial and spiritual needs that need to be done? That's palliative care. And the aim is to improve the quality of life. We are not extending life, but we want to improve that quality of life that they have. Advanced esophageal cancer then would refer to a stage 4, whether a stage 4A or stage 4B, 4B being a metastatic disease, and a 4A meaning any but N3, and also a 4A or 4B with N2 or N3, even though without metastatic disease. So this is by TNM staging, it will be like that. The main symptom that we need to palliate in esophageal cancer, of course, is dysphagia. Despite all the other things that the patients have, but dysphagia is one of the distressing symptoms that this patient have and that needs to be palliated. Options for palliation, they range from endoscopic measures, dilatations, which are not ideal because you have to direct these patients at least each and every week, and it's not feasible. There's risk for perforations and the like. That's why currently our primary palliative measure is endoscopic stenting that will be discussed in the next slide. Use of chemotherapy in combination or as monotherapy for palliation. Our medical oncologists are also trying that. Surgery as a palliation for dysphagia, like resection of the part, is now historical, it's no longer a common practice. And radiation therapy using brachytherapy and external beam radiation therapy is a good palliative measure, otherwise not available in the public service in Malawi, but it will be available soon by July. And these palliative measures can be used as single modalities or as a combination, better used in a combination for best outcomes. So going to esophageal stenting as a primary palliative care option. In most of our African countries, under the Stent Access Initiative, we are provided with stents to use safe expanded metallic stents as a first line for palliation. You can have stents in plastic form or metal, but better metal stents, which could be fully covered or partially covered, but sometimes we do receive bare metallic stents. A good stent should also have anti-migratory features so that it doesn't move from where it is. So those stents with shoulders and some skid proofing are also good. And a stent should also provide anti-reflux mechanisms to prevent refluxing of GI contents into the esophagus. So having sleeves or valves is also another feature that is very important for stents. So self-expanding metallic stents in this slide, you see my colleagues in a central hospital down 400 kilometers from where I am, Dr. Kajombo, who is online at the moment, and also Dr. Mulima putting in stents as they have endoscopy services and a part of the Africa study site. And they're putting stents without using fluoroscopy. That's the one thing that we should also understand, the lack of fluoroscopy to guide position for stents. Chemotherapy for dysphagia palliation is also one thing that we are trying to use, and using it in combination for disseminated esophageal cancer. For our side, we are using either infusion of 5-fluorouracil in combination with cisplatin or paclitaxel with cisplatin. The other drugs, I think in other centers, they do use that, but the first two are the ones we are using, and we are seeing good change in terms of the quality of life and the resolution of dysphagia with those regimes. Issue of gastrostomy feeding tube. I need to understand in the room, is this a common practice in your country? Would you consider to put a gastrostomy feeding tube? And if you do, in what case scenarios would you want to put a gastrostomy feeding tube? In my practice, I no longer put gastrostomy feeding tubes like that. I personally feel that the benefits and the risks, the risks outweigh the benefit, because most of these patients that will need gastrostomy feeding tubes, they have very obstructive tumors and they are very malnourished. We do not have the actual gastrostomy tubes. We are improvising using a 22 French urinary for a catheter that leaks and it just messes up the quality of life for the patient. So if you look at quality of life and they go for palliation, I personally do not put gastrostomy feeding tubes. And generally they will not palliate the dysphagia, rather they will palliate some of the nutrition. But these are some things that you'll have to discuss possibly in your MDT also. It can be put for some cancers that are not suitable for stenting, that like those are in the esophagus, the cervical esophagus. But also we should understand even though in the cervical esophagus, if the tumor is at least at a minimum of 1 centimeter below the upper esophageal sphincter, you can still put a stent. Issue of percutaneous endoscopic gastrostomy versus open gastrostomies. In our setting, if I'll have to put a gastrostomy feeding tube or a jejunostomy feeding tube, it has to be done open technique, because there's no place to do a percutaneous endoscopic gastrostomy. Reaching that far, I thank you all for listening into my presentation, and I do acknowledge the Merck Foundation for giving me this opportunity to present to you and discuss and share our experiences in Malawi and how we are managing esophageal cancer without radiation therapy. An apology, I could not make this in person, but I'm glad that we can speak this morning. Thank you.
Thank you so much, Dr. Judith. I can feel the I can sort of sense the feeling you had after coming back home from a place like Tata Memorial Hospital, which has everything, and then you go home like a person in a scuba jacket, but on the sand. You have nothing to swim in, and I can see that but you need to be creative, and I've seen how creative you are. I don't know if we have any questions for her, if she can, or some comments.
Yeah, good morning. Thank you so much, Dr. Judith, for that wonderful presentation. Dr. Fori is the name. So I may want to know what will be the best pharmacological management of patients with esophageal cancer who come down with intractable pain, and when should we consider interventional pain management for such? Thank you.
Can I take it now, or there are other questions in the room that I can take in succession?
Yeah, Dr. Judith, Dr. Banavlia from Tata Hospital. Thank you for the presentation and trying to do whatever best you can in your settings. But I agree that radiation is a very, very important treatment, even in palliative care for esophageal cancer. So you are missing the important modality of treatment. The other thing that we use, actually, I also work in a rural setup where we use metronomic therapies as palliative. We start with the injectable, like you told, weekly we give Pacli, and cisplatinum I use more than carboplatin, but that we give weekly, and that can go on for continuously 10, 12, 15 weeks. But after that we put them on oral, depending on which type. If it's a squamous, we give methotrexate or based cetuximab, not cetuximab, but methotrexate erlotinib based treatment, and if it's basically a, basically the other thing is capecitabine and endoxon based therapy, but we try to continue them on oral treatment as much as they respond. Not all of them do respond, but some of them go on for years also, so that the palliative aspect, even metronomic therapies can help you in some subset of patients, though not all. So, but thank you for the good presentation.
Thank you.
Yeah, thank you, Judith, for presentation. I'm happy that Malawi is still active in Africa, that we started some time back. And the risk factors have been very difficult because in the same country, a large country like Tanzania, you'll have practitioners in certain regions of the country who have never seen an esophageal cancer. And we know the whole of Africa, we cook on firewood. And that brings a lot into question whether it's actually the firewood that causes esophageal cancer in this setup. So we don't know yet. We have done genetic studies and we have not seen any genetic pattern that would also point to a genetic, but we know that it has a geographical distribution even within countries. That's why you are seeing it in Bomet and Eldoret in Kenya, which are islands. And in Tanzania, you'd see it in Kilimanjaro in the southern islands and the western islands. And you don't see it in the lowlands. So that's one thing that we have not yet uncovered exactly what's causing esophageal cancer. And again, as been said, the lack of radiotherapy is a big blow. But then when you have radiotherapy and you have stents, you also have a problem. Because then stents should only be for palliation, but radiotherapy can also palliate. So we were deploying both stents and radiotherapy, and when the tumor started to get fibrosis with stent inside, the pain the patient gets was unbearable. So you can palliate with either of them, either radiotherapy or a stent, but I would not recommend both. Yeah, so both are palliative options, but radiotherapy can also be curative in esophageal cancer. So I hope you are also doing CT scan staging to know whether you are actually palliating this patient or you are addressing nutrition to make them surgical candidates, because that was the other problem we were facing within the Africa community, that our counterparts were addressing it like a palliative disease, but this is a starving patient. When they are cachexic and poorly nourished, does not necessarily mean they are metastatic. They are only starving. So in China, in Linxiang, where they're also seeing, actually it is the place with the highest burden of esophageal cancer in the world, they start these patients on an immediate, when they come, just like bowel obstruction. So they addressed it politically, that people had obstructed esophagus, obstructed roads, obstructed rivers, and the politics was to open up roads, open up water, and open this esophagus. So they do CT scan as first thing, and you decide whether this patient is for palliation or this patient will be treated curatively. If they'll be palliated, then a stent is deployed. If they'll be treated, they are dilated and you put a feeding tube and you feed them aggressively, and then they become surgical candidates. They will get neoadjuvant treatments and then they will get surgery. And so I want us to avoid this blanket palliation within Africa. Stage patients appropriately and decide which group will be palliated and which one will be optimized nutritionally and performance-wise to benefit from surgery. Then you will realize that a good proportion of patients will be surgical candidates. Thank you.
It's a very important thing, but again, the best way to improve the nutrition is to treat the disease itself. So the weekly chemo that we give, really, you are right. Again, the same thing in the rural setup. 90% of the patient come really cachexic, lack of eating. But when we start them on chemo and low dose, not the 3 weekly chemo, low dose chemo, it really improves their nutrition. In the second, third week, they start eating. By 8th week, by the time they reach radiation, many of them have improved, gained weight, improved the nutrition. They tolerate the radiation therapy well. So I think the best way to improve the nutrition is to treat the disease so that the disease improves and they can start eating this thing used to improve the intake, and it helps in the long run both for this if they have to undergo surgery or radiation, both ways it helps them once they have the nutrition improved.
I think, sir, the point that you made about being very careful with stenting is extremely important, because as a surgeon who deals with esophageal cancer, we do have patients who, get stented outside because of dysphagia, and then surgery becomes very, very difficult, especially if it's a middle third tumor around the airway. The fibrosis makes it near impossible to resect these tumors. So, I'm sure that whoever did the stenting outside meant well, but for a curative intent patient, many times we are not able to do justice with their treatment.
I know Dr. Judith is not a medical onco, so I'm not sure whether you're going to tackle that pharmacological question, or we have a medical onco person. Okay, go ahead, please.
Can share what we do here for patients with intractable pain. Actually, I would say that my center where I am in, there's no medical oncologist, there's no pathologist, there's no radiologist, and I am the surgical onco person that has to deal with these particular patients. So I can attempt a few things that I work with my team in palliative care. So basically what the pain will actually be maybe also from neuropathic pain. So we also, apart from giving opioids like morphine, we also treat them with gabapentin or pregabalin if the pain is very, very intractable. That's how far we can go. We do not have the luxury of doing intrathecal delivery of pain control or nerve blocks. We are not at that level. So in my center, that's how far we can go. I'm not sure. I can also learn from the other people within the room on what the modalities that they're actually doing in their centers. And I would really love to hear from the African colleagues so that I understand from their setting to see what is feasible in their setting to manage pain.
Thank you so much. I think we have a panel discussion in the afternoon on just pain management with cancer, and I think that we'll keep it for that time. So thank you so much, Dr. Judith. Please pass a regards to Dr.
Acknowledge the whole team, and also as we have discussed, there are lots of gray areas in our region that needs a lot of studies, and I do hope that Merck Foundation will help us through to research some of these areas. So when we come back in future to discuss these issues, we should come back with results from our research studies that we are doing, and we can show with data and the improvements that we have done. It will be a sad reality for me to come back at some point and discuss this same level of discussion 2 or 3 years later. Thank you.
Thank you, thank you, thank you.
So we'll have Professor Banavali again for the last case discussion. So it will be on pediatric oncology, brain and central nervous system tumors. So over to you, Prof.
So basically, if you see pediatric tumors, the commonest tumors are the blood cancers, that is the leukemias and the lymphomas, which nearly form half the tumors. But the other most important tumor in children is the CNS tumors or the brain tumors, and you can see nearly 1/4 of the pediatric tumors are brain tumors, so it's a very important aspect of treatment. Very importantly, if you see here, basically, over the years, we have it has still become the leading cause of morbidity and mortality in pediatric cancers. We have improved a lot of in many of the cancers, but still brain tumors is not one area, is one area we have not really achieved much over the years, and you can see here mortality has remained nearly constant over the years. The commonest cancers here is, you can see here in the brain tumors, is basically the gliomas, which you can see as the pilocytic astrocytoma, the malignant gliomas, the neuronal and mixed neuronal glial tumors and astrocytomas. So these are, some important tumors. So this gliomas is the commonest brain tumor in children, followed by the embryonal tumors, out of which medulloblastoma, as you know, is one of the common cancers there and highly curable amongst the brain tumors. So again, I showed you this slide in the morning that we have made a lot of improvement over the last 50 years in the management of pediatric cancers. But very importantly, if you see here in brain tumors, the high-grade gliomas, the diffuse intrinsic pontine gliomas, absolutely in the last 30, 40 years, there has been no improvement at all, and the outcome has remained nearly the same. So one area where still a lot of things can be done, and in the morning I showed you that with the use of immune therapies and all, we are really trying to improve the outcomes in these tumors. But what has happened in the other aspects of brain tumor management, let us discuss that in this lecture. I have already discussed the immune therapies in the morning, so I will not repeat that again. But there are other things that has helped to us to improve, not even if not the outcomes of the brain tumors. We now understand the much better the tumor biology with the molecular risk stratification that we have started to use. And over the years, actually, this will help us to formulate better therapies for patients with brain tumors. And very, very importantly, again, it has been told again and again since morning that cancer cannot be treated by one person. You have to have a team, and we are really fortunate at TMH to have a multidisciplinary team to manage all type of cancers. But very importantly, brain tumors really requires a multidisciplinary team if you have to manage them well. And this is not only this thing is like this slide shows the WHO classification, for example, now has really changed the way we were even diagnosing these cancers before compared to now. And there is layered reporting. What does that mean? Is that initially we were happy to have a morphological diagnosis itself, but no longer that is important. Morphological diagnosis alone is not enough, and we need to have layered reporting in the sense that along with morphological diagnosis, now we have to know the histological grade of the tumor. Grade plays a very, very important role in how we manage this cancer, so histological grade. And what is now changing the management of brain tumors is the molecular subtyping. I told you in the morning how it has helped us to treat with immunotherapies, but the molecular subtypes is very important to know, and that has helped us to better manage this patient with brain tumors. For example, I'll be discussing only two tumors. One is the medulloblastomas, and that is the glial tumors. And let us start with medulloblastomas. So as we all know, medulloblastomas is actually divided in various things. So we have metastatic and non-metastatic tumor. And in metastasis, we have M1 that is only in the CSF. The M2, 3 is in the CSF and spine. And M4 when it goes outside the brain into other organs like the bone marrow, lung, liver, etc. So that's important to know how much spread is there on these tumors. And very importantly, like I told you, along with that, we already knew this, which was there from before, is what is the histopathology. For example, the desmoplastic tumors do the best. Then we have classic, and the anaplastic, large cell anaplastic tumors do the worst. So all this is important information. And that is how we used to conventionally classify these medulloblastomas. That is, if the patient was less than 3 years, had a lot of residual tumor, or had metastasis, or had anaplastic morphology, these were considered to be high-grade tumors, high-risk tumors, and they were treated accordingly. But we have gone ahead from that, along with that data. Now, very importantly, especially in medulloblastomas now, we have to know the molecular subgrouping so that we can group classify them as per the molecular data. There are 10% of patients who have Wnt abnormalities, and these are the ones who really do well. And why is this important? Because if we know upfront what is the subtype, we can basically, for example, if it's a Wnt type of tumor, we don't have to be very aggressive. We don't need to have even a R0 resection. Even some residual tumor is okay. Because when you aggressively do the surgeries, you can have the posterior fossa tumor syndrome and really have a lot of complications also. So knowing which subtype will also help this in this management of the tumors, or even decrease the chemotherapy or radiation therapy once we know this, what is the subgrouping. So we have one Wnt subgroup, the Stonic Hedgehog pathway abnormalities, the group 3 and the group 4. So the group 3 is the one which does the worst, and the Wnt is the one which does the best. So knowing this helps us to better manage these patients. And if you see here now, so as opposed to the conventional classification, now we risk stratify them according to the, along with the old data, we also consider them to be high risk if they are MYC amplified, or if they have the group 3 tumors, and if they have basically the others are in the low risk group, especially the Wnt group is in the low risk group. So basically this has changed the way we risk stratify this tumors. And this is the way we manage, for example, if the patient depends on the age. So if you have a patient with medulloblastoma who is less than 3.5 years, basically they undergo surgery, and that is followed by chemotherapy. And we try to delay radiation or avoid radiation in this group of patients because of the long-term side effects. And if the patient is more than 3.5 years, basically the surgery is followed by the craniospinal irradiation, and then we give them the chemotherapy. So this is how we manage this patient. And how do we manage patients with infantile or the less than 3-year-old child with medulloblastoma? So very importantly, again, we need to know whether it's a non-metastatic or a metastatic disease. So non-metastatic disease, if there is a second part which we need to know, is whether it's the anaplastic or the classic type of morphology as compared to the desmoplastic tumors. Like I told you, desmoplastic are the one who do well. So for them only chemotherapy is enough. But for this patient, group of patients, we start them with chemotherapy, but later even give them high dose chemotherapy in the form of autologous transplant, and if required, delay the need of radiation, but they may require focal radiation therapy later. As compared to that, the metastatic who are in the very high risk group, they require intensified chemotherapy along with the high dose autologous bone marrow transplantation, but they also are given radiation therapy as per the age of the child. So the common chemotherapy approaches that are used in patients with infantile or the infantile medulloblastomas was the primary was the baby brain protocol, which was the old one, but that is no longer used now. And the two common protocols that are used is the HIT, which is the high dose methotrexate, along with the intrathecal therapy. This is a German protocol as compared to the Head Start studies, which is the other common protocol that is used in this patient. So if you see the HIT protocol, it has basically the intraventricular therapies, which is followed by, actually along with that we give a high dose cyclophosphamide and vincristine, followed by methotrexate and high dose methotrexate and vincristine. So this includes a lot of intraventricular therapy along with high dose methotrexate and also the other carboplatin etoposide based therapy. So this is quite popularly used in infantile medulloblastomas. But very importantly, again, if you see, this protocol avoids, as expected, less than 3.5 as we try to avoid radiation therapy. So you see here, without radiation therapy, if the child has the classic histology, basically they don't do well. It's a desmoplastic group of tumors which does really well with this protocol. And the other common thing, as I told you, is the residual tumors. If there's no residual tumors, these patients do really well. But if there's residual tumor, they don't do that well. So what this shows that if you have residual tumor, if you have non-desmoplastic morphology, you require radiation therapy. Chemotherapy alone is not enough to really improve the outcomes in most of the patients. The other protocol, which is a Head Start protocol, what this uses is basically the chemotherapy. Along with that, they use autologous transplant in the form of high dose, basically myeloablative chemotherapy with thioetoposide carboplatin. So this uses high dose therapy along with autologous transplant. So again, this is not done in most this thing, but in higher centers, especially in US, this protocol is quite used, but this may not be possible to use in many of the low and middle income countries. So again, this shows the same thing basically, that if you have the the desmoplastic histology, you do well, but for the others, the outcome is not that good. So what again it shows is that the type of histology matters, and that shows that how aggressive the tumor is, and maybe these are the patients, like I showed you in the first presentation, that immunotherapy may help in improving the outcome in some of these patients. Like I told you, 10% of the patients with medulloblastomas may have immunologically active tumor. So what happens to the child who is more than 3.5 years old, and this is much better here, so you can give radiation there. So like in this group of patients, basically again these patients are divided into average and high risk, like I told you in the first few slides back. So if the patient is average risk, that means not anaplastic morphology, this thing, then you can basically give them low dose of craniospinal irradiation as compared to those with high risk, where you need to give more radiation therapy. And like I told you, more radiation is not good in the long run. So this is better, because if you with low radiation, long-term side effects are decreased. And in chemotherapy, again the same thing, they require 4 to 8 cycles of chemotherapy. What are the other options? And the other options are using, I'll show you in the next few slides, concurrent carboplatin during radiation therapy, and whether we can use high dose chemotherapy here. And again, those who have average risk, they do really well, more than 85% long-term survival, as compared to high risk, those who have 30 to 70% survival only. So what are the chemotherapy regimens? The adjuvant therapies include surgery. We start with surgery in all the patients. And the adjuvant therapy, again, this is a Packer regimen. We started with basically the lomustine-based chemotherapy, cisplatin, lomustine, vincristine. But what happened is, in many times this drug is not available, lomustine is not available, so they changed it and have increased it now, the cyclophosphamide in this thing. So instead of lomustine, you give cyclophosphamide, so cisplatin cyclo-VCR based protocol. And very importantly, the outcome is nearly the same in both, so it doesn't matter depending on the availability. The side effect profile may change in this group, but basically the outcomes are nearly the same. So wherever it's available, we have used lomustine, but if it's not available, we use the cyclophosphamide based therapy. So the other option, like I told you, the one which has been really used is basically use of carboplatin as a radiosensitizer. So along with the radiation therapy, we give them weekly carboplatin during the therapy, and that has helped to improve the outcome in this group of patients. This is the data from Tata Hospital also. You can see here nearly 60-70% of the patients are doing well in the long run with the use of carboplatin as the concurrent therapy during radiation. And the other one which has been used, especially developed by St. Jude's, is what they use is basically high dose. They give non-myeloablative chemotherapy. That means they give high dose of cyclocisplatinum vincristine, but rescue it by giving stem cell transplant. So they remove the stem cell from the child upfront, keep it in 2-3 aliquots, and after each dose of non-myeloablative high dose chemotherapy, they infuse the stem cells, and then basically with that they showed that the average risk patient are doing really well in this, more than 80-85%, and even the high risk group patients are nearly doing at 65-70%. So this has helped them to improve the outcomes in patients with medulloblastoma. And though this is not very popular in other centers, because this rarely requires high dose chemotherapy, stem cell transplant. So basically this is not all centers offer this type of therapy because of logistic reasons. And what do we do at the Tata Hospital? As we know, one of the reasons why these patients don't do well is that after the initial responses, many of them relapse. So what we have been doing it's an ongoing trial now at Tata Hospital, where we are using metronomic maintenance therapy. So after the initial standard therapy, now we have been putting them on maintenance therapy using low dose oral metronomic therapies. This is an ongoing trial, and time will tell whether this type of treatment may help us to improve the outcomes by decreasing the long-term relapses in this group of patients. So what is the current approach for medulloblastoma? Is that, again, the first thing is accurate risk stratification is very important, because this helps us to really plan the treatment in this group of patients. Chemotherapy only strategy is for, especially for the young children less than 3.5 years of age. But again, like I told you, desmoplastic are the one who really do well. All others require some type of radiation therapy, not maybe to begin with, but later in the treatment they'll require that. Multimodality treatment, timing of modality is essential for optimal outcomes. Again, very, very importantly, like I told you, this requires a really multi-team approach to treat these children. So sending them, referring them to a neuro-oncology center is very, very crucial, because right from the diagnosis, that means having a good pathological, morphological and molecular diagnosis, after that good radiological evaluation, good surgery, good chemotherapy, good radiation therapy. So you really require a good team if you have to improve the outcomes in children with brain tumors. And further research is focused on decreasing therapy for good risk and better therapies for high risk patients. So this is very important to understand that you can cure these children, but along with the initial therapy, I forgot to tell that after the completion of therapy also the rehabilitation services are so important. So not only you need the surgeons and the radiation oncologists and pediatric oncologists, you also need a very good rehabilitation service, because this patient require lifelong support many a times. So the other thing that I'm going to discuss is the pediatric low-grade gliomas, because this is another important group of tumors in pediatric brain tumors. But again, you have to understand that the pediatric low-grade glioma is a chronic disease and often requires multiple lines of therapy. Again, the same thing like in medulloblastoma, it's a multidisciplinary team approach, right from decision making to treating this children. So it's very important to have a team. And surgery is important, because as for all tumors, as solid tumors, and especially even in pediatric, if a good surgery is important, you have to cure many of these patients. So surgical resection is the treatment of choice for resectable tumors. A gross total resection or near total resection is curative in many of these patients. Biopsy should be done wherever possible, because again, the advantages of doing surgery is achieves immediate symptom relief in patients who have tumors at crucial sites, enables accurate histomorphological diagnosis, it provides tumor tissue for appropriate molecular testing, and with this data it helps to facilitate further adjuvant therapy. So very importantly, though surgery may not be possible to really do a complete surgery, even doing a biopsy may give you important clues in how to manage this patient later. And again, the same thing, resection is possible only in approximately 50% of patients. So not all cannot get a complete resection, but like I told you, even for a biopsy, it is good to do the surgery in this group of patients if possible, because if it's in the midline structure in Pons region and all Pontine region, you cannot operate them. So not all can undergo surgery, but wherever possible, please try to get a biopsy in this group of patients. So if you see the, again, algorithm for management of pediatric low-grade gliomas, you see a resection if possible for treatment as well as clinical diagnosis. If there is a complete resection, you can just observe this, these children. Whereas if you have incomplete or no resection, then if the patient is asymptomatic or no, there's no really symptoms, you can still continue to observe these children. There's no hurry in treating them. Whereas if there is any indication to treat, the treatment will either be chemotherapy, and I'll show you radiation as much as possible. We try to delay radiation in this group of patients. Again, very importantly, even if there's a relapse later, again the primary treatment will be surgery. So if there's a relapse and the patient is, the disease is operable, even the second time, and even we have gone third time and operated on this patient with low-grade gliomas. So you see here, the important prognostic factors are multiple. You see here the grade 1, so the lower the grade, the better is the outcome. If this tumor is in the cerebellum, the outcomes are better, whereas if it's in the brainstem, outcomes are not that good. Age, again the same thing, less than 1 year, 1 to 3 years are the best, less than 1 year are the worst. And if there's a gross total resection, they are the best. as compared to others. So there are multiple prognostic factors in these patients of low-grade gliomas. But very importantly, if you can see here, and like I told you in the previous slide, low-grade glioma is a chronic disease. So most of these patients will do well. The 20-year overall survival is nearly 90%. So you have to understand that it's not a 1 day or 2 day thing. You have to take care of this patient for years and years to come. So it's very important how you manage this patient, not for the immediate effect, but for the long-term outcome in this group of patients. So is overall our survival only the factor that you have to keep in mind? And like I told you, it's no, it's basically you have to keep, see how far you can keep them, we have a progression-free survival. So best, how better you can get a progression-free survival is what is important. The clinical parameters, for example, you have to preserve the vision in many of these patients. You have to maintain or monitor the endocrine dysfunctions in this patient. Try to see how much you can prolong or delay the radiation therapy. The quality of life parameters have to keep in mind, and very importantly, the late effects are supposed to be kept in mind. So it's what is important is to keep in mind what is the purpose of the therapy. And you can see here, this is data from St. Jude, where they have used radiation therapy. So you can see here, with radiation therapy, the outcomes are much better as compared to if you event-free survival, this is, as compared to those if you give the chemotherapy alone. But very importantly, actually, it's not just to look at the event-free survival. You can see here that when you give radiation therapy, there are a lot of drawbacks. There are a lot of cerebrovascular events over the years. There is a lot of secondary brain tumors, endocrine dysfunctions, cognitive decline over the years. So it's very important to keep all this in mind when you think of giving radiation therapy to these children. So this is what we do. Basically, if you see here, what we do is radiation for more than 5 to 7 years. We can give radiation and chemotherapy in younger patients. But chemotherapy at the time of progression, chemotherapy, we start with chemotherapy. This shows how we have changed over the years. So where initially we used to start with radiation, but then we started with chemotherapy and you had progression radiation therapy. But later we even started with chemotherapy, but at the time of progression again gave second line chemotherapy, try to delay the radiation therapy. So very importantly, we are trying to delay radiation therapy as much as possible. And this is because of the side effects. And there are various chemotherapy regimens, but what is important is this, that the typical 5-year progression-free survival is around 45% with the various types of chemotherapy, and no one chemotherapy protocol is better than others, so you can use your choice of chemotherapy, but all reach the same event-free survival. So what this slide shows is that if you give chemotherapy versus radiation therapy, again, like I told you, the progression-free survival is lower, around 50% with chemotherapy as compared to 70 to 80% with radiation therapy. But very importantly, the long-term toxicity is much more in patients with radiation therapy. And the other problem is chemotherapy basically is not that, without any problems also. So chemotherapy also has not been easy on the child and the family, because many times they have to keep on coming to the OPDs for years at a time. So missing school dropouts is known in this group of patients. Long therapy schedules, they have to frequently travel to the hospital. Many times they miss the normal childhood activities. That significant affects the growth and development of the child, and overall significant psychosocial impact with 50% progression-free survival and event-free survival. So a lot of problems are there even with chemotherapy, and that is why we have started looking, is there an alternative to treat these children better, and that's where the role of molecular therapies have come now. So as we have started understanding the biology of these brain tumors, we came to know that many of these pediatric low-grade gliomas do have molecular defects, and especially the BRAF mutations as well as BRAF fusions, and whether we can target those is what is going on at present. And if you can see here, this with BRAF fusion and BRAF mutations being common, now there are these are therapeutic targets, and there are drugs like trametinib, selitinib for the fusion as well as dabrafenib for the mutations. So we have started using these drugs now. Very importantly, we found that though dabrafenib is used for in patients with mutation, this tumor is very clever, so if you try to target at one point, the other thing pathway gets activated, so the MEK pathway gets activated. So what we are doing now is we are using combinations of the dabrafenib as well as trametinib, and this is, I'll show you, this has helped us to further improve the progression-free survival in this patient. So this use of molecular therapy has helped us to offset some of the issues faced by children. And as you can see, the progression-free survival and the event-free survival is not different than chemotherapy. It's not that it has cured tumors, but what has happened is that it has the molecular therapies or the targeted therapies is giving us nearly the same event-free survival as chemotherapy, but very importantly, it is decreasing the long-term side effects. So you can see here, basically, if you see by using trametinib alone, it's 16.4 months, but if you use trametinib and dabrafenib, it's nearly 37 months progression-free survival, so which is very good. And I'll show you in the next slide that you can see here that when the Buffet, actually from Canada, he did a study of randomized trial of trametinib plus dabrafenib versus chemotherapy in this group of patients. You can see here the outcome with the molecular therapies or target therapies is much better than if you use chemotherapy. And at the same time, you can see that the toxicity was less and the quality of life was better. So you can see here any adverse event, you can see that the grade 3 toxicity in this group of patients which you targeted therapy was 47% as compared to 94% with chemotherapy. And basically you can see here the overall this molecular targeted therapy was better tolerated than chemotherapy alone, and the quality of life was much better in patients who received the targeted therapy as compared to chemotherapy. So overall outcome was same, but the quality of life was better using targeted therapies, and that is why now can targeted therapies become frontline therapies is what is going on, and there are multiple studies going on at present using this as upfront therapy. So again, it brings to the same slide. We saw that chemotherapy, radiation therapy was better than chemotherapy, but the long-term side effects were more. But if you see now the target therapy, the outcome is nearly the same, progression-free survival with both, but this is at a better quality of life, and basically it's a much better tolerance. So we are shifting away from chemotherapy, from radiotherapy we shifted to chemo, and now from chemo we are shifting to molecular therapies in this group of patients. And this is what this slide shows. So as you see, we started low-grade gliomas, observation, progression, there's chemotherapy, second progression, again chemotherapy, and followed by radiation. But now what we do is, with the low-grade glioma, we start with observation, but on progression we treat them with the molecular therapies, and only later we go to chemotherapy and then radiation therapy. So this is, even at Tata we are doing this, so we are using the same drug, dabrafenib, trametinib is available, so we are using it in many of our patients with low-grade gliomas. And like I told you, the toxicity profile, though it's not fully established, but it's better than chemotherapy. Cost availability is still an issue, but now there are generics available, so we are using those. Molecular testing is required, so this is very important. Drug approvals, many countries awaited, oral tablets, so child, again it's sometimes difficult to give them, and tumor response is slow. Don't expect overnight responses like in chemo. It takes many times months to see the response, but eventually it happens. So this is just a slide to show you how the optic pathway glioma responds to the trametinib. So really good responses in some patients. And again, this shows in another group of patients, the tuberous sclerosis, where we are using everolimus, another targeted therapy, mTOR inhibitor. So we are seeing good responses in that group of subgroup of patients. Again, neurofibromatosis is another low-grade glioma. You see here actually the no biopsy. Again, this is one tumor where we really do not biopsy because you cannot biopsy optic pathway, but no biopsy is required. But basically, these are slow tumors, and basically we use single agent vinblastine and absolutely avoid radiation wherever possible. So we avoid radiation here, And we use bevacizumab, another the VEGF inhibitor. Basically, this is a drug which is used in this group of tumors with good stabilization of disease. It doesn't go away but stabilizes. So what is the present shift in paradigm in treating this low-grade glioma? Actually, all the slides have shifted. I don't know why, but really all my slides have shifted. But anyway, so what is we doing now? In 2005, we started with radiation therapy in this group of patients. Then we shifted to chemotherapy and used radiation on progression. From there, we shifted to chemotherapy on progression, again used chemotherapy to delay the radiation therapy. But now what we do is we start with the MEK inhibitors, and after progression only go to chemotherapy, and after progression on chemotherapy we go to radiation therapy. So we get many more years of treatment, radiation-free interval, so that the long-term side effects are really decreased in this group of tumors, and outcome, the quality of life is better. So to see low-grade gliomas, again like I told you, is a chronic disease. Long-term survival is good, needs expert multimodality team approach and individualized treatment, incorporate biology in decision making, very important. Chemotherapy is using more than before, delaying the radiation therapy. MEK inhibitors, BRAF inhibitors are more likely used upfront, and again long-term effects of treatment and sequelae have to be kept in mind when you are planning the treatment of this tumor. So this in one slide actually shows you how we are doing in various tumors. So for medulloblastoma, like I told you, chemo, surgery, radiation, all are required. Again, we try to reduce radiation in this patient less than 3 years of age. ATRT, again all 3 are required. PNET, again all 3 are required. Ependymoma is one tumor where it's not a chemosensitive tumor. We really don't know whether chemo makes any difference here, but we do surgery and radiation there. Germ cell tumor, again chemo, surgery plus minus depending where the site is, and radiation therapy is used. Low-grade gliomas, again instead of chemo now, the targeted therapy will come here, surgery and radiation therapy later, much later. And for high-grade glioma, definitely the immunotherapy will come here upfront, followed and surgery and radiation stays. So we are changing the way we are treating this group of patients. So pediatric tumors, brain tumors are a heterogeneous group of tumors. It's not a simple 1 or 2 type of tumors. There's so many of them. Management is complex, requires specialized multidisciplinary team approach. Timing of multimodal therapy is critical to optimize outcomes. Accurate risk stratification is absolutely mandatory. So molecular, grading and the morphological, all 3 are required to make a good diagnosis. Molecular subgrouping is highly prognostic and pragmatic approach, and therapeutic implications are evolving. So thank you very much, and I'd like to thank Dr. Girish Ramaswamy from our brain tumor group who has given me this slide.
Thank you so much, Prof. That was really insightful. Do we have any questions for him?
Any one of you managing brain tumors, by the way? No, yeah. Question. You have any questions?
The problem in our setup is one is diagnostic. Just we have biopsy can be done by neurosurgeons, but still we will depend on the morphology. There is no other. We have MRI to see whether there is seeding, and also we do CSF to decide whether medulloblastoma is high risk or average risk. But most of the patients, they end up with default because they are from the periphery, and during the follow-up, they don't complete their treatment. Those who are around the city, they come for radiation, for chemotherapy also, and we have some patients on follow-up. Initially, it was very difficult to have MDT with the neurosurgeons in the team. And the last 2 years, almost, we have started the MDT, and it has improved the treatment outcome. The waiting list, initially it was every month we were having, when you do it waiting, around 60, 70 patients were in the list who are waiting for neurosurgery and also for radiation.
Every week?
No, no, every month when we see, we have now weekly MDT.
Okay.
But after we start the MDT, almost we clear those tumors with surgery and radiation, and most of patients who are in the waiting list are craniopharyngioma. Others are handled by neurosurgeons and by radiation oncologists, and the MDT has helped us to almost clear out the backlog. Thank you.
No, actually, depending how many cases do you see per year for brain tumors?
No, I am not sure.
No,
But,
how many you must be seeing? No, I'm telling you, see, many times since it's not a big this thing like leukemia or something, we can have a MOU or something, then we can, our brain tumor pathology is a very strong team, and if you can have this thing, we can help out with the doing this in the especially the molecular test in your group of patients, because it's now established at our center, so we can help out. It's a large number, it may be difficult, but if there is a number which is manageable, we can easily do it. Because you are right, for that small number of patients, you may not be able to do that, but since it's so crucial to do this test, we can have a common area where you can send the specimen, and now the report can go on email, so it doesn't need to, it may not take that time or a long time also, and there's no emergency to do the molecular, 2-3 weeks you can easily wait after the surgery to get these reports and then modify your treatment accordingly, so we can work on it if possible.
Thank you. But previously it was difficult because most of the patients were seen by neurosurgeons. Now, every week we have 4 patients that are present in the MDT.
Okay.
Thank you.
If possible, we can help out, we'll do that. Thank you very much.
Good afternoon, everyone. Again, I would like to welcome our distinguished speaker, Professor Dr. Bamon, who's a professor and head of Department of Gynecological Oncology at Dr. B. Barrow Cancer Institute in India, and he will be discussing the topic endometrial cancer in young patients. Professor, welcome again.
So, good afternoon, everyone. So, thank you for coming back. So, basically, as you know, I'll be speaking on the management of endometrial cancer in young patients. Endometrial cancer, as we all know, is a disease of the older group of population. And 85% of the women will be in the postmenopausal group or outside their reproductive age group, and only as per the literature, if you see, the Western data are there, they have shown that almost 8 to 14% of the women will have endometrial cancer in their reproductive age group. A very difficult situation, We know that for endometrial cancer, we need to remove the uterus, but then there will be the women who will be detected during their infertility checkup sometimes. So they won't have any children. There are other group of women who may have one children, they want some more children. There also we have difficulty. Then there will be group of women where if you remove the uterus and the ovary at this young age, the hormonal issues. So all these things I'll be discussing point by point. So but then the problem is that whenever you get a woman at such a younger age group with endometrial cancer, lot of counseling has to go in. Unfortunately, if you see even the Western data, only 46% of the women are counseled for all these aspects. So this is very important. Whenever you get a woman in the fertility age group, younger age group, with endometrial cancer, lot of counseling goes into it, so that she must understand what are the things that we are trying to do. Basically, we'll be discussing with them the fertility preserving options. But that does not guarantee that she may need a definitive surgery in the event of progression of the disease when we are trying to treat her for the fertility preserving options, with the fertility preserving options. So now, if you see what are the characteristics of these younger patients with endometrial cancer, if you see, they tend to have a prognostically favorable histologic type, such as well-differentiated adenocarcinoma. Most of these patients will have a favorable histological type, and then mostly they are likely to present in stage 1 disease. That is another good thing to happen. And if you compare the stage by stage, the prognosis of endometrial cancer between a reproductive age group and the postmenopausal age group, the reproductive age group patients does better. So these are the good things that happens. Okay, so now how they present? If you see, most of these patients in the younger age group will be diagnosed, as I've already told, during their infertility workup. Someone has done a hysteroscopy, they find a polypedal thing, they have taken it out and it come out to be endometrial cancer, and then they are referred to you. Okay, so this one way. Other option, you know that obesity and greater BMI greater than 30 is responsible for almost 80% of the patients with endometrial cancer in younger age group. We all know how obesity affects the insulin resistance, and hyperinsulinemia produces hyperinsulinemia, and then increased bioavailability of the steroid hormones and localized inflammation which is there. So now, overlap of these factors in PCOD. All these patients may have PCOD, and all this PCOD, obesity, hyperinsulinemia, all this contributes to this endometrial cancer. Again, there will be a group of patients where you will have this familial syndrome. These patients may have a history of familial syndrome in the form of Lynch syndrome, HNPCC, which is caused by these 4 genetic mutations, MLH1, MSH2, MSH6, and PMS2. And also some will have Cowden syndrome, a part of the condition, although very rare, P10 mutations. So if you see all these things, now coming back, how you diagnose and assess. History, including family history. As I have already told, some of these women will give you a family history of endometrial cancer or other this mutation-associated cancers. Then you need to do a histological confirmation. Without histological confirmation, you cannot tell that she is having a endometrial cancer. And how do you do it? We do a DNC or hysteroscopic guided biopsy. If you have a hysteroscope, it's very easy, and it's preferable to do a hysteroscopic guided, go in, see the exact lesion and take it out and do a histological confirmation. And also you have to understand determine the extent of the disease. How do you do? Basically you will do a imaging, either it is a contrast enhanced MRI is preferable over ultrasound, CT or MRI. Plain MRI. And laparoscopic evaluation not recommended unless imaging is suspicious for extensive disease. Otherwise, up to this much is okay with us. So now, what are the guidelines? So as you see, we have one guideline where the ESG guidelines for fertility sparing treatment in endometrial cancer. So you can go through this. So what I've already told, so we need to know now what are the eligibility criteria. When you need to do fertility sparing treatment for this group of patients, then what are the predictors of success? When you say this is a woman who will do good with this fertility sparing treatment, then what are the approaches? We may have a surgical approach, then we have hormonal approach. We can combine both surgical and hormonal approach, and also the receptor status and how it is associated with the surgical success. So these are the main eligibility criteria for conservative approach. The most important thing is that the woman should be in the reproductive age group less than 40 years. She should have a strong desire for fertility, and she should be reliable for follow-up. That's the most important thing. If you treat them and you lose them to follow-up, then all these patients will come back to you with a recurrent disease. So they should be very reliable for follow-up. Then about the histopathology, well, they should be grade 1, well differentiated. That is preferred for us if you are planning to preserve the uterus. Then absence of LBS are very difficult to see in the endometrial specimen, in the preoperative endometrial specimen. So I put a query, but then it said that it should be LBSI negative. Then regarding the molecular status, MMR positive, you can treat. They respond good, but then sometimes the recurrence is also higher in this. P53 positive, bad tumors. You cannot go ahead with the fertility sparing treatment. Pol positive is a very good marker for us. We can go ahead with the fertility sparing treatment. And PR positive, they say responds very good to progesterone, which is one of the modality of treatment for fertility conservation surgery. Then in the CT scan, which you do, there should not be any metastasis on CT scan. And one tumor marker we can do is the CA125. It basically they say that if the disease is spread outside the uterus, then the CA125 is a marker which can be elevated. So this is another thing. And the MRI, very important, one of the most important modality of investigation. There we need to find out whether there is any myometrial invasion, any cervical invasion, or any adnexal mass on MRI. These are the things we should be clear of. So this is okay. So now once these criteria are fulfilled, we go ahead with the management. So how do you do? We may have the surgical management, we may offer her medical treatment, and also the combined approach. So what is this surgical approach? Surgical approach, now people have been trying to do hysteroscopic resection. Hysteroscopic resection is used to resect the tumor, if you see, the adjacent myometrium and the underneath myometrium. You do the hysteroscopy, you see a small tumor, take it out. It is done in three strokes. First stroke, you just remove the polyp or whatever tumor is there. Then next stroke, you go adjacent endometrium, you remove 3 to 4 mm, and third stroke you make and remove 3 to 5 mm of the myometrium of that part. So this is our three. Next slide also. So what the advantage of this? If you see, improved accuracy of diagnosis, reduction of tumor burden, higher regression rate, and shorter time to regression. If you do this and then start with progesterone, then they have a higher rate of regression. What are the disadvantages? They say that it may affect future fertility due to endometrial destruction and intrauterine adhesion. But then if we put a intrauterine device after this, then the adhesion will be less. Many studies have shown a lower rate of combined therapy compared to progesterone alone. Okay. So now, this step I have told you. The first step, you see, we remove only the tumor, the green. The second step, the adjacent endometrium, 4 to 5 mm, we remove with the resectoscope. Third step, go deep, and the myometrium portion, 3 to 4 mm of the myometrium, you resect. That is the 3 strokes you make, and the whole the polypoidal type, whatever the early disease was there, you take it out. So now, once you have done that, next, now you know it is a well-differentiated endometrial adenocarcinoma, myometrial invasion is not there. Now we can add it with you can put two things. One, you can put a levonorgestrel intrauterine device containing 52 milligram levonorgestrel. Along with that, you can add with oral progesterone. The two progesterones are used. One is megestrol acetate, 160 to 320 milligram per day, or MPA, okay, 400 to 600 milligram per day. Previously, we used to start only oral here, but now if you are doing a resecting it out, then only levonorgestrel also you can try. Keep the oral for the future year thing. And if you are not doing any resection, because it is a widespread superficial disease, large area of the endometrium is covered, it is not possible for resection, then you can try add both. You put a levonorgestrel plus oral, you can start. Okay. So this is how. Give it for 3 months. So once you have given for 3 months, then with this intrauterine device in situ, put a hysteroscope, guided hysteroscopic, take a tissue sample. So now, after 3 months, when you have taken that sample, then again you put it for histopathological diagnosis. If you see that there is complete response, no evidence of disease now, continue for 3 more months. That is the total 6 months treatment. Then you do your repeat again, the same histopathology of the endometrium. 4 things will come. You may get a complete response in the biopsy report. You may get a PR, means partial response. You may get stable disease. You may get progressive disease. I'll come one by one. When to do what? So, during the whole these things, one important thing you should remember, weight control during fertility sparing treatment is highly recommended. Another important thing is that whenever you start any fertility sparing options, you should always tell them this is not a standard of care. We are just buying some time to give you a baby, and then once you complete a family, immediately the hysterectomy, definitive surgery should be done. So it is just a time buying option which we need to explain to the patient. That's why they should be explained everything, knowing all these things, then only they can go ahead with their treatment. So now, this is how I told you already, with the copper IUCD in situ, you can just go in with a grasp technique, you can take that tissue for endometrial biopsy. Okay, so now I told you there are 4 things which may happen at the end of 6 months. If it is a complete response, then that patient is ready to go for pregnancy. Generally, we ask them to go for pregnancy immediately. Ideal approach, they should go for ART, because in natural conception, sometimes it takes longer duration, and we know that disease may come back. So we want to finish our family completion as soon as possible. So we have to convince them that you go for ART, okay? If patient may be sometimes unmarried, so in those cases, you can put her the IUCD device and just put her on follow-up. Okay, how do you follow up? Every 3 monthly, you call her, do a clinical examination, ask for any complaint. If she doesn't have any complaint, do a ultrasound, MRI for endometrial thickness. So once these are clear, then she continues for the next 3 months. Like that, you go on continuing. But in the event, and once she gets married, get her children, one child or whatever, and then you finish the definitive surgery. Or another option is that patient on follow-up, suddenly she develops the disease. So now you have two options. Either you restart the treatment, again hormonal treatment, or you have to go for definitive surgery. I'll come to that also. Now, other thing what you can get is that you may get a partial response. Patient, they will have a biopsy where they have said the patient has responded, but some cells are still there, etiological cells. In those cases, you can continue the progesterone therapy. They say up to 12 months, but literature have said people have tried up to 15 months, not more than that. So you can continue with this progesterone therapy, and every 3 monthly recheck, whether it is going towards the curative side or towards the progressive side. Accordingly, you have to take your decision. Other one is that you have given for 6 months, now at the end of 6 months, the second biopsy, you got a stable disease. In those cases, you can increase the dose of progesterone. I told you, no, it is 400 to 600, or that 160 to 320 milligram. So here what you can do, suppose you have put her on LNG plus 160 milligram magistral acetate. Here you increase it to 320 milligram magistral acetate and 3 more months and see how she responds. Okay. And last thing that you may get is a progressive disease. In those cases, you have no other option. You have to do a definitive surgery in the form of total hysterectomy. Because you have already explained to the patient at any moment of the time during her treatment, you may land up with this situation, and in those cases, we have to go ahead with your definitive surgery. In that case, the fertility sparing option is not possible for you. So this is how the chart runs. Okay. So this is in simple here. Now, as I have already told, informed consent is very important. You have to always explain them. This is not a standard of care. Patients should be clearly informed that the conservative approach only aims to create a time window so that pregnancy can be achieved and should not be considered as a long-term solution to the disease. Regular monitoring is mandatory. Hysterectomy required after pregnancy is achieved. Then hysterectomy required once the pregnancy is achieved, or there is progression, or there is persistence of disease. So all these things I have told you, again I am reiterating for the fact that these are the things which needs to be explained to the patient very carefully. Now progesterone. I told you 2 progesterones, oral progesterones we give, MPA or magistral acetate, although we do not have any randomized controlled trial data as of now, but these are the 2 drugs that we generally give to this group of patients. Complete response rate was similar between MPA and MA, but recurrence rate reported lower for MPA treated cases. Progesterone containing intrauterine device delivers a higher dose of progesterone to the endometrium than oral progesterone and can avoid systemic complications associated with high dose of oral progesterone. That's why nowadays it is preferred that we always try to put a LNG insert and low dose oral progesterone. In case of the other situations which I told, then you go on increasing the dose of oral progesterone. So progesterone IUD used alone or in conjugation with other drugs. So these are the situations. This is how you give the progesterone, oral or oral plus IUCD or only IUCD, progesterone insert. Okay, now how do you monitor? I've already told, but still again, I'll tell you, first evaluation after 3 months, you've started the treatment, first evaluation of the 3 months. DNC preferred over endometrial biopsy except in those with Mirena. With Mirena, then only I told you, hysteroscopic guided, you can take it out. Just a guided biopsy. TVS evaluation if persistent disease at 3 months to rule out progression. Ideally, MRI can be done if you are suspecting a disease is there. Subsequent pathologic evaluation 3 monthly till remission. I've already told. Hysteroscopic resection biopsy to be avoided due to adverse impact on future pregnancy. There are some papers where they have told that destruction of the, because it leads to destruction of the basal layer of the endometrium, fibrosis, thermal injury to myometrium. So only if a small tumor is there, then I think we can do a resectoscope. With the hysteroscope, we can resect it out. But there are widespread area which is covered by this polyp or endometrial cancer, then it is very difficult. In that cases, if we do, then it becomes very difficult. And most important thing is that the weight management. As I've already told, that is very important part. You should always look after the weight management. Now, so what are the predictors of success? So I told you, grade 1, well-differentiated tumor. Very good response, generally we get. Low endometrial thickness. Lower is the endometrial thickness, higher is the chances of recovery from this and success of your treatment. Then if you see the hormonal receptors, ER, PR and pole positive. Pole is of course the ER. With NGS you have to do. So easily available is ER, PR. So if these are hormone positive tumor, they tend to respond better with the hormonal treatment. Again, I told you, younger is the age, better is the response. So that is there. And low BMI, less than 30, they respond better to the hormonal treatment. Again in MRI, if there is no myometrial invasion, of course, those with myometrial invasion, we generally don't tend to take them up for fertility sparing treatment, but if we are getting a no myometrial invasion, then those are the patients which will respond better. And last, but most important thing, it is always a MDT approach. You should sit with your pathologist, radiologist, everything, all team members should agree together, because the pathologist has to tell us correctly that it is a grade 1 well-differentiated tumor. So that also very important. That a lot of things will depend on the pathologist. Radiologists need to confirm that there is no myometrial invasion. That's the most important thing for us. So these are the things we reconfirm once again in the MDT, and then once everybody is satisfied with all their reports, then only you can convince this woman, counsel her, and then you can go ahead and start this treatment for this group of patients. Well, now, impact of molecular type on fertility preservation. Of course, molecular typing is not available in many parts of the world, but then we can try to do as much as possible. If you see ISC, those centers where they have ISC facility, you can look for all these MLH mutations, and then P53 can be done by ISC. However, pole cannot be done by ISC, that needs the NGS. So now, if you have a facility, if you know the pole status of the patient, if the pole is positive, that is a very good patient. You can always go ahead and start fertility treatment for that patient, for that group of patient. If she has one of these 4, MLH1, MSH2, MSH6, PMS2, then these are the patients that respond to treatment, but again, the recurrence is also very, very fast. They come back, trying to come back. So they should be under constant follow-up if you know that this patient is MSIH. Then P53, I told you, these are the tumors. If P53 positive, then we generally discourage. They should not go ahead with the fertility sparing treatment for this group of patients. They do not do very good with this marker being positive. And in NSMP, standard fertility sparing protocol may be applied with individualized follow-up. Okay? So these are the things as far as these markers are concerned. Now, surveillance after remission. You have done a treatment, you got a good response, complete response. What will you tell to the patient? I've already told, but then again, periodic interview to explore any symptoms. Every 3 months generally we call them. We do a physical examination. Then transvaginal ultrasonography at 3-month interval. When during follow-up, you should do TBS, ultrasound, but if there is any complaint, immediately you do not depend on complaint of irregular bleeding and all this, do not depend on ultrasound, that MRI, if there is any complaint. Otherwise, a routine ultrasound. Periodic pathologic evaluation of the endometrium using office endometrial biopsy, DNC biopsy or hysteroscopic not recommended in patients who do not have any symptoms or signs. On follow-up, every 3 months you call, clinical examination, then a TVS, and then no complaint, liver. If there is a complaint, MRI at the same time you add up with a guide-directed biopsy sampling. If desired pregnancy, ERT can be attempted. I have already told, because we don't want to spend much time once we treated her. We want to, that the window that we are getting, we want to achieve a pregnancy during that window, and so that she completes her family. If there is a planned delay in pregnancy, then consider OCP or low-dose cyclic A or continuation of Mirena. Generally, if she is unmarried, then generally they will ask for the oral contraceptives, the OCP, low-dose oral progesterone, and if she is married, and then sometimes they opt for this LNG also. Now, completion surgery to be done at the end of childbearing. That you should not forget. Even if there is no evidence of disease, once the childbearing is complete, we do go ahead and do the definitive surgery in the form of hysterectomy, plus minus bilateral salpingo-oophorectomy, which we'll discuss. So now, response confirmation, I told you, after 2 consecutive complete response endometrial biopsy with a minimal interval of 3 months are necessary to consider success of fertility. After 6 months, only you can tell that, okay, we have succeeded, and now you can go ahead. Using ART, I have told you, that shortens the time of conception and avoids prolonged anyway, this I already told. Now, recurrences. So, what are the risks of recurrences after fertility sparing treatment? So, this woman we have treated, now they will come a follow-up. So, you see there is a high risk of recurrence, almost 40%. Whatever literature we have currently, they have suggested there is almost 40% chance of recurrence in this group of patients. So, that's why we have to counsel them to complete their family as soon as possible. Now, suppose you have detected recurrence, what you can do? You can again restart that fertility sparing progesterone hormone, but you have to tell them that the next recurrence will come sooner. So, of course, at the first recurrence, it is not always here that you need to go ahead with a hysterectomy. Even then she has not achieved her pregnancy, then you can go ahead and restart the progesterone therapy at a higher dose. Many recurrences after fertility sparing treatment were of short follow-up after cell-based therapy. Therefore, mortality rate could not be mortality we do not know as of now the mortality in this group of patients after the first recurrence, but then because very few literature is available on that. But then definitely if you are treating a patient on the recurrence, in the recurrent setting, then you know that these are the patients, so they may need definitive surgery at a date closer to the year. Now, reproductive outcome. So, we have treated with the sole intention that they should achieve a pregnancy. So, what is the reproductive outcome? According to systemic review of 32 studies with 408 endometrial cancer patients with fertility sparing treatment, 76% of the patient regressed, and there was a live birth rate of around 28%. Okay. Now, ART could be introduced for this group of patients with a history of ovulation or fertility sparing. Of course, there are many patients who will go to the infertility specialist, diagnosed there, and then you treat her for this with these options. And once you have treated, immediately you send her back to the fertility specialist to get her a pregnancy. Now, patient with atypical complex hyperplasia and endometrial cancer with fertility sparing treatment, those who received ART had a 40% chance of live birth compared to those group where it was naturally conceived, where they have a year of 14.9%, who tried spontaneous conception. So that's why you can see that it's a huge difference. So you can see you should prefer the ART for this group of patients. And relapse rate did not worsen from the hyperestrogenic state by ART. People suspect that once you are going for ART, you will be subjected to this hormonal treatment, and does it affect my ear? But it is not there. So now, prognostic indicators of reproductive outcome, if you see, ovarian function at baseline is very important. Age of the patient, lesser is the age, higher is the chances of achieving a good response. Obesity, more than 30 BMI is a bad thing for us. PCOS along with obesity is again bad, those do not respond very well as for the other group of patients, and those patients where there is a Lynch syndrome, in those group of patients, they do well, but then again it comes back. So you should be aware of that. Some gray areas. So I've told you the grade 1 is good with us. So higher grade, do not have any children, they may insist, but then there's a gray area, you have to decide. You have to discuss with the patient what you can do for this group of patients. Again, there may be a mild myometrial invasion, what you do. So as per here, we cannot do, but then this patient may insist. So these are gray areas which are not there in the, you have to take a case-to-case basis, explaining everything. So these are things which cannot be here. Receptor positive show good response but have higher relapse rates in some studies, but small number limit independent. So those who are receptor positive, they say that they respond well, but then again this comes back once you stop the treatment. So that is also there. So this group of patients, you need good counseling and continue that treatment till you achieve a pregnancy. Retreatment for relapse in patients who have not had a successful pregnancy. Once you retreat I've told you, there is an option of retreating. On follow-up, she got a recurrence. You can restart with progesterone therapy. Response rate is 50 to 100%. That is a wide range. And relapse rate is also almost 50% in this group of patients. So this is the thing. So now, definitive surgery. As I've already told you, definitive surgery forms a part and parcel of this group of patients. You should explain them very nicely. So when do you need that definitive surgery? One thing is that definitive surgical treatment consists of total abdominal hysterectomy with or without bilateral salping oophorectomy and surgical staging. So now, this is recommended after childbearing due to a high recurrence. Recommend after completion of childbearing, which I've already told. Once childbearing is complete, you complete the treatment. Again, during follow-up, there may be a disease reappearance or progression of disease, that time also there. So, in case of recurrence, no response at 6 to 12 months, maximum 15 months of hormonal treatment, as well as in cases of disease recurrence, either in uterus or elsewhere. So, these are the situations where you need to stop the year and you need to finish the year. So, now, the fertility sparing treatment summary, if you see, well-differentiated endometrial adenocarcinoma, strong fertility desire, no myometrial invasion, assessment is receptor study you can do, MRI very important, options, high dose oral progesterone, hormonal IUCD, plasma GnRH analog, few studies have shown, completion surgery after childbearing. Now the ovarian preservation at primary surgery, these are young patients, whether you need to do ovarian preservation or not. Well, 5-year survival rate more than 90% in early stage disease when you treat them. So low incidence of ovarian metastasis, avoidance of menopausal symptom if we do a ovarian preservation, positive impact on the cardiovascular, bone and CNS cell, and better quality of life. These are the things which goes in favor. Now concerns. Suppose you want to preserve the ovary, we know that around 5 to 6.5% usually cases with high uterine disease, there is a missing out on the occult metastasis. Around 5% of the patient may have occult metastasis. The risk of relapse of hormone sensitive endometrial primary, theoretical relation is there. No robust evidence of safety based upon prospective clinical trial. They have shown that there's a large cohort study which analyzed 3,200 women. Findings suggested that ovarian preservation in premenopausal women with early stage low grade endometrial cancer might be safe and not associated with increased risk of cancer related morbidity. So as of now we stand that if it fulfills all these criteria, grade 1, well differentiated, no myometrial invasion, we can leave the uterus, if we ovary, if we want to do a definitive surgery. Deciding factors, removal of the ovary should be individualized according to the patient's age. Young age, we can go ahead. It's around perimenopausal age group, then definitely we can remove. Probability of ovarian involvement is another, you have to see what is the probability of ovarian involvement. Again, if the patient has a family history where you know, then these are the patients where you go more in favor of taking out the ovary, and presence of adnexal mass, of course you will remove it. In case of ovarian preservation, salpingectomy, if you are planning for a ovarian preservation, salpingectomy, you go ahead and do the salpingectomy in this group of patients. So wrap up is that the ovarian preservation is highly individualized. Patients who desire ovarian preservation should receive a full explanation of the potential risk. Genetic test may be necessary in patients with a family history of related malignancy, not suitable for endometrial cancer patient with extra transplant. Careful intraoperative assessment of the adnexa is also mandatory. HRT, last slide. Currently, there is insufficient high quality evidence to inform women considering HRT after treatment for endometrial cancer. Now, the available evidence, both single RCT and non-randomized evidence, does not suggest significant harm if HRT is used after surgical treatment for early stage endometrial cancer. Now, the use of HRT after endometrial cancer treatment should be individualized, taking into account the woman's symptoms and preferences, and also considering molecular subtype and recurrences. If you want to use, then either estrogen alone or EP combination, which generally used. Thank you.
Thank you so much, Professor. 2 questions have come online. The first, I think you've tackled this, but please handle it again. Up to how far number of pregnancies is acceptable for such patients after all these interventions?
How many number of pregnancies?
Yeah.
Yeah, I think one should be good enough, because we know most of the patients will come back to you once after the first pregnancy, if you try to extend the year. Yeah. Think I'll opt for 1. I'll counsel her for 1.
Then hysterectomy.
Yeah. Then hysterectomy.
Correct. Then is there any role in management of endometrial cancer with immunotherapy for such patients?
Immunotherapy, these are actually, very early stage cancer. As I was told, hormonal therapy is good enough for them. So I have not come across any paper where they have started immunotherapy for this group of patients. Because it is simple treatment. You give hormonal treatment, and then she will take orally, and then immediately, and another important thing is that immediately after stopping that hormone, we counsel them for pregnancy. So the question of immunotherapy is not there.
Thank you.
That is where you can give immunotherapy. There. In this sort of early disease, there is no.
Okay, I'm sure because of time, I'll allow one question. And then for those that have other questions, please just put them down. At the end, we'll still come back to the questions.
Thank you very much for such an interesting lecture. I've not seen this practice before. I'm just curious, in your own practice, how many patients have you seen offer this? How many have been successful? This kind of practice?
The counseling is very important part, I'm telling you. There are many, but I do have currently 5 patients who are undergoing this treatment, and I have 2 patients who have achieved pregnancy and came back to us with and then we offered them here. One patient, she was not achieving pregnancy even with the IUI. That patient we had to undergo. She had adopted a child, and then she told that don't want to take any more risk. So I had done a definitive surgery for her. She adopted one boy. So that is what. Otherwise, it is you can see very good response. There are some patients who works after 3 months of treatment. The first biopsy that we do once we start the treatment, after 3 months, we got you can see negative. If she fulfills all those criteria, they respond very nice, very good. I think every quarter we see 2-3 patients, all referred by the infertility specialist to us. So mostly they come from the infertility specialist. Mostly.
I want to say family planning. Tuber ligation or tuber, fallopian tuber removing.
I don't get your question.
The problem is in family planning, they used to take the fallopian tube and you do ligation or removing. What's your position? Because when you have an endometrial cancer or ovarian cancer, it can go to the fallopian tube.
So I told you, suppose you are planning to keep the ovary, then it is better to take out the fallopian tube, self-injectomy. The tube I need to take out if you are planning to keep the ovary. Otherwise, so both we remove. I don't know whether... tubectomy. Okay, you are telling that during tubectomy, instead of tubectomy, whether you go ahead with the self-injectomy. That's what you are telling. Patient has a family history of this genetic mutated cancers, then definitely I will prefer doing a self-injectomy. Nowadays that study has come, no? One is that oophorectomy, or you do a self-injectomy till 40 years and then you remove the ovary. There is one that tuba trial or something. The 2 trials people are working on that. So, but that is what. So, if patient gives a family history, strong family history, you know, and if you have a germline mutation in those group of patients, then definitely I'll take out the tube. I'll counsel her for oophorectomy, means removal ovary and the if she tells that, okay, I want to wait for some time, then we take the tube and keep it till 40 years and then you remove. That is one.
Maybe his question is, in a routine family planning.
Routine family planning, I don't think it is, no. Tubectomy, instead of tubectomy, self-injectomy. I don't know that I don't practice that but maybe I don't know. I can throw some light on that because we see only those patients who come to us with this. Maybe as an obstetrician, if you practice obstetrics, then maybe these patients may come to you. But then I definitely will look into the family history and the germline mutations in this group of patients who wants to take a. But as a routine, I don't know. In these patients who wants family planning. Okay, so but then it is a very easy technique. You can always do it. very easy technique, but scientific, I'm not aware because I don't get to see this group of patients. Yeah.
Thank you.
Thank you.
So now we will have Prof. Devayani again, who's a thoracic surgical oncologist. So she'll be taking us through improving surgical outcomes in cancer care.
Good afternoon, and I'll try to keep this short and crisp. So we may all do fantastic surgery and be very happy with what we've achieved at the end of the OR, but the truth is the patient needs to go home and go home well and get back to her or his daily life, and in most cases adjuvant treatment. So why is cancer surgery so different? It is not like any other surgery because we believe in the Holstedian principles of radicality. R0 resection is a must if you're operating in cancer, which often means that you have to remove the entire organ, sometimes surrounding organs as well. These surgeries are long because you end up doing a thorough lymphadenectomy along with your primary specimen. And a lot of times these surgeries come with reconstruction. Like if we do an esophagectomy, you would do a stomach pull through to reconstruct the esophagus. If you do a head neck surgery, you might put in a free fibula to reconstruct what you've removed. So the patient has to not only recover from the insult of surgery, but she or he also has to get used to a new way of living with these new changes that we put into their bodies. And because these surgeries are long and technically demanding, they have higher morbidity and mortality compared to normal non-cancer surgeries. Our patients with cancer are also different. They are physically, nutritionally, and mentally deconditioned because of the diagnosis itself. And they have long treatment plans. So surgery is usually just one component of their entire treatment. They would need to undergo systemic therapy, radiation, either before or after. So they have a long course to travel. It's not easy. So the surgery is the simplest bit. The most complex thing is how do you decide when and how to operate this patient. So it's never the decision taken by one person. It is usually a multidisciplinary team. And this is the team that manages a single lung cancer patient at the Tata Memorial. And these are all the people involved in the decision-making process. Of course, the most important being the patient himself or herself. So how does an MDT benefit? There's evidence to show that discussing an oncology case in the MDT actually changes the decision in 20% of the times. That is, in 1 in 5 cases, discussing this case with your colleagues from radiation, medical oncology, the radiologist would change what you choose to do for this patient. It also shows that the adherence to evidence-based is much better when you're discussing a case in the MDT. The patient gets satisfied seeing that there are so many people who are sitting together and putting their brains together for the treatment of the patient. It's an excellent opportunity for training everyone in the room. And also, it's so easy to just tell your colleague that, okay, I need a repeat biopsy, can you take care of this? And it ensures that it gets done quickly and seamlessly. Everyone is on the same page. So this is a study which put together 59 studies. It was a meta-analysis across all cancer types. Discussing a patient in the MDT actually improved their survival quite significantly, with the hazards ratio being 0.7. And patients who were repeatedly discussed in the MDT after every point of their treatment did better. All this improvement was attributed, one, to better staging because you had the radiologist and the pathologist in the room as well, personalized treatment for every patient, and timely interventions with reduced delays. So once a patient has undergone MDT and we decide that yes, this patient needs surgery, the next step that the patient undergoes is prehabilitation, which is a proactive approach to optimize their physical and psychological well-being before surgery, aiming to improve recovery and reduce complications. So a lot of evidence has come up regarding prehabilitation in the last decade. This I found most impressive. It is the PREPARE program from the Imperial College London, which very beautifully encapsulates every component of prehabilitation. It is physical activity, so our patients undergo aerobic as well as resistance training. respiratory exercises, each of them gets an incentive spirometer. They go to the nutritionist to evaluate their nutritional status and intervene when necessary. Psychological well-being, so they also see the psychiatrist in order to assess what are their vulnerabilities and to treat them for that. They usually have polypharmacy. All these are old patients, so all their comorbidities are well optimized, whether it's diabetes, heart disease, blood pressure. De-addiction is an important component because many of these patients are smokers or are dependent on alcohol. Finally, all this leads to enhanced recovery. And in countries like ours, one more thing that we need to really think about is the financial support, because treating cancer is not cheap. It is very, very expensive. And if you take only part of the treatment, it is as good as taking no treatment most of the times. So we need to make sure that the patient has adequate financial support to go through the entire treatment process. So once this is done, the patient has undergone a prehabilitation program. We have something called a high-risk joint clinic, which we conduct twice a week at the Tata Memorial for Thoracic. And the patients here are referred either by the surgeon, the anesthesiologist, or the pulmonologist, whoever sees this patient and feels that they are at high risk for surgery. So almost 30% of our patients undergo a high-risk joint clinic, where we sit with the patient, the family, and all these people that I just spoke about, and we objectify the risk that the patient has for this particular surgery, whether there are any other alternative forms of treatment that we may offer to the patient. And this improves the involvement of the patient and the caregiver. They actually understand the implications of what this surgery means to them, and then they can take an informed choice whether they want to go ahead or not. So these are the scans. So, if we see a coronary calcification like in the image here, or if you see bad lung fields, these are typically the patients that would be discussed in the high-risk joint clinic. Also, if the patient is 60 years or older, they undergo one visit to the geriatric clinic, where a comprehensive geriatric assessment is performed. The life expectancy is calculated. The risk of this particular patient for surgery and chemotherapy is also assessed. And in our study, we found that 98% had vulnerabilities at least in one domain. More than 50% of the patients were taking multiple drugs for comorbidities which needed to be streamlined before they came on table. All these things are done before the patient comes up. And here I would like to thank Dr. Vanita, because she spearheads the geriatric program at the Tata Memorial Hospital. Once all this is done, the patient now has finally come to you. It's the day before surgery. And like we have been taught, surgery is in the planning, not so much in the doing. So we see the scans carefully, we go to our radiologists, sit with them and try and get the minute details of whether it's resectable, which vessel are we going to get into trouble with. And we use technology. So in cases where we are planning to perform, say, a segment, we do a 3D reconstruction of the image, find out whether the tumor is indeed in the segment that we plan to remove. So this is a tumor in the carina, in the main airway. We sit with our anesthesiologists and the radiologists and decide, okay, what kind of tube are we going to place for this patient? At what point are we going to switch to an in-field ventilation? And finally, we plan the approach for surgery. So I'd like to show you this case. It is a 28-year-old gentleman with a non-seminomatous germ cell tumor of the testes. And he came with 2 large tumors in his body post-chemotherapy. Tumor markers had normalized. There was this huge mass sitting in the left side of his chest and an even huger mass sitting in his abdomen. And both needed to be addressed because the tumor markers are normal. There's no more chemotherapy to be given. This needs to come out. And we had to sit and discuss how to sequence, what would be better, which one should we do first. And finally, we decided to do the thoracic bit first because the left lung was of no use anyway. And the idea was that if we get this big tumor out, maybe the right lung can perform better and maybe he'll be fit for an abdominal surgery. So he's been discharged yesterday and he's doing well after the thoracic surgery, and he awaits surgery for the retroperitoneal mass. As we go ahead, we are starting to realize in surgery that less is actually more. More and more we are shifting. So when we see the biology of the disease, it's no longer about oblong excisions like the breast, the pectoral muscles, the chest wall. You don't need to do all that. You need to understand the biology of the cancer, treat it systemically first, and then bring them to the operating table. We are looking at smaller incisions like laparoscopy, VATS, robotic surgery. Like we spoke previously, it makes surgery less painful. It gets your patients out of the hospital faster and back to their adjuvant treatment. Precision has improved using fluoroscopy, navigational techniques within the operating room with integrated CT scanner machines, etc. in the OTs, but we are far away from that, but it's something that we need to aspire to. But we have started using simpler things like the ICG or nerve monitoring while performing our resections, which definitely improves our outcomes. Resections are also getting smaller. People are moving from mastectomies to breast conservation, to sphincter-saving surgeries in colorectal cancers, to segmentectomies in lung cancer. So we are trying to see how we can do less and less and improve outcomes for our patients. ERAS was a program that was conceptualized by Professor Henrik Kellett in Copenhagen, and it has gained popularity not only in cancer surgery, but in all surgeries all across the world. It is for optimizing recovery by reducing surgical stress and inflammation. And in oncology, what it helps to do is get our patients back to their oncological treatment and adjuvant treatment early. These are the components. It has parts in preoperative, intraoperative, and postoperative. So for example, if we are prepping a patient for an esophagectomy, we follow ERAS by admitting them just 1 day prior, no prolonged fasting. They are allowed to have their dinner, no food after midnight, and we allow clear liquids till 6 a.m. of the surgery, so that they are not in a fasting state when they reach the surgical table. They're adequately counseled about the surgery, the expectations of the postoperative course, a thorough consenting process, optimization of all their comorbidities. They are taught the incentive spirometer at least 1 week in advance so that they know how to do it in the postoperative period. Intraoperatively, we try and do minimally invasive surgery wherever possible. We avoid an epidural and give them good alternative sources of analgesia so that they can get out of the hospital faster. We keep them less on fluids. We prevent hypothermia. In the postoperative period, our esophagectomy patients, the surgery lasts for around 6 hours, but they're made to sit up in bed on the day of surgery in the evening. We give them their spirometer. We ask them about their pain scores and get the pain team involved if there is any pain. By next day, they are out of bed and moving around in the recovery, and they are started on orals by day 2 and on full diet by day 6, which is when we aim to send them home. So this is in keeping with the ERAS protocol. It has shown to, of course, decrease hospital stay, decrease surgical or non-surgical complications, especially pulmonary atelectasis, earlier return to oncological treatment, improved survival, and improved quality of life. So, these are not expensive things. It's just a change, shift in the way we think, and it does wonders for our patients. Technology in the OR is improving all over the world, better sterilization techniques, better vision, better precision, better anesthesia machines, so monitoring their physiology becomes easier. Surgical equipment has improved, staplers have come in, but it's also the not so technical bits that we need to streamline if we want to improve outcomes. There has to be improved communication in the OR between the surgeon, the anesthetist, the nurses, and the technicians. There have to be surgical safety checklists like the WHO checklist that we use while performing our surgery. And we have to be prepared for disasters, whether it is airway loss, like in surgeries that we do, or massive transfusions, which may happen in any cancer surgery. And we need to have protocols in place as to what to do if one of these things happen, which I think is more important to improve outcomes of our surgery. Other than surgery, to improve outcomes, other therapies have also advanced. There's SBRT, there's a proton therapy coming in, there's NGS-guided systemic therapy, which my colleagues have spoken about, and of course there's immunotherapy coming in all cancer subsites. Surgery is teamwork, right? So there has to be referral. Major oncological surgeries have improved outcomes at high volume centers. So say if you see an esophagus or a pancreas and your institution is not doing so many of these, you may be better off referring these patients to institutes that do more of these surgeries every year. You may encounter some post-op complications where we are unable to take care of them at our center. There should be no hesitation. In fact, there should be a system in place to be able to refer them to people who see this more often. For this, there should be an integrated network for surgeons offering cancer surgery, and we have to be honest with ourselves and our outcomes. There have to be periodic surgical audits, and comparing with peers, we should not feel shy about discussing our complications with our colleagues. Maybe if we discuss it, you may avoid the next one with someone else. And I think that freedom of speech should be something that we should encourage. Every surgeon needs a mentor. We have all learned from someone above us. It is not a skill that you can purely acquire by watching videos or reading textbooks. It helps us to standardize techniques, making them safe, efficient, and reproducible. In today's world, you could also have a telementor, which could work just as well. Robotic surgery is becoming remote. The first lobectomy was done in Spain via China, so that's going to become a reality very soon. Simulation models are available for most major surgeries, and the pandemic gave us Zoom and Skype, so global exchange has become very, very simple. It does not come without its challenges. There are socioeconomic gaps in care, as we are well aware. There is lack of standardization, and there is lack of honest auditing, which is something that we must address. Surgeon burnout and mental health is also very important, and it's not spoken about often enough. And many times our patients themselves have unrealistic expectations of what they aim to aspire at the end of surgery. It could also be the caregivers. So the consenting process has to be very, very robust. In conclusion, it's time we synthesize technology and biology. We have to prioritize access, equity, and innovation. So innovation does not necessarily have to come from the West and then we adopt it here once it becomes less expensive. I think it's time that it comes from us as well. We have to study the cost effectiveness of whatever intervention we are doing and actually analyze how much it is improving the life of the patient that we are all wanting to treat. And we have to remember that the patient is the most important person in this entire process, and it is the agency of the stakeholder. It has to be his or her decision to move ahead with whatever treatment we've planned for them. Thank you very much.
Thank you so much, Prof. Any question?
Clinic is very important, especially for us in the low resource settings for the HR, and then of course where we work, we're also seeing older patients. So I think the geriatric aspect to care may be something also need to improve. Since my boss is also here, so.
Yeah, no, great, very different topic that you took, but very interesting one. One thing that is very important in surgical, like you told, in oncological surgery is the timing of treatment, right. Timing of surgery, because many times in most of our high volume centers or even centers where they don't have people at that time, things get delayed and
Correct.
then the whole thing, you lose a lot of, basically
Absolutely,
time.
absolutely.
So that is one other important thing, and very importantly, other thing which we don't talk about is the perioperative treatment. When you operate and then by the time you start your next treatment, how soon you can start the next treatment, because many times, once you operate, whatever remaining cells are there start dividing, the Gompertzian curve, which they come on the exponential phase. And then if you don't start the treatment within time, again, then you lose a lot of, good work that you already done before. So these are another important things which is very, very important in oncology, which sometimes we do overlook,
Absolutely, yes, sir.
Yeah, mine is just a comment and a challenge in practicing at a lower income level. One of the things you added in the prepare was the finances, and I think that's hindering us significantly, and many people are not referring to this. You come to a country like Tanzania, for instance, for many years people have to travel all over the country because there's only one cancer center and with no financial support. So you give one cycle of chemo, normally not to standard what is available, and then they disappear. And you think it is toxicity, but it's because they cannot afford to continue staying. and the treatments are longer. So I think one of the things we are missing is that advocacy aspect, what can be taken closer to the patients, because not all patients will need radiotherapy. Right. Chemotherapy can be delivered wherever there is a well-structured hospital. And that's what we are advocating for now, to have all our regional hospitals being able to offer chemotherapy at least, because then it will be a little bit closer. They can go back to their village when they are waiting for the next cycle than keeping them in town. So that's one of the greatest problems we have. The other one is, who do you decide to treat? Like, I feel like we are administering more chemo in the palliative setting, and when we have patients who can benefit from cure, then we have run out of chemo. And that's a very difficult decision to make, because we don't have guidelines that tell us you should not give chemo, because all our guidelines, whenever I want to make a guideline, some high-income country partner will come and say, yes, I can help you make it, and then they make you adapt theirs. But that's not convenient to our settings. Like, we are trying to make a sub-Saharan guideline. It was a competition between US and Europe, which one is taking a lead on how you make your guidelines. So I feel like we have not used our local context to guide our guidelines. Something I saw at Tata, you have localized the guidelines to your context so much, and we have failed. So while we are spending very little in health, but we want to offer services like somebody was at MD Anderson. Now we have a PET scan, while we can detect our metastasis by X-rays. Exactly. And why do you have a PET scan before you have radiotherapy in another center? So these are also not well guided, because somebody comes and tell you, yes, this patient needs a PET scan, but you don't have the basic cancer care in another. That's why we have somebody trying to offer surgery, but or a surgical oncologist, but no pathology. So are you even sure this is cancer? Right. Because that's also a big problem we are having. So I look at it like we need a reset of mindset with us who have been exposed in oncology, form advocacy groups, and try to have localized guidelines without foreign interference. You seek support but not intervention, so that we develop what works for us. We move one that is easy at a time. So like, we have a national guideline for the first time, but we covered all cancers. And so 5 years come, we have not implemented anything. And I feel that's a problem. And many times these guidelines only address the oncology, the chemo aspect. And they are not talking to me as a surgeon, what type of breast cancer surgery should we offer now? It's just saying, offer mastectomy. Which mastectomy? Do colon resection. Which colon resection? So the guidelines are only talking on the regimens of chemotherapy that needs to be given, and immediately you realize there's an industry interest in this. So these are one of the biggest problems that we have. Thank you.
Actually, the problems that we face are also very similar, sir, both. So to the first comment that you made about patients taking their systemic therapy closer to home, we actually encourage that. So if I had to look at my data, almost 70 to 80% of our patients come from outside the city, and almost all of them are given referral letters with protocols of the chemotherapy and radiation. And by now, we have also formed a network of people all over the country. So we give them a specific name and number as to, this is the person you need to meet near your hometown, take this chemotherapy and come back to us on this date. So if that can be replicated from where you are, maybe that is the way forward. And for your second comment, about guidelines. So we have the NCG guidelines currently in place, and I like that they have divided the guidelines for every cancer into 3 sections. So the first section is ideal, which is the way the Western world sees the guidelines. Like, if you had no resource constraints and all the money in the world, this would be the guideline. The second one is good guidelines, that is, which balances the ideal and the basic minimum, which is when the resources are there but not enough to waste. And the third one is absolutely necessary, like this is the bare minimum and at least this needs to be done. So yeah, so I think that would bring local context into guidelines for.
Thank you so much. I think she deserves an applause. Thank you so much.
Thank you so much.
I know there are burning issues, but because of time, allow me to proceed. Let's.
Thank you very much for this presentation. Mine is on the errors. I mean, it's intriguing to see how aggressive you are in terms of your errors protocol, and in specifically talking about feeding on day 3. So is this a patient you're doing oral feeding or tube feeding? Because I delay my, I mean, we are a low volume center, and I tend to delay my feeding till day 7. I'm just scared to have any mediastinal leak.
Yes.
And you do yours on day 3. Wow.
Yeah. So we put in a nasojejunal tube for feeding, and that starts on day 0, that is on the night of surgery. By day 3, they are on clear liquids. By day 4, they are on liquid diet. By day 5, they are on soft diet. And day 6, they are home. So that is what we follow. But also, we are able to do this because we have a very, very good ICU setup, and our residents are also very well trained in picking up a complication. So I think, sir, if you are, like you said, from a low volume center for esophagectomies, I would do what you're doing, because we all know that a bad leak can be catastrophic. And we are comfortable in doing this because we have systems in place to pick up complications early before it becomes fatal for the patient. So I think this would work in a high volume center, but in a low volume center, not just the surgeon, but even everyone else who's involved in the patient's post-operative care, if they're not used to seeing these patients, I think the way you're going would be the way to go.
Thank you again, ma'am. Thank you so much. Gives me pleasure again to invite Professor Dr. Jaya Ghosh, who's a medical oncologist from the great Tata Memorial Center. And she's going to speak to us on the management of chemo-resistant GTN, or gestational trophoblastic neoplasia. Ma'am, welcome again.
Thank you. Thank you, and thanks again for the opportunity to speak on gestational trophoblastic neoplasias, because these are again cancers in young women with a very high cure rate. So before I move on to chemo-resistant GTN, I'll just take a small overview on the GTN and then move on to the chemo-resistant ones, both in low risk and high risk. And we are all aware about the staging for GTNs, and that, you know, lung mets stage 3 in GTN and not really stage 4, and all other sites are stage 4, and even for stage 4 disease, we could potentially achieve a cure of around 80 to 90%. And important is to understand the risk stratification for GTN, and it's not really necessary to keep this in mind, but to go back and look at the table and be able to risk stratify. And just one point while I'm on this is that this pre-treatment beta-HCG is the beta-HCG at the time that we are starting the treatment. So say, for example, a patient had a beta-HCG which was more than 1 lakh prior, I mean, at the time of diagnosis of a molar pregnancy, she gets a suction evacuation done, it drops down to 500, then it, you know, continues and there is a plateauing of beta-HCG at 300 or 400, then the value of beta-HCG that you take here is the one that after evacuation at the time of plateauing, when we are starting treatment, that is the value that is to be taken for that, because that's a, you know, common difficulty that we have, so I just mentioned that. And of course, based on that, we risk stratify based on the risk stratification factor into a low risk if the score is less than 0 to 6. If the score is between 7 to 12, these are high risk, and more than 13 these are the ultra high risk. Now, why we need to know this is because a low-risk patient can be treated with single-agent chemotherapy, which is a single-agent methotrexate or actinomycin D. A high risk, we all know, need multi-agent chemotherapy. But what is most important is the ultra high risk. These are very high risk patients, somebody with extensive lung mets, beta HCG close to 30-40 lakhs. So those are the patients, they have a very high chance of bleed and a very early mortality. So even though we know chemo cures, but with chemo patients bleed also. So that is why these patients, we first give them pre-phase or a low dose etoposide cisplatinum and 1 or 2 cycles weekly, and then once they stabilize, they go for standard dose chemotherapy. So it is important to know that very high risk or ultra high risk patients or those with extensive metastatic disease with high chance of bleed, we need to consider them for low dose EP. And of course, if we have these very high risk patients, if we have a high volume center nearby, we do refer to them or at least get in touch with them. So once we have decided that, of course, we have treated our standard management, and then we decide that there is resistance to the standard management. So how do we define resistance? Because the talk was on chemo resistance. So whenever we are treating gestational trophoblastic neoplasias, we look at the log reduction in the beta HCG. So if it was 10,000, has it come down to 5,000, or is there a log reduction? But if there is no log reduction and there is an increase in beta HCG despite 2 courses of therapy, or there is a plateauing, that there is less than 10% fall over 2 weeks, then in 3 courses, so by 3 cycles basically, so then we call it as plateauing of beta HCG, and then we consider it as resistance. If this happens in the beginning, that's primary resistance. If it happens subsequently, we call that as acquired resistance. Okay, so before we move on to chemo-resistant GTN, I would just like to make 2 points about how do we go about treating the low-risk gestational trophoblastic neoplasia. So usually, these are, suppose somebody post a molar pregnancy, young lady, no other site of metastasis, disease confined to the uterus. That's like a very classical picture of a low-risk GTN. She comes 6 months or 7 months after evacuation for a molar pregnancy with a beta HCG which has not normalized. So how do you treat them? So usually single agent methotrexate is the one which is most commonly used at a dose of 1 milligram per kg on day 1, 3, 5, and 7, along with leucovorin 15 mg tablets that we get on alternate days, day 2, 4, 6, 8, and we give this every 2 weekly. Now this is a fairly simple regimen to use, can be given on an outpatient department, but what we do need to check for is look at their creatinine, look at their albumin, and of course their overall nutritional status. Always have kind of blood in reserve because they might bleed suddenly. So, and of course warn them that if they have increased bleeding to come back to you, and so that they're nearby. So that is important. And we have another drug called actinomycin D, which also can be used, and this is of course again a 2-weekly regimen. So between the two, when we compare the biweekly methotrexate, that has shown to have a greater response rate, of course less hair loss, because this is a chemotherapy which we assure patients, young women, post a lost pregnancy. So we at least assure them that there is no hair loss, which is again a stigma. And of course, though there is an increased incidence of mouth ulcers and eye watering. Okay, and how much is the response rate? It's a busy slide, but just to show that if you, low risk is again a range from 0 to 6. So if you have a low risk patient who has a score of say 1 to 2, so that patient, the probability of response is close to 70 to 80%. Whereas, if you have something which is a score 5 or 6, this drops down to 30 to 40%. So that is what is there. Of course, these patients can be salvaged by a second line, either single agent chemotherapy or a multi-agent chemotherapy, and overall success rate is close to 100%. But to the first line, it is anywhere between 40 to 70. So if I have a low-risk patient who has had a first-line treatment with single-agent methotrexate, and now we see that the beta HCG is plateauing, so what do we do? Do we treat this patient with another second-line therapy, which is like actinomycin D, or do you use a multi-agent chemotherapy with imaco? So how do we choose between the two? So if they fail on single-agent methotrexate, and they have a plateauing of beta HCG, as I will discuss later on, between which is, the beta HCG has plateaued at say 300, 400, 500. There is no metastatic disease elsewhere. It is not a choriocarcinoma. One could use single agent actinomycin D. So failure to one single agent, you can move on to another single agent. And it has been seen that, of course, it is important to remember what all are the exclusion criteria, because extensive metastatic disease, choriocarcinomas, if there is a long delay in forming this, so they are all, the exclusion. That is not a place where I would use a single agent chemotherapy. And yeah, this is the same, that usually these are, beta HCG which is less than 1000 if they have a plateauing. So once I have a failure on one drug, if I use another single agent drug, we are likely to achieve in the remaining, 74% of these patients who are resistant would respond to a single agent. The rest 25%, of course, would go on to needing a multi-agent chemotherapy. And of course, with the use of single agent, it is less toxic, and whoever have failed the second line will of course go on to a multi-agent chemotherapy. So it is important that at the Charing Cross, they were initially using a cutoff of 300, then they move on to 500, then 2000. So bottom line is that if I have a patient of low risk GTN treated with single agent methotrexate, and they are plateauing, the beta HCG is plateauing at somewhere between 300 to 500, we are really confident in probably offering them only another single agent drug which will cure, which is likely to achieve a cure in almost 93% of these patients, sorry. Yeah, 97 to 98. Whereas, as we move, if we can even offer it up to one, if the beta HCG is plateauing at around 1000, but we have a little more relapses in these situations, which could be salvaged again by multi-agent. But of course, if I have challenges to using multi-agent, I mean, at least we can use that upper limit of cutoff of 1000, and by that, at least 75% would be salvaged by another single agent. And it is only the rest 25% who are not getting salvaged we could refer to a center for multi-agent chemotherapy. Okay, and as I said that as you move on in the low risk category, if they have a score of 5 or 6, what are the predictors that they are likely to have a higher chance of relapse? So patients who are likely to, and so for those patients we have our antennas up or our thresholds up, is other patients who have a histopathological diagnosis of choriocarcinoma. So it's very important that for any molar pregnancy that we are evacuating, it be sent for histopathological examination, because the histopathological diagnosis of choriocarcinoma portends a worse prognosis as compared to a complete or a partial mole. And similarly, of course, if patient presents with metastatic disease, they are at a higher risk of failure. And third, what is the pre-treatment beta HCG? So if, of course, a patient does not have any metastatic disease and it's not choriocarcinoma, then a beta HCG of more than 4 lakhs, 400,000 is something that is likely to portend a worse outcome. And of course, if you have choriocarcinoma or metastatic, then even a beta HCG of 1.5 lakhs can be a marker for worse prognosis. So bottom line is a higher beta HCG, worse prognosis. And of course, without any of these risk factors, the threshold is higher. With any of these risk factors of a chorio or a metastatic, even a beta HCG more than 1.5 lakhs or 150,000 is something that portends a worse prognosis. And in these kind of patients, of course, if they fail first line, they are the ones who should go on to a multi-agent chemotherapy. Those, we don't put them on a single agent chemo, and therefore this is how we would go about choosing. Any of the risk factors, high level of plateauing, we would want to give these patients multi-agent chemotherapy. So how do we give this multi-agent chemotherapy? Imaco, we are all familiar with. 2-3 things I would just want to mention here is that those patients whom we are giving multi-agent chemotherapy, it's a fairly well-tolerated regimen, but we have to be very, very careful about its toxicity. Most important is that how we are delivering, of course, what is the nutritional parameters. Somebody with a very low albumin of 1.52 is likely to have a higher risk of toxicity because these are all albumin-bound drugs. Also, somebody with effusions, we would not want to give them this. And one of the most important thing is, of course, the renal function tests. So they have to have a good renal function for us to be able to give them the Imaco regimen, because not only is there a dose modification of methotrexate, but also etoposide needs dose modification if a patient has renal failure. So one has to be careful. Second is that this methotrexate 200 milligram per meter square is given as an IV infusion over 12 hours. So the timing is so very important because it has to be given over 12 hours. We cannot have it being given over 14 hours, 16 hours, or it can't be 8 hours. So it has to be given for over 12 hours. The leucovorin rescue has to start at 24 hours. So whenever our residents write this protocol, two of us have to cross-check that the timing is correct. So I've started methotrexate at 12 noon, next day 12 noon, patient has to get their first dose of leucovorin. So that is something that we need to ensure, because if the dose of leucovorin is delayed, they get a lot of mucositis toxicity, and on follow-up, if a patient comes with mucositis, we have to check their blood counts and renal function because they are at a higher risk of developing these toxicities. So the most important thing to avoid these toxicities is to ensure these checks in place. And of course, duration of infusion, timing of leucovorin are some of the most important factors when we are giving this. They routinely don't require GCSF support, but if a patient is developing toxicity, then we give them prophylactic growth factors from day 4 to day 6. And day 8, of course, is an outpatient procedure. For the day 1, day 2, we usually admit because it's a 12-hour infusion. So outcomes with Imaco, so usually these are high-risk patients, and almost 92%, and this was data analyzed from our own institute by my colleagues. So even in these patients, we were able to achieve around 72, and those who % cure rates, and those who could not be salvaged on first line, they move on to second line therapy. And as I was mentioning that patients with very high-risk GTN, the ultra-high-risk GTN, score more than 13, or those are the ones who benefit from pre-phase or a low-dose induction chemotherapy, which is we give them 2 days of cisplatinum and etoposide as per the guidelines. But in our situation, sometimes patients come with extensive, florid lung mets, bleed, on oxygen. So those patients we have even restricted to just a single day and subsequently given them weekly cisplatinum and etoposide. So that is something that we need to know, because if we give these patients, ultra high-risk patients, full dose chemotherapy, they have a very high early mortality and they die because of bleeding. So, and lung bleeds, it's very difficult to salvage. Okay, so then what to do? Okay, so we've given them Imaco, and even high-risk patients with metastatic disease, we are able to salvage with Imaco almost 80 to 90% of the times. But what to do with patients who have progressed on Imaco? So there we of course have this regimen of IMA-IP or BEP, where instead of on day 8 cyclophosphamide and vincristine, we give them etoposide and cisplatinum. And another regimen used is paclitaxel cisplatinum, alternating with paclitaxel and etoposide. And this is the IMA-IP regimen, where of course we use a higher dose of cisplatinum. And of course that is associated with significant toxicity and almost, with low hemoglobin and low blood counts, almost close to 20 to 30% of these patients have this toxicity. But if you look at survival after IMA-IP, around 88%. So if a patient has had Imaco regimen, has not responded to it, among those who have relapsed, around again 80% of them would respond to second line therapy. And so therefore, if we see that those patients who have had a relapse, I mean, these are very small numbers, but most patients would respond to EMA-EP, some to BEP regimen, the same BEP which we use for germ cell tumors. And of course, we have this other therapy of alternating TPTE, and these patients also almost 70% to 80% of these patients achieve a response. So, where is this now? Okay. So therefore, of course, these are very small numbers because GTNs and even chemo-resistant GTNs, you don't have huge numbers of these patients. And of course, as we move on to more different drugs, they have a higher incidence of toxicity. So as I was talking and, somebody asked a question regarding immunotherapy and the GTN. So if for a very small subset of patients who are chemo-resistant to all of these, majority of the GTN can be treated with very simple, low-risk, single-agent or high-risk basic chemotherapy drugs, and 90% of these patients are cured. But for the small 5 to 7% of chemo-resistant GTN whom we were earlier losing, there is a role for immunotherapy. And why is there a role? As I said, that the placenta tissue has immune tolerance because they express PD-L1, and that's nature's way of preventing fetal-maternal tolerance. So therefore, if these patients develop resistance, there is a rationale for use of immunotherapy in these patients. And of course, that is why, there are several, these are not large randomized trials, but several case series which have shown that continued response with immunotherapy, even in drug resistant, and even some of our, occasionally very few patients that we've treated, even patients with brain mets or extensive disease do well after 4 or 5 courses of immunotherapy. And the beauty here is that unlike other solid tumors where you need to give them continued immunotherapy lifelong, as per NHS guidelines, it is up to 5, but in resource constraints, when we didn't have and they could receive only 3 or 4, even after that they have maintained response. However, at the same time, I must mention that some patients do not respond even in this category, and it is important to know, and I think that understanding is evolving as to who would respond and who would not. So the current indication for pembrolizumab is only in the 3rd line after they received imaco and a platinum-based either EMA-EP or a BEP regimen. That is immunotherapy recommended. And as I have said that it is only in the, and for patients who have PSTT, placental site trophoblastic tumor or epithelioid trophoblastic tumor, which are known to be chemo-resistant, you can use it in the 2nd line. Okay, and so usually the recommendation is up to 5 doses, and if they've had a response, to just follow them up. It is still not recommended in earlier lines of therapy, so it is only in a drug-resistant setting that is there. So to summarize that for patients who are resistant to 1st line imaco, one would use EMA-EP or BEP or TPTE in the 2nd line. And if this don't respond to any of these, then of course there is a role for using immunotherapy. But we are yet to understand what are the exact predictors for response to immunotherapy. So hope is there in the, thank you.
Thank you so much, ma'am. The tone you gave there. And I'm sure there are some comments and questions. At this time, I'll invite questions.
Thank you, Professor, for the wonderful presentation. I have 2 questions for you. The first one is, my setting, I don't have this infusion pumps that regulate the amount of chemotherapy that goes into the patient. So I want you to take us through how will you manage a patient with methotrexate toxicity in case you encounter.
Okay, so one is preventing the methotrexate toxicity. So even if you don't have infusion pumps, so generally we used to previously, when we didn't, in my residency days at peripheral colleges where I worked, we used to have these infusion sets where you could do the drop counts, and some of those pediatric or they have this. So if you have those infusion sets, that is fine. Even if you don't have that also, even with a normal infusion set, we know that there is 500 ml which has to go over 24 hours, and each ml has like around 24 drops. So how for a pediatric patient you would dose, you would do a drop count and set that, but of course then check every 3 to 4 hours, because that, you know, the problem with that infusion is it shouldn't go fast. So we used to have somebody very closely monitoring, or use one of those pediatric drip sets to give them that, and then monitor and give. So 12 hours is not something that, ideally yes, an infusion pump, but even if I don't have an infusion pump, it will just need close monitoring that it goes over 12 hours. So have these checks. And even with infusion pumps, we can have problems. So some infusion pump, something goes wrong and nobody has checked, you realize that it has gone over 6 hours or 8 hours. So you should have these 3 to 4 hourly checks, knowing that, you know, this drug has gone over this much time. They should be well hydrated for this thing, because we're just using total of 300 milligram per meter square. You don't need hydration like you would need for a high dose methotrexate more than 1 gram, but patient would need to be well hydrated, especially like, you know, if it is hot and they are dehydrated and they just come to the hospital and we start Imaco, that shouldn't be. So at least we should give them 1 or 2 points of fluids, they are well hydrated, and then we can start the methotrexate. With regards to toxicity, the most important thing for this low dose, we don't need monitoring with methotrexate levels, which is not needed, and generally for 99% of these patients we are able to do away without any need for MTX level monitoring. But what we do monitor is that if a patient has toxicity, is their creatinine levels. And if we think that the, you know, patient has presented to us with day 3 with toxicity and mucositis, we do give them extra doses of leucovorin, especially if I don't have the ability to monitor the methotrexate level. We can give them good hydration and, you know, continue their leucovorin for an extended period of time. But the key is to, of course, avoid the toxicity. Yeah.
Thank you so much. My second question is, during acquired resistance, after you've been able to bring down the beta HCG level to normal, how many additional cycles can you give?
Okay. So just let me tell you before resistance. So normally what we give is that once the beta HCG has become normal, you give 3 additional cycles. Okay, so minimum is 2. I mean, between 2 and 3, they said like the relapse rate has decreased from 8% to 4%, but so normally we give 3 additional cycles. Say for example, beta HCG normalized after cycle 4, so we would give them cycle 5, 6, 7. And the same holds true even if they've had resistance, like patient had a beta HCG of 10,000, it has dropped down to say 1,000, I mean say 600, 700 and starts plateauing. At that time, if you start them on single agent actinomycin D, then it normalizes. So then after, suppose after 3 or 4 cycles, then you would give them additional 4 cycles of that actinomycin D after that normalization. But we need to be able to do weekly beta HCGs for these patients.
Hello, thank you very much for this really informative and insightful presentation. I just wanted to know if there's any role of MAC regimen, MAC, as a viable alternative first-line multi-agent therapy for high risk, because I think studies say that it has similar efficacy to Imaco with lesser toxicity.
And so most of the people have moved on from MAC to Imaco because of greater efficacy and, you know, not much difference. So we usually move on to, because MAC has the same things except maybe the etoposide. So then again, moving on to another line. So currently most guidelines have moved on to use of Imaco for high risk. And if I do have to use multi-agent after first line failure, then I would choose Imaco. But of course, we have raised the threshold of using a multi-agent chemotherapy. So, you know, if somebody has, as I mentioned, that beta HCG plateauing at even up to say 1,000 without any other high-risk factors, one could probably just do away with a single-agent actinomycin D. So that is where. So really, most of the guidelines presently have moved on from MAC to just using Imaco, where we do need to use multi-agent. And there's a very recent, nice guidelines in the JCO I just have mentioned on the management of these gestational trophoblastic diseases with all guidelines, so that is something that you could refer to.
Thank you.
Thank you. Thank you.
So next we'll have Dr. Vickers, who is a medical oncologist as well from Tata Memorial, like said before. So he will take us through optimizing outcomes in metastatic colorectal carcinoma. The floor is yours.
Good afternoon again. While he adds the slides, metastatic colorectal cancer is a huge topic to cover, and it's very difficult to cover most of the aspects. But what I'll try to cover is that what is the basic chemotherapy we're going to consider, and what will be the what is the importance of having sequencing the therapy rather than having triplet all together in the first line. Okay, so to begin with, I'll cover the MSI high colorectal cancers who present in the advanced setting, and usually these are the number who will be about 3 to 5%, max 7% of the total metastatic colorectal cancers. So this was the first trial which brought in immune checkpoint inhibitors in the metastatic colorectal cancer who are MSI high. If you note that the median progression-free survival almost double compared to the chemotherapy, and this was the doubling of the survival led to approval of this immune checkpoint inhibitor in the metastatic setting. Do we have any other data? So the combination of immune checkpoint inhibitors, nivolumab plus ipilimumab, was recently presented in GI ASCO this year, the updated data, and then we know that combination of these two drugs, one is anti-PD-1 and the other is anti-CTLA-4. These are trying to make the tumor more hot and then have the more benefit of immune checkpoint inhibitor. Now, what is the benefit what we see in these patients? In about 3 years progression-free survival is about 70% compared to single agent nivolumab, about 50%, and compared to chemotherapy alone, which is 14%. And just to compare with the pembrolizumab single agent, the 3-year progression-free survival is 40%. So probably you can achieve 40 to 50% of 3-year progression-free survival with single agent, and if you add doublet, you can achieve almost 70%. So this is the only, probably the only tumor as of now has become standard of, the immune checkpoint inhibitors have become standard of care in the first line if you have MSI high tumor. So if the patient comes with metastatic colorectal cancer in our outpatient department, we need to have is MSI testing done before we even plan any treatment. And MSI is usually done by IHC method. Moving ahead, I wanted to mention our own data because today morning we heard Dr. Banawali talking about the low dose immunotherapy, and we had this retrospective audit of patients who received low dose immunotherapy or standard dose immunotherapy, and we evaluated their outcome. Of course, there was no head to head comparison, but if you look at the 1 year PFS, in these patients is 90%, and with the standard dose is about 76%. It's not that I'm trying to say that it is better than standard dose, but it is a retrospective study, small number of patients, but these all patients did very well even with the low dose immunotherapy. Now we gave 40 milligram of flat dose to these patients, and this has come out of a desperate situation that we see such a good response to immunotherapy, and patients were not able to afford. So patients were given low dose immunotherapy. This we published in JCO Global Oncology. Now when patient comes to us in the OPD or outpatient department with metastatic colorectal cancer, what is important? That of course apart from MSI, we need to have KRAS, NRAS, or maybe I'll call it ALRAS, and BRAF, so that we can plan anti-EGFR therapy, yes or no. So do we need to wait, because it is about 7 to 14 days we need the report will take, and that is where we can start the chemotherapy. Now this question is important for the left-sided tumors, it is not so important for the right-sided tumor. I'll come to that. The other markers what we are going to look at is HER2 or maybe then NGS if you have luxury of doing all these tests, but these are not so important. Now these are the 3-4 important trials which started triplet drug of chemotherapy with 5-FU, oxalic, inotecan in the first line, and these were looking at the intensification of chemotherapy. Now do we need to give first line chemotherapy as triplet? These trials had about, this is a meta-analysis of these own important trials, and these trials had more of a right sided tumor, and this trial looked at the survival benefit versus the toxicities. Now what we see is that we had improvement in the progression free survival and overall survival compared to doublet, but what happens is there's about, these patients had grade 3 to 4 neutropenia, which is about 45 to 46% compared to 20% in doublet, high number of febrile neutropenia and significant risk of diarrhea. And these patients included in these trials were a performance status of 0, which we usually don't see in our clinics. So do we need to add triplet? Maybe in a select fit patient, yes. Now on the right hand side, if you look at Cairo 5 trial, which looked at, these are the patients who were right sided or RAS mutant, they received triplet plus bevacizumab versus doublet plus bevacizumab. There was a PFS difference, we improved the progression free survival, but there was no overall survival difference. Again, if you look at the left sided RAS wild patients, if you include triplet chemotherapy with anti-EGFR versus doublet plus anti-EGFR, there is no difference in PFS or overall survival. So before I move on to that slide, I want to highlight one important point. Intensification of chemotherapy may not always result in overall survival benefit. Selected patient with understanding the toxicity what we are going to give, we need to consider triplet in these patients. Well, in left sided RAS wild patients, we can definitely add anti-EGFR drugs to doublet chemotherapy and achieve the similar or probably better PFS and OS. So now if I have a RAS wild left sided tumor, maybe I can consider for addition of anti-EGFR therapy with doublet and not giving the toxicity of triplet. If we want response rate, what do we do? Now these are the ESMO PAGA guidelines and recent updates on ESMO guidelines, and to my surprise they added anti-EGFR in the right sided tumors, those who are RAS-RAF wild, for early shrinkage. But I have summarized this table on the right hand side of your screen. So if you give triplet chemotherapy, you can achieve better response rate compared to addition of anti-EGFR with the doublet. Since we know the right sided tumor do not benefit much, or there is no PFS and OS benefit with anti-EGFR, I would say if you really want response rate, better go for triplet chemotherapy. If you want to achieve overall survival benefit, you can think of anti-EGFR in the left sided RAS wild, and the right sided should be left alone and not be given anti-EGFR therapy. Now what are the response rate we achieve with the anti-EGFR therapy, which is not much, and this is what this slide highlights. Which anti-EGFR therapy? Cetuximab versus panitumab. This study showed that the skin toxicity is more with panitumab, so as the hypomagnesemia, but infusion reactions are less with panitumab compared to cetuximab. Of course, it is completely humanized, the panitumab, and compared to cetuximab. There is no difference in the survival point of view. Now, what do we do in RAS mutant patients? Intensification of therapy, one of the option, but as I show you, the triplet would cause more, only PFS benefit and no survival benefit, and that would cause more toxicity. Do we add bevacizumab? These are the studies who have looked at this addition of bevacizumab to the RAS mutant patient, and there is significant improvement in the progression-free survival. Overall survival is doubtful, so we need to explain the patient about addition of this kind of treatment when we talk to the patient, and what is the expectation of the patient in terms of improvement in the survival, ultimate survival. Do we give maintenance therapy? Yes. If you look at the, this may be a busy slide for most of you, but if you look at the 5-FU maintenance or capecitabine plus bevacizumab maintenance, that adds progression-free survival, and probably after you have given 8 to 12 cycles of oxaliplatin based therapy in FOLFOX in the first line, you can go for maintenance therapy either with 5-FU leucovorin plus bevacizumab or capecitabine plus bevacizumab till progression or toxicity. Which one, if you have the left-sided RAS wild patient, can you give bevacizumab first or should you give anti-EGFR first? This was the study looking at the randomized trial. They looked at the subset analysis, and cetuximab plus chemotherapy followed by bevacizumab plus chemotherapy was better, superior if you consider left-sided RAS wild patients. So sequencing is important. There is a biological rationale for that. Once you give bevacizumab, the effect of anti-EGFR goes down. Now, these are the meta-analysis of the retrospective studies, again saying the same thing. If you have left-sided RAS wild tumor, start with anti-EGFR and then give bevacizumab. Do we combine bevacizumab plus anti-EGFR? A big no. There were these 2-3 important studies which showed detrimental effect. So till now what we have understood is that we don't combine cetuximab and bevacizumab. We give anti-EGFR in left-sided RAS wild patients, RAS-RAF wild patients, and then second line we give bevacizumab. We may not use anti-EGFR in the right-sided tumors. When we want response rate, we will use triplet chemotherapy rather than combining with anti-EGFR, and giving triplet chemotherapy in the first line would cause more toxicity even though there is a survival benefit. Now we recently saw that the BRAF inhibitors were brought into the picture. This was the earlier trial, and then we were part of this trial as well, that this was presented in GI ASCO, and updated results also have come. So this is a trial which combines FOLFOX plus cetuximab plus encorafenib in first line in BRAF mutant patients. Again, even though the Western literature says that BRAF mutation is between 3 to 9% to 10% to 15%, our own study of prospective 300 patients showed 1% or less than 1% BRAF mutations in our patients. Now it is of small importance, of course, but BRAF mutant patients do not benefit with chemotherapy, so anti-BRAF encorafenib is useful, and that is a landmark study. Now HER2, there are many phase 2 single arm small studies looking at addition of trastuzumab plus the other anti-HER2 drugs. We will still have to wait for the larger results. The question is, if it is not RAS mutant and it is RAS wild, whether you give trastuzumab, pertuzumab, cetuximab all together, or how many mAbs are we going to give to the patient? That is a biggest challenge. This is our data. Of course, the updated data I couldn't present because it's under peer review, but if you look at this data of 2013 to 2017 metastatic colorectal cancer patient, this is the era where we did not have generic bevacizumab, and we hardly gave anti-EGFR therapy and bevacizumab in 6% patients. The median survival was close to 17.6 months. Updated data of after this era where we had generic bevacizumab and a better patient assistance program with anti-EGFR therapy and sequencing of therapy, our median survival is close to 29 months. And this is, the data is under peer review, which is about 2,500 patients data what we have collated. And that's from our side. Thank you.
So thank you so much. We'll now proceed to the next.
Okay, our next presenter now is Dr. Ricky Fraser. He's a consultant medical oncologist at Hugh Faculty Lead for Belinda Cancer Center and clinical lead for the Acute Oncology Assessment Unit, and also the program director for Diploma and MSc in Medical Oncology University in Buckingham, United Kingdom. He'll be joining us online, and his topic will be immunotherapy now and next, a cure for stage 4 cancer, fact or fiction. Dr. Ricky, are you there?
Yeah, good evening. Great to be here.
Okay, good evening. Please carry on.
So look, great to be here. As you can see, I'm sort of a jack of all trades, master of none. So I do a few things. I do quite a lot of immunotherapy. As it says here, I'm program director for an MSc in medical oncology with Lerner in the University of Buckingham, and I lead our advanced therapy at Velindre Cancer Centre in Cardiff in the UK. And so what I'm going to do today is talk a little bit about where we've come from, where we are with immunotherapy. I think it's an exceptionally exciting time. And then I'm going to talk a little bit about where we're going to, and we're really on the cusp of something absolutely incredible in cancer care. And I'm delighted to talk about this today. I know you've had a long day. I'm going to try not to keep you here all evening, but I may get overexcited because I think there's an awful lot of really exciting stuff that's coming down the line. So I'm going to talk a little bit about immunotherapy. I'm guessing many of you will be familiar, but I'm just going to remind us all so we're on the same page. I'm going to talk about toxicity management. So I spend a lot of my life managing toxicities nationally in the UK and beyond, and actually I'm still learning every day. I'm going to talk a little bit about some of the ways that we can potentially empower our patients. I think it's really important that we put the patient at the center of that journey. And then I'm going to finish by thinking about some of the novel and advanced therapies coming down the line. And then probably if you're going to take nothing else from my talk today, it's probably worth taking a picture of the educational resources that I'll put at the end. They're all completely free. They're absolutely open to everybody. And hopefully that will help us all go on this journey together. So those of you who are familiar, and maybe those of you who are less familiar, immunotherapy is what it says on the tin. So it's using the immune system to fight cancer. And we know the immune system does this. One of the tumors that I treat is kidney cancer. And about 1% of the patients I see in kidney cancer, they get referred to me. They have a biopsy of one of their lung metastases, which is confirmed to be clear cell renal cancer, the most common type of kidney cancer. And then I restage them because a bit of time's gone on, and some of those lung metastases have started to regress. And what we think is going on there is that it's the immune system that's already starting to fight against that cancer. So what I was saying is that when we think about immunotherapy, we're really up until now talking about checkpoint inhibitors. And so a rule of thumb is if there's an L in the middle of the word and MAB at the end, it's probably a checkpoint inhibitor. But actually, immunotherapy is much broader than this now. We've got lots of these new and novel immunotherapies that are coming down the line. And we know that checkpoint inhibitors, slightly oversimplified, but we've basically got T cells, which are a type of immune cell, and we've got tumor cells. And the T cells try and kill the tumor cells, and the tumor cells protect themselves by putting the protein PD-L1 on their surface. It stands for program death ligand 1, but frankly, who cares what it's called? It's just a protein on the surface of the tumor cell. It binds to PD-1, which is a receptor on the T cell. And when they bind together, it stops the T cell from being able to kill the tumor cell. And so what these drugs are, what these antibodies are either drugs that bind the PD-1 or bind the PD-L1, like avelumab binds PD-L1, removes the interaction between those two proteins and allows the T cell to kill the tumor cell. And the reason why people like me get so excited talking about it is that we've now got this potential, and normally when I get paid to speak, I'm not allowed to use the C word, but I've not been paid today, so I'm happy to say that I think there is a proportion of patients that we're able to cure in the stage 4 metastatic setting, even when these patients have got lung mets, liver mets, or even brain mets. And that's why I get so excited thinking about immunotherapy, but also thinking about how we manage those toxicities. Now, this is back from 2021, and you may say, well, that's quite lazy. Why have you not updated this slide? And it's simply because I can't include 2022 or later indications onto a slide. They're just coming too quickly. There's too many immunotherapy indications for it to fit on a slide, which is clearly fantastic for our patients, but poses us real challenges in terms of service delivery and ultimately toxicity management. And I talk to patients about this being a double-edged sword, that we've got this potential to cure you with your stage 4 cancer. But being entirely honest, we've also got the possibility of causing a life-threatening toxicity. And that's why management is so critical in this space. So where are we of today? So we've now got combinations of immunotherapy with immunotherapy. We've got immunotherapy and targeted therapies, and we've got immunotherapy and chemotherapy. So this is getting more complex all the time. And I'm not going to bore you with data today. Data is not what I'm here to talk about. I'm just going to show one trial for those of you who are less familiar with melanoma. When I started treating melanoma, and I'm quite old now, when I started treating it, we really only had dacarbazine chemotherapy, and nearly everybody died within 12 months. And this was the trial, CheckMate 067, led by one of my colleagues, James Larkin, a good friend of mine from Marsden, who, in essence, we randomized 3 different groups of patients, combination immunotherapy and single agent. And we looked at the outcomes in these patients with widespread metastatic disease. And this is the take-home message. We've got 10-year data, and nearly half of these patients are now alive at 10 years. And I think you can accept that that curve is starting to look pretty flat. Most of the patients are no longer on any treatment. And bearing in mind you're allowed to die from something other than your melanoma, if you look at melanoma-specific survival, it's above 50%. So I've got no doubt that we're curing a proportion of patients with these checkpoint inhibitors. And that's clearly a fantastic place to be. But it comes at a cost, and the cost are these autoimmune side effects that can affect any organ of the body. And that's what I spend now about 60% of my time managing. And most of you will be familiar with the fact that, in essence, if you think of an organ of the body and put the word itis on the end of it, they are potential side effects that we might see. So colitis, inflammation of the bowel, myocarditis, inflammation of the heart, uveitis, inflammation of the uvea. The list goes on. And what this means is that there's more than enough work for me to do running a toxicity service in Wales, managing this breadth of toxicity. So I'm just going to run through a few of these toxicities and just talk a little bit about how we investigate and manage them. Pneumonitis, inflammation of the lung, typically presents with cough and shortness of breath. And when we ambulate these patients, when we get them up and walking, often they desaturate very quickly. Pneumonitis can be a floridly progressing disease. And so when I see pneumonitis, if they don't respond to steroids very quickly, I'm already starting to think about other immunosuppressive drugs that I can use to manage this, like tocilizumab, like infliximab, which target IL-6 or TNF-alpha, so target the cytokine storm that's driving this inflammatory process. Colitis is really common. So I see about 10% of the patients I treat with ipilimumab and nivolumab developing colitis. And a really classic story for colitis secondary to immunotherapy is the patient that says, I was really well yesterday, and today I'm pooing 10 times a day. That's a really common story that I hear with immunotherapy-induced colitis. Some patients will just have diarrhea. They don't necessarily have blood or mucus. And actually, it's quite rare for the patient to have abdominal pain. Most of these patients will tend to not have abdominal pain unless they've got small bowel involvement. And it's really important that we get scopes for these patients, either a flexible sigmoidoscopy or a colonoscopy. And when our gastroenterologists push back and say, well, you know, you've got a CT, it looks like colitis, why do you need to do a scope? I always say to my gastroenterologist that there's 3 primary reasons that I need a scope. One, that if I see ulcers on that scope, 60 to 70% are not going to respond to steroids and will need a biologic agent. Number 2, biopsy is the best way to pick up CMV and look for inclusion bodies. And number 3, there's a type of colitis where the mucosa looks okay. you biopsy it and they've got a microscopic or lymphocytic colitis. And these patients respond beautifully to things like budesonide. Now that's given orally, but it's got essentially 100% first pass metabolism in the liver. And so it negates a lot of the steroid-induced toxicity that we see by giving things like prednisolone or methylprednisolone. Again, how do we manage this? It tends to be with steroids, but again, in patients that aren't responding, we start to think about infliximab, anti-TNF alpha. We tend to think about vedolizumab and anti-integrin, and increasingly, we're starting to use other drugs and things like fecal transplants to manage these toxicities. And again, I'm going to come back to talking about feces later. We see an awful lot of neurological toxicity. So this occurs in about 1% of patients. And so we see things like myasthenia gravis. Some of you will know that myasthenia gravis is a problem with the neuromuscular junction. And so when we get this problem, typically we get patients presenting with droopy eyes, difficulty swallowing, weak voice. And I've had a number of patients who've come to clinic and just said, oh, I'm falling asleep and I don't know why. Did a blood glass, they're in type 2 respiratory failure. And actually what that turned out is to be a myasthenia gravis. And those patients often need critical care support to manage respiratory complications and often need to be intubated. There are other things like Guillain-Barré syndrome, where you've got an ascending numbness up the body. And then other more complicated things like posterior reversible encephalopathy syndrome, or PRES, where in essence patients present with headaches, visual disturbance and seizures. And again, these complications can be life-threatening. So management, again, this time I would tend to give 500 milligrams or 1 gram of methylpred to manage these. But the important thing is not necessarily the management. There are people out there that can do that. It's recognizing that this complication may exist. Now, I want to spend a couple of minutes talking about myocarditis. In the clinical trials, we used to think myocarditis was about 0.1% of the patients we treated. And we now bring cases to that, that MDT, that forum, on a Monday UK time at 11:15. And we're now seeing an awful lot of myocarditis across the UK. And so I'm now estimating that 1 to 5% of all the patients that we treat with checkpoint inhibitor immunotherapy develop a myocarditis. And many of these patients will present with an arrhythmia as part of that myocarditic process. It's also really important that you're aware that when you see myocarditis, many of these patients will also have myositis, so inflammation of more general muscles, and they'll also have myasthenia gravis, so that weakness in facial muscles and respiratory muscles. And the mortality rate to badly treated triple M is about 90%, and even well-treated triple M is about 30 or 40%. And the best way to diagnose myocarditis is by doing cardiac MRI. So I end up with a lot of people saying, well, surely we can just do an echo. An echo will not tell you if you've got myocarditis. It will rule out other causes like aortic stenosis or heart failure. And you may see that heart failure may be related to myocarditis, but cardiac MRI is the gold standard test. And then finally, there's a whole host of endocrinopathies. It can affect the adrenal gland. It can affect the thyroid gland. The one that I always talk to patients about is about 1 in 400 chance of developing type 1 diabetes. And the reason I always mention that specifically is if patients develop type 1 diabetes, that's a lifetime on insulin. And so that's a game changer for their quality of life in a way that taking thyroid hormone or adrenal hormone wouldn't necessarily impact them so severely. Now, I want to talk just briefly about some of the ways that I think we can empower our patients. As I showed you on that melanoma slide, in melanoma, the chance of me having a durable outcome in a patient who's got metastatic disease that's spread to the liver or the lung or even to the brain is about 50%. But like you, I want that percentage not to be 50, I want it to be 60. or 70, or God forbid, one day 100% of patients surviving with metastatic melanoma. And what I think we sometimes don't realize is that there's already ways that we can give our patient the best possible chance of responding. And I'm going to go through some of those things today. As you know, I've got a fascination with poo. It's quite a declaration for this time in the day. But actually, I think poo is going to be the answer to a lot of our problems. And the reason for that is we know that certain bacteria in the gut predict response to immunotherapy. So we know, for example, that bifidum bacteria, rheumococci bacteria tend to predict a positive outcome. We know there's certain bacteria that tend to be bad for the gut, things like bacteroids and others. Again, anyone who's interested, we've done 3 podcasts on this with the team in Australia who are leading the way on microbiome research, and I absolutely recommend listening to them. And so what does this mean for practice? Well, here's just one example. So this is in renal cancer. I treat renal cancer. And this is looking at the addition of Clostridium butyricum 588, a butyrate-producing bacteria, and just supplementing your immunotherapy with increased strains of this CBM 588 increases your response rate to immunotherapy. And when we do the preclinical work, we can see downregulation of T regulatory cells and upregulation of CD4 and CD8 cells. So the microbiome, the bacteria in our gut, is directly affecting the immune system that we've got to fight the cancer. And so I don't think we're far away from giving people CBM 588. And even more exciting, I don't think we're far away from doing fecal transplants from patients who are responding to patients who aren't responding. What am I telling my patients as of the 19th of June, 2025? I'm telling my patients, actually, there are things that you can do. You can use a high fiber diet. We know that will enrich for things like rheumococci and bifidum bacteria. I tell them to eat lots of fermented foods, and I tell them to have a wide variety of diet, because all of those things, and again, those podcasts will highlight it, all of those things lead to a more varied diet, better for the good bacteria, and directly improve patient outcomes. I also talk to my patients about antibiotics. Now, if somebody has sepsis, they absolutely need antibiotics. But we've got lots of patients, particularly lung cancer patients, who've got a background of COPD, who it will be very easy if they've got a bit of a cough and cold before they start their immunotherapy to give them some broad spectrum antibiotics to nip it in the bud before we start their treatment. That has a massive chance of reducing their ability to respond to the immunotherapy. So I try to avoid antibiotics in the 8 weeks prior to treatment and the 8 to 10 weeks after they started treatment, because it will directly impact the microbiome and reduce the chance of response. And so you can see how we can move from that 50% durable outcome to 55 or 100 just by trying to improve these small things and incrementally improve our chances of patients responding. Now, there's also data coming through. It's quite robust data. There was more presented at ASCO this year showing that PPIs directly impact your microbiome. They also increase your risk of nephritis, and they cause lots of low magnesium. And so when I see new patients on PPIs, if they don't really know why they're on a meprazole or lansoprazole, I just stop it outright. And if they say they've got the worst reflux in the world, I switch them to famotidine. And again, I think we're going to incrementally improve outcomes by doing this. I haven't got time to talk about it today, but there's also some really nice data coming through looking at giving immunotherapy earlier in the day. And it looks like if you give your immunotherapy before 3 p.m., that will improve the outcomes of the patients. And that clearly has massive ramifications for our treatment units and the way we deliver this to patients. Again, I could talk all day, but I'm mindful that I haven't got time to do that. want to finish my final 10 minutes thinking about the future. I don't think there's any better time to be in oncology than now. I think the next couple of years are going to be absolutely sensational in terms of the new treatments that we're going to be able to offer patients. Things like cancer vaccines. Last week, I was lucky enough to present the first All UK Cancer Vaccines Award. It's amazing where we are with cancer vaccines. You know, COVID was terrible for lots of reasons, but it's absolutely accelerated our cancer vaccine work. We've got cellular therapies, we've got receptor therapies, we've got CAR T therapies, we've got oncolytic viruses. It's amazing how we are now being able to harvest our immune system. And I would love to spend the rest of my day talking to you, but I'm sure you've got bed and food to do. So I'm just going to mention a couple of them. We've got something called bispecific. So I treat melanoma, and we've now got a drug called TEBI or tebentafusp, which is a drug that, in essence, is a receptor that brings the T cell closer to the tumor cell. And again, this is a new treatment that now offers people with uveal melanoma a treatment they didn't have. Offers small cell lung cancer patients a drug called tarlatamab that they didn't have. Again, we're bringing this science to patients in the real world. Now, any of you who have terrible taste in music like I do may recognize that this is the New Kids on the Block. One of my favorite bands. I'm in the 0.1% of people who say that. But we have to accept that we've got some new toxicities that we've got to learn about. We've got to learn about cytokine release syndrome. We've got to learn about ICANS, so immune effector cell associated neurotoxicity. And we've got to learn about HLH or macrophage activation syndrome. And I've not got time to talk through these today in any great detail, but really what I'm talking about is overstimulating the immune system, causing the release of lots of cytokines. Cyto means cell, kine means attract, stimulating a very vast immune response. And as a result of that, getting leak in our capillaries in lung, causing hypoxia, and getting leaky blood vessels leading to hypotension. And so we've got to get used to these toxicities. We've got to get used to identifying them. And we've got to get used to using drugs like anakinra, which is an anti-IL-1, to manage these toxicities. I just want to mention two final treatments. And this is the bit that I'm most excited about. Again, I'd love to talk all day to you about this. We're about to open a trial in Cardiff called Tilvance 301. And this is basically, so for those who aren't familiar, TILs or tumor infiltrating lymphocytes is basically taking the tumor out of the body. So imagine someone's got lung mets and liver mets and nodal mets. You would take some of that node away. Those tumor cells would hopefully be surrounded by T cells that recognize the tumor. That's why they're sitting there. You take those T cells out, you clean it up, so you've just got the T cells left. For us, we send them to Philadelphia in America. We turn that into billions of cells. We give the patient some chemo to make some space. We give the cells back to the patient, and we give them IL-2 to stimulate further proliferation of those cells. We are curing patients with just one treatment of TILs that takes about 7 weeks in total. And we're doing this in patients who failed other types of immunotherapy. And so again, this is just incredibly exciting that we're going to be able to bring this to our patients. And it's this durability that we see after just one dose. Yes, we get some toxicity like CRS, so cytokine release syndrome, but it occurs very early. The vast majority of patients after those first few weeks have got no toxicity, but potentially are going to be cured of their metastatic cancer. And this really just highlights that, yes, we need to be able to manage these patients. We need to work with our medical colleagues. We need to work with our critical care colleagues. But this is very much a sharp dose at the start, and then toxicity lessens off very quickly. I posed to you the question at the start, can we cure stage 4 metastatic cancer? I genuinely believe we can. But more than that, there are now ways that we can take that 50%, or for example, in renal cancer, it's about 30%. And by optimizing their gut, optimizing their medications, optimizing the time of day, and giving them some really good patient education through podcasts, we can bring that percentage to 60 or 70. And ultimately, you, like me, want that percentage one day to sit at 100. And I think our new and novel therapies are going to give us a genuine chance to do that.
Thank you so much, Dr. Fraser. I'm very sure there are questions and comments. Please.
Thank you, Dr. Fraser, for this wonderful talk. I have a question. Say, for example, a patient had a toxicity with immune checkpoint inhibitors. How do you decide on re-challenging the drug? So I give you a case scenario, a rectal cancer with lateral pelvic node, not willing for extensive surgery. We gave EP-neo 2 doses. Patient had myasthenia gravis and complete heart block requiring temporary pacemaker. Responded to steroids, thankfully. We kept infliximab ready but didn't require. Now patient has been given radiation to the rectal cancer after 2 doses. Now the question is whether to give nivolumab. Of course not ipilimumab. We decided not to give ipilimumab, but the plan is to give nivolumab or no. How would you take that call?
Yeah, look, that's a fantastic question. So I mean, the first thing to say is there's not a right or wrong answer to that question, and that's why you're asking it. But it's a question I'm asked every day up and down the country. So the way that I look at this is the first thing to say is if somebody's had toxicity, I always scan them about 6 weeks after it because chances are they will have started responding. We know that patients who develop severe toxicity tend to be the group that do really well. So the first thing to say is I wouldn't re-challenge them until I'm certain that they've genuinely started to progress. Because actually in my experience, if someone who gets something like triple M or myocarditis myasthenia, and if we check their CK, I'm sure they'd have myositis too, that patient's got a fairly good chance of responding. If I was going to re-challenge them and I was going to give them nivolumab, so with myasthenia gravis, it would depend on did they need to be intubated, how quickly they responded to steroids, did they respond to IVIG or other agents that we might use to treat myasthenia. Similarly, it sounds like for the myocarditis, we didn't need infliximab or tocilizumab or abatacept. I think that's what I'm hearing. So actually, what would I do? If the patient understood the risks, I would reconsent them for higher toxicity the second time round. I would be willing to re-challenge them, but probably what I would do is I would give them 2 weekly nivolumab for the first couple of cycles and then put them onto 4 weekly afterwards. But I would absolutely consent them for a higher risk of death from either of those toxicities. And if my gut, and again, obviously you've got the scans, you know, but that patient, in my experience, will be really unlucky if they're not having a response after those toxicities.
Well, thank you very much. I mean, the patient definitely has a response on MRI, and I'll take that information. Another question is that you mentioned about patients do not respond much if they are on antibiotics. Even there was a data presented on HCC patients, PPI, and what is your thought on patients who are with the liver metastasis? The liver metastasis versus non-liver peritoneal metastasis. There's a difference in the response.
Yeah, no, absolutely. So, you know, we see this, you know, so that's a great example. We see that across a number of different metastatic sites. So we know from big data sets, pancreatic metastases don't tend to respond particularly well to IO. True bone lytic metastases don't respond particularly well to IO. So you're absolutely right. And these are all the things that I'm factoring in when I'm seeing a patient and deciding how aggressive I want to be with the immunotherapy. Now, I haven't got time to talk about it today. Again, I'd be delighted to come back and speak to you outside of this Merck meeting or at your own local meetings. There's some really nice data coming through now looking at predictive models using epigenetics, using IL-6 as both predictors of response and toxicity. And so I think over the next few months, we're going to start being able to finesse using metastatic sites, using epigenetics, using things like IL-6 to stratify our patients in terms of chance of response and chance of toxicity. And again, I'd be delighted to talk about that in the future.
Thank you. Thank you very much.
Any other comments or questions? Yes, ma'am.
Also, I wanted to understand, so thank you, very nice talk, was that if patients have, on immune checkpoint inhibitors, like for example in CA endometrium, and they are on single agent pembrolizumab, come back with some fatigue, and except for a high NT-proBNP for cardiac failure and mildly increased CPKMB, we don't find any other marker for like myocarditis. 2D echo is normal. So something like a very early or a subtle maybe myocarditis, like even on an MRI we don't find anything very specific. So how do you deal with these? Because they don't fit into a classic myocarditis, but they are like an early myocarditis. So how do you go about treating them?
Yeah, look, that's a fantastic question. So let me give you a few tips that I've learned the hard way. So the first thing I would say is that it depends which troponin assay you do. So we know that troponin I is more specific than troponin T, and troponin I has got a shorter half-life, so it often goes up and comes down quicker. And so if your lab does troponin Ts, typically I would ask them to do a troponin I. That can help you identify it in addition to the BMP. The other thing that can be really useful, so if I'm suspecting a myocarditis, but let's say you either can't get a cardiac MRI or it's too early to see the changes on a cardiac MRI, what I will often do is an MRI of the femur. And actually, if the patient's got inflammation in the quadriceps and they've got a raised BMP and new onset fatigue, it's in my I've never seen a case, and I've managed a fair bit. I've never seen a case where they've got a raised cardiac marker, MRI confirmed myositis in their thigh that didn't later show myocarditis in the cardiac MRI. So I would use that as a proxy that if those muscles are inflamed, but it hasn't yet made its way to the cardiac MRI, that actually I would treat that as a myocarditis. And my initial management would be 500 milligrams or a gram of methylpred, a biologic screen, and I'm already starting to think about infliximab or abatacept, abatacept being an anti-CTLA-4 receptor blocker, which is now I've used a number of times with great success.
Thank you.
Thank you so much for the insightful presentation.
My pleasure.
Yeah.
Have a wonderful evening.
Likewise. So the last speaker before the other session will be Dr. Kofi Adum-Atta, Acting Head of Family Medicine, Polyclinic and OPD at Cape Coast Teaching Hospital, Ghana. He holds an MSc in Pain Management and is a distinguished Merck Foundation alumni. So we're looking forward to an insightful presentation, and then the topic will be integrative approaches in pain and palliative care for cancer patients.
Okay, so my name is Kofi Adum-Atta. I am a family physician and a fellow in training in hospice and palliative medicine at the Ghana College of Physicians and Surgeons in Ghana. I'll be talking about integrative approaches to pain and palliative care for cancer patients, and I would like all of us to also contribute because we are all tired. So if you feel like you have any contribution to make, kindly just go ahead and then make it. So this is going to be the presentation outline. We'll talk about principles of palliative medicine, some of them, not all, and then we'll talk about pain and other symptom management in palliative care. We'll talk about palliative care in lower and middle income countries and why have an integrative approach to pain and palliative care. We'll discuss a few end-of-life care issues, some ethical and legal considerations, and some take-home messages. So the burden of cancer in Africa is growing, and by 2040, it's estimated that it's going to double. Breast cancer and cervical cancer are particularly prevalent among women in Africa, and then hepatobiliary and then prostate cancers among men. So it's a huge public health concern that we all need to be aware of, and that the palliative care needs are only going to increase as we move along. Pain is very common for all patients with chronic illnesses and diseases. Again, so there's a very high prevalence, more than 70% of patients with metastatic or advanced disease experience pain. And pain is not just its physical presentation. There are other dimensions of pain that we have to be aware of. Notably, it could be psychological, that is, whether the patient has worries or anxieties or has fears or depression associated with the pain. There are emotional states that affect the patient's day-to-day activities that we have to be aware of. There are social and cultural implications or dimensions of the pain. And most importantly, again, are the spiritual dimensions that we need to be aware of. So there's a need for integrative approaches to managing pain in all its dimensions. So, there's evidence-based medical treatment, especially if it's combined with complementary strategies that respect the person or the patient, respect the socio-cultural circumstances of the patient and the spiritual context. It's going to help the patient improve in their quality of life. Again, as I said, about almost 70% of patients with advanced cancer experience some form of pain. And so managing pain generally improves the general well-being of the patients who are in our care. The International Association for the Study of Pain defines pain as an unpleasant sensory and emotional experience that is associated with actual or potential injury or described in terms of such damage. What this means is that pain is exactly what the patient says it is, whenever he or she says it is. And that's, we should take that. There are different types of pain and pain presentation. Pain could be acute, that is, if it's less than 6 weeks, could be subacute, that is, if it's between 6 to 12 weeks, or chronic, that is, if it's more than 12 weeks. Pain can present in different syndromes. The notable ones are nociceptive pain, that is due to stimulation of nociceptors, or it could be nociplastic, which is a form of altered nociception, but in the absence of tissue damage, or it could be neuropathic due to invasion, compression, or distraction of the peripheral nerves of our patient. So what is palliative medicine? There are several definitions, but they all should contain these key terminologies, that it is a specialized branch of medicine, and that it is holistic in its approach, it is team-based, and then in addition to that, it is geared towards improving the quality of life and relief of suffering and pain for patients and patient relatives that are faced with life-limiting conditions and then life-altering conditions or life-threatening conditions. So again, the dimensions are very important. It's not just the physical presentation that the patient is presenting with that you should concentrate on. You should also look at the psychological, you should look at the social, you should look at the cultural, you should look at the spiritual aspect of it. The scope is very broad, and we are going to talk about this, why we should integrate it very early into the care of our patient. So if you look at this diagram, we can see that in the pre-morbid state, our patient is healthy, or maybe you do some screening and you pick up a disease state that the patient may have. A lot of people confuse palliative medicine with end-of-life care. It is not. They are not the same. End-of-life care is not palliative medicine. Palliative medicine is not end-of-life care. End-of-life care forms part of the components of the spectrum of palliative medicine. If a patient presents with, let's say, any type of cancer, In the early stages, you might want to do a curative procedure for the patient. In the maybe stage 3, stage 2, late stage 2, stage 3, you might want to do some life-prolonging treatment for the patient. At the point of diagnosis, if you commence palliative medicine, in addition to the curative and life-prolonging treatment that you are giving your patient, then your patient gets to have a lot more improved quality of life because they understand their disease better. It's part of the component of palliative medicine that you are discussing with them. They're able to plan ahead. They're able to coordinate their care far better when you start palliative care very early from the point of diagnosis. At some point, both your curative and life-prolonging treatment might not work. Then you realize that symptom management or supportive treatment seems to take a bigger chunk of your management. And then you are doing a lot more what we call end-of-life care, and then your patient moves into hospice care. I will define all of this. Even beyond the point of dying, your patient still benefit, sorry, your patient relatives benefit from bereavement. So, hospice care, as I said earlier on, technically refers to our patients who, with a life expectancy of less than 6 months. Comfort care is the care you give to patients who are actively dying. At this stage, you do not do any life-prolonging treatment. You do not do any curative procedures. All you're doing is making the patient comfortable in the setting that they are comfortable with their families, their spiritual care, all the other needs are taken care of so that they can pass comfortably. Usually the patient is actively dying some few days to some few weeks at that. Palliative care starts from diagnosis. It coexists with all the curative and life-prolonging treatment that you are doing. Please, we all understand the difference now. So end-of-life care is not palliative care. So this is another diagram explaining the same thing. At some point, maybe beyond diagnosis, your patient might be stable, you will be doing curative treatment, your patient will move and become unstable, can deteriorate. You realize that the role of palliative medicine tends to increase as you move towards the terminally ill patient. So even at the point of dying, the patient relatives can benefit a lot from bereavement care. Palliative medicine is patient-centered. So the treatment that you are giving should align with the patient values and preferences. The patient's perspective needs to be taken as part of the decision-making process and ensure that the patient is actively participating in their care. Communication is very key, so we need to engage with the patient and discuss everything, right from breaking of bad news, which is a very scientific process that we need to take seriously, and any other question that the patient might have or patient relatives might have, so that they really understand their condition better and then understand the coordination of the care that they have to do. If they need to go to surgery, it has to be coordinated. If they need to go into oncology, it has to be coordinated. If they need to do radiotherapy, it has to be coordinated. If they need non-clinical services, it has to be coordinated as well. The care, as I said earlier on, is holistic, which is that you do not just address only the physical problems, but you make use of the biopsychosocial model, address all the physical concerns that the patient will have, including the primary condition and all associated symptom presentation. You also have to screen for depression and anxiety because these two are very common with patients with chronic illnesses. And then you have to identify all the contextual issues that the patient might have with respect to their social lifestyle or their social life, with respect to their cultural lifestyle. We've had patients who, for example, he's the head of his extended family, he's supposed to chair funerals, he's supposed to chair family functions, but because of his illness state, he's not able to do any of these things. And it kind of creates a lot of distress for him. He's expressing distress and pain, but it's not a physical pain. It's socio-cultural. Again, palliative medicine ensures that there's continuity of care for the patient. It also ensures that the patient is receiving a well-coordinated care. So in all the areas of care, or in all the settings that the patient is receiving care, pre-hospital, hospital, hospice, or comfort or home care, the continuity of the care is assured. There's a lot of information that is given to the patient, and the transition is seamless. If you go to very huge hospital facilities, the patient will be confused. They might not know where to go from one point to the other. But if the care is coordinated with palliative medicine, then they will know that at this point of the disease, this is where they have to go. At this point of the disease, this is where they have to go. And it kind of removes a lot of anxiety off their shoulders. Now, let's discuss pain. So in our clinic, we explore the presentation of pain in several ways. There are a lot of ways that can be done, but we use these two acronyms mainly. The Socrates, which refers to the site onset character, radiation, associated symptoms, the timing of the pain, exacerbating, relieving factors, and the severity of the pain. We can also use the RATS system, which is more quick to recognize, which is to go through all these, assess, do a physical assessment, treat, and then self-report. So when you use this approach, you systematically approach the presentation of the pain, because you need to identify the particular pain syndromes that the patient is presenting with and treat those pain syndromes to improve the patient's quality of life. Let me come back to this. So this is the Edmonton Symptom Assessment Score. It has on it about 9 to 10 non-specific symptoms that are usually associated with chronic illnesses and then cancer conditions. The first one, as you can see, is pain. There is also a severity score where you can score the intensity of the symptom that the patient is presenting with. When you improve on pain, tiredness, drowsiness, nausea, lack of appetite, shortness of breath, depression, anxiety, the general well-being of the patient, and any other presentation that the patient might have, you realize that you improve upon the patient's general well-being. They look happier, their distress levels are lower, their suffering reduces, and their quality of life also improves. There's a diagram where you can mark on it which part of the body that they're experiencing the pain, and then you can also continue to do the scoring system here as well. So there's a difference between nociception and pain. Nociception refers to the packaged noxious stimulus that is transmitted along the afferent neurons to their relay center in the spinal cord, then through the lateral columns in the spinothalamic tracts to the sensory cortex in the brain. As this packaged information is being transmitted along, there are a lot of other factors that the patient is going through which affect the expression, whether modulation of the pain or the sensation, whether to diminish it or to catastrophize it. So my experience of pain, for example, if I prick you with the same intensity of pain, let's say I prick you with a needle with the same pressure, and then I prick myself with the same pressure of pain. We have the same level of stimulus, but my expression of the pain will be different from yours. Mine might be more than yours, yours might be less than mine. And it's due to all the other modulators which can either enhance or diminish or catastrophize the pain sensation for your experience, makes the pain unique to you. So there are biological factors, like previous traumatic injuries, genetic predisposition, hormonal factors, or if there's inflammation associated, can also affect the expression of the pain. The psychological states, anxiety, depression, the temperament, anger, fear, sleep, stress, catastrophize, as I said earlier on, and self-efficacy, and then social factors, the economic state of your pockets, whether you're able to, you are the breadwinner, whether you're able to provide for your family or not, despite your condition, affects how you experience the pain. If I am going for an interview, or my boss is sitting on my neck, maybe in the night I couldn't sleep well because I had to study very hard, and my hand got caught in the door, the way I'm going to experience the pain is totally going to be different than when, let's say, I am moving among my friends, it's a party, we are all drinking, there's loud music, and all. You realize that in the second scenario, my experience of the pain is going to be less diminished than compared to the first. So anxiety worsens or catastrophizes the pain. Anger and fear catastrophizes the pain. The socioeconomic status, if there's stress or dysfunctional family, the social context, our interactions, if they are dysfunctional, will worsen the pain. If we don't have adequate family and social support, or the therapeutic relationships are not strong, it will worsen the expression of the pain for us. So the pain experience, if it's not properly managed, can lead to fear, avoidance, disuse, disability, worsens the psychological state of the patient. But if the pain experience is well managed, then the patient can have recovery or some level of recovery and improved quality of life. So we are all aware of this diagram. For mild pain, we know that we use the non-opioids, usually the NSAIDs with or without acetaminophen, with or without adjuvant. For moderate pain, we make use of the weak opioids, with or without the non-opioids, with or without adjuvant. And then for severe pain, we use the strong opioids, with or without step 1, and then step 2. Sometimes, this medical management of the pain might not be enough, so the patient will benefit from interventional or procedural treatment to help improve upon their pain. So these are some of them. We can do a tunneled epidural catheter or tunneled peritoneal catheters, like using the spigoted Tenkov catheter for malignant ascites, because your patient will be coming for maybe every 2 or 3 days for you to tap peritoneal fluid or do an ascitic tap for the patient. The multiple entry or the multiple taps will itself be its own risk factor for the patient. So instead of doing that, you can put in, we usually use a Tenkov catheter, which is used for peritoneal dialysis, but it can be co-opted and used specifically for this. It stays on the patient. When there's a need to drain, a specialized care nurse can go and then do the drainage and then spigot it back again. There are neuroablative procedures that can be done with radio frequency. So, example, you can use 50 to 100% alcohol or phenol or glycerol or even hypertonic saline. So these are some of the Tenkov catheters for abdominal drainage, because if the ascites becomes very gross, it splints the diaphragm, the patient goes into dyspnea, they go into a lot of distress. There's no amount of morphine that you will give in such a patient that is going to relieve. And the same thing goes for pleural effusion. You need to tap or put in or do a thoracotomy and the chest tube drainage in order to relieve the suffering that the patient. So there are several presentations that the patient can come with, the symptoms, and then so the management that can be done for the patient. Most importantly, that I need to stress on, as for physical management, we are all good at it, but we also need to be aware that for patients with chronic illnesses, they develop anxiety and depression, and it's quite common. So you can use the tricyclic antidepressants or the selective serotonin reuptake inhibitors or the serotonin norepinephrine reuptake inhibitors. And then non-pharmacological approach will be to do psychotherapy or mindfulness-based interventions, and then cognitive behavioral therapy are also available for us. For lack of appetite and its associated weight loss syndrome, some of the management that we can do are the steroids and the progestogens like megestrol. There's also a very serious focus on nutritional support, so which means that focus on high-calorie diet and nutrient-dense foods. And then we need to address all the emotional problems that the patient might be presenting with. In the lower and middle income countries, about 80% of palliative care burden is in lower and middle income countries, but access to palliative care services across Africa is just about 10% penetration. So some of the challenges could be systemic. such as the governmental policies or our essential medication list. There's also limited healthcare infrastructure or insufficient training in palliative care. There are cultural and religious barriers, especially from where I come from. We don't discuss death in the public, and it's a taboo. We don't talk about it. We also have a saying that men don't cry. So no matter how bad the pain is for the man, you cannot be seen to express yourself in public because of cultural taboos. There are opportunities to address this, which is being done, for example, being done in the Uganda model. There's community-based palliative care models. And then from where I come from, we've started integration of palliative care into our healthcare system. Also, task shifting strategies to train non-specialist healthcare workers is currently ongoing across several facilities. Okay, so why an integrative approach? We've spoken about the multidisciplinary team, and there's the need for an interdisciplinary team is very essential because the practice of palliation takes a team approach because no one person can address every single problem that the patient has because you need different medical specialties and disciplines. So the basic that you can even have in the team, you need some physicians, you need nurses, social workers, psychologists, chaplains, and then imams or traditionalists, pharmacists, and then other specialists. So the interdisciplinary team collaborates to provide comprehensive care by pooling their expertise and perspectives together to improve the patient. We, as family physicians, we don't just concentrate on the clinical diagnosis that the patient is presenting with. And even with the physical or clinical diagnosis, we take note of the organic diagnosis, the medical surgical comorbidities, the palliative problem list that the patient has, the psychological and psychiatric comorbidities. But we go beyond that to talk about the individual, as we do an individual assessment and diagnosis, taking into account the patient fears, worries, concerns, patient knowledge, attitudes, and practices, because what they know is what they practice. Sometimes the information they have might be wrong, so we need to listen to what they know, and then we can also correct them. The level of functioning is also important, because if they are not able to do the work that they previously were able to do, it affects their general outlook on life. Their expectations, especially if they are realistic, because if they are not realistic, and then based on the stage of the disease, we need to educate the patient and patient families on how to manage their expectations. At every visit in the clinic, we talk about their goals of care, and their spirituality is very important. Then we do a contextual assessment and diagnosis, which takes into account the environment, the immediate environment, which is the immediate family that the patient is in, and then the external environment, or the external environment, which refers to the community that the patient is in. So the resources that are available to the patient, the family support systems, financial support, influence of culture, tradition, and religion. So we have to identify problems in all these assessment areas and then address each and every one of them in order to provide a holistic assessment and then care for the patient. Communication is very important. And then, so the interdisciplinary team, communication and coordination of the condition is very important. Documentation is also very important. So the family physicians play a very vital role, because family physicians are traditionally trained to provide, to coordinate the care, to provide comprehensive care for the patient and patient relatives. So it's the family physician or the primary caregiver who will be in a position to direct that at this stage of the disease, maybe you need to go and see this one. At this stage of disease, you have to go. These are the symptoms you are presenting with. See this specialist. These are the concerns that you have. Let us call the social worker to discuss it. So depending on the spiritual leader based on the patient's faith, it needs to be discussed. The physician plays a very important role because they can focus on symptom management, providing medical interventions to relieve pain, The nurses also play a critical role in the daily management of the symptoms by providing bedside care and then serving as patient advocate. Psychological support with respect to social workers assess and support the social and emotional aspects of the care, including the family dynamics and access to resources. Spiritual care is also equally important, so chaplains and imams address the spiritual and existential concerns of the patient, helping them find meaning and peace, especially during the course of the illness and then at the end of life as well. Pharmacists are very important in playing a key role in ensuring optimal medication use, particularly for pain and symptom management. So they are very crucial for documentation and for avoiding medication errors, because at some point, the patients usually are on polypharmacy, they're taking a whole lot of medications. So you need the pharmacist plus the physician to make sure that you don't have drug-drug interactions, or some medications do not make the patient worse off. So components of the integrative pain management, I've spoken about this. There are other treatments that can be done, for example, massage, physiotherapy, transcutaneous electrical nerve stimulation. Aromatherapy is also there. Music therapy has been demonstrated to really help relieve stress from patients, to calm their nerves. Radiotherapy, especially if it's for conditions such as spinal cord compression and then the superior vena cava syndrome. Complementary, from where I come from, before the patient even come to you, they would have started some herbal medications or Ayurvedic medications. And so for some of them, it does help for them. There's an Indian medication that we use in our clinic called Aptizum. It's a medication designed for managing lack of appetite in growing children. But we found a lot of use for it in managing lack of appetite in our cancer patients, and it's working very well. Very soon we'll publish an article on it. So the spiritual care, as I spoke about, also is very important. Palliative care, or integrated palliative care, can be practiced at in all settings, whether pre-hospital or in the hospital setting. So in urgent care setting, outpatient, ambulatory. So these are the first two that we do in our hospital, and then inpatient care. It can also be practiced as part of home visits and community visits that we do. So how do we know that our patients have reached end of life? It's sometimes very difficult to tell, but we should be able to identify this. Some of the common signs that we can see may be profound weakness, reduced intake, or altered consciousness. Breathing patterns might be abnormal. There are some tools that we can use. The ECOG scale, palliative performance scale, and then the Karnofsky scale can also be used. Now, it's supposed to help us shift focus from disease management to comfort care, prioritizing symptom control, and then addressing all the family worry and anxiety. This is how the ECOG scale looks like, and then this is the palliative performance scale. So let's say we have a patient who is ECOG 4 and has PPS of 50%. You can see that estimated median survival in days is about 41. It's fairly correct and well correlated. So then it helps us in our planning for the kind of management that the patient will need, or the kind of preparation that we need to do for the patient. The patient at end of life can present with several symptoms that we need to be aware of. So pain, dyspnea, agitation, and secretions. So for pain, we can continue our opioid use. For dyspnea, low-dose opioids and then fan therapy can be useful. Use of anticholinergics like glycopyrrolate or hyoscine bromide, or even we can use tricyclic antidepressants for secretions. Agitation, we usually use either antipsychotics and then low-dose benzodiazepine for terminal delirium. We do not also forget about the family. So importance of family meetings to communicate prognosis, the goals of care, and provide emotional support are very important. We also prepare the patient for the prolonged illness and the stage that whether we are doing curative or we are doing life-prolonging treatment, or we are continuing with the supportive care, or we are doing end-of-life care, or hospice, or we are doing comfort care. So we can also provide what we call anticipatory grief counseling, where we give the patient and patient relatives information to prepare them for an eventual death that might happen very soon. So some ethical considerations that we need to be aware of. We need to respect the patient's autonomy because it's their body and they decide what they want to do with it. But it's our responsibility to give the patient all the information that they need so that they can make the decision that they can almost do. And also advanced directives are very important at this stage. Sorry, even before that, so that the patient can give advanced directives on, for example, do not resuscitate, do not investigate, the temporary durable medical power of attorney, communication, family, forgiveness, togetherness can all be discussed here so that the patient and patient family will be better prepared for any eventual outcome. So an integrative palliative care is very important for our patient because when we start palliative care very early in the care of our patients, their general outcome improves markedly compared to patients who access palliative care services later on at the end. Family physicians have a very crucial role in delivering and coordinating palliative care, whether it is patient-centered care, interdisciplinary approach. When we start palliative care early in the disease trajectory, we get improved outcome. Thank you.
Thank you so much, Doc. At this juncture, we will transition into a panel discussion where we'll continue the conversation that has been ably handled by Doc. I invite Dr. Grace Momba, Dr. Mamadou Sow, Dr. Sapausa Victor Nicholas King, Dr. Gloria Adiambo Omondi, Dr. Gide, Dr. Gregory, Dr. Musiana. Sana. So welcome to this final session. We'll take almost 20 minutes at least to go through this session. My name is Dr. Anteni. I'm a diagnostic and interventional radiologist based in Lusaka, Zambia. I've got an able panel here and we're going to each talk about pain management from our various sectors. And I would like to introduce my co-moderator, Dr. Fatou. Then she'll get the ball rolling.
Okay. Thank you. So we'll just proceed with the panel discussion. We'll try to make it as interactive as possible. So I will start with Dr. Gregory Faure.
Yeah, good evening, everybody. I am Dr. Gregory Bajala Faure. Sorry. I'm from Sierra Leone, West Africa. I am a trained pain and palliative care fellow from India, sponsored by Merck Foundation. And I am also the executive director of Sierra Comfort Home Care Agency, which is fairly very new, established by myself and colleagues after completing my fellowship program in pain and palliative medicine.
Hello, everyone. My name is Dr. Mamadou Sow. I will do my speech in French, so I speak in French. Mon nom, je me présente d'abord. Mon nom c'est Dr. Mamadou Sow. Je suis chirurgien cancérologue à l'hôpital d'Al-Adjam de Dakar, au Sénégal. Donc j'ai eu à compléter un an de fellowship avec Merck Foundation en surgical oncology. Et quand je le faisais, j'avais exprès choisi 3 départements, le sang, les cancers gynécologiques et les parties molles. Donc, actuellement, je suis en train de travailler spécialement sur tout ce qui est breast oncology, gynec oncology et soft tissue sarcoma. Merci.
I am Dr. Abdul Qadir Muhammad Said. I am from Ethiopia. I'm working in Addis Ababa University College of Medical Science and in the Department of Pediatrics and Child Health. I'm a hemato-oncologist, and I trained in 2018 by Merck Foundation in the fellowship program of Pediatrics Medical Oncology. Thank you.
I am Othniel Musana, a Merck Oncology Fellow. I'm a gyne-oncologist working at a faith-based private not-for-profit hospital in Uganda. I think that's a bit for now.
I'm Dr. Sopwasi, Victor Nicholas King. I'm a gynecology oncologist. I'm head of unit at our National Referral Hospital in Monrovia, John F. Kennedy. I'm a Merck Foundation Fellow.
Afternoon. My name is Gloria Omondi. I am a physician, and I'm grateful to Merck Foundation. They sponsored me for my MSc in clinical oncology. I work in a hospital called Kenyatta Hospital, our largest in Nairobi, Kenya. And currently I'm ongoing with my oncology training as a fellowship in medical oncology. Thank you.
Hello, I'm Dr. Grace Momba. I'm a medical practitioner as well. I am currently working in a district in Malawi called Chikwawa district. I'm working in the public health space. I was sponsored by Merck Foundation. And I did a postgraduate diploma in cancer and clinical oncology under Queen Mary University of London. It was an online program. Thank you.
Okay. Thank you all for the detailed introduction. So we'll just go with Dr. Gregory Furey. We'll just have a few questions for you so that you will just enlighten the audience. So the first question will be, how do palliative care professionals collaborate with family members and caregivers to support the patient's need holistically?
Thank you very much for that question. Of course, for most of us coming from Africa, we know care is basically generated, or care generally starts from the home where you have all of the family members. Therefore, if we actually want to properly manage the patient, we cannot do it without the presence of the family members. So they are not just bystanders there, but they should be part of the care team that provides support for their patients. So what basically happens when you have maybe what happens generally in a hospital setting when a physician gets into the hospital. So what they will do most of the times is that they will ask all of the relatives to go out of the ward. Once you are needed, they call you in. And that brings a lot of confusion and dissatisfaction among the patients and even among the relatives. Therefore, with palliative care team, having the family members or the caregivers as part of, as playing an integral part in providing support for their patients brings a lot of satisfaction. So what they will really do is, as a palliative care team, we have to ensure that we integrate those family members or caregivers into caring for their patients and their loved ones. So they have to be part of the care provider. And how do we empower them to actually provide care for these their relatives. So it has to do with a lot of open communication. So you have to open communication with them. You have to teach them, and you have to make them powerful so that all decisions that are taken regarding their family members are taken unanimously by the palliative care team, the family members, and then the patients themselves. So with that, integrating that aspect of care really brings comfort. And mind you, when we were talking about palliative care, we're not only palliating the patients, but we're also palliating the family members. So it's very important. And some of the evidences we have, because in medicine now you have to speak with evidence. Some of the evidences we have will have to do research that has been done in the past, which mostly says if you support family members very early, family caregivers and family members in managing the patient, then it means those patients will mostly be satisfied, and then they will be pain-free on most occasions. So we have multiple research that has been done that actually supports the use of family members in caring for their loved ones. So their importance cannot be underestimated at all.
Thank you very much. In the previous session, we were taught that pain management involves a number of specialties. Dr. Gloria, you're a medical oncologist. So there's a patient, then there are other colleagues of us. You need to organize us, but at the same time, you need to empower the patient. How do you go about it?
How I go about empowering the patient? Okay. Thank you for that question. Yes, I really enjoyed the past lecture, and like you were told, there are very many people who are involved in cancer care. One of the things that I like to do is actually to pick the pain. Like our colleague told us, ladies may complain, but men, the African man especially, sometimes they keep quiet about their pain. They suffer in silence. Or even when they have the pain, they feel like it is not okay to complain. So one of the things I like to educate the patients about is to voice their pain and teach them that complaining, telling us about their pain is not complaining. So encourage the patients to voice their pain. I think that's very important, because many patients will come and tell you about other things apart from their pain, yet that's a very important part of cancer care in our patients. So I really encourage patients to talk about their pain, and you even teach them how to report their pains. You know, normally you ask a patient, how are you doing? I'm okay. I mean, even if they're suffering so much, they'll just say, I'm okay, especially in the African greeting. How are you? I am fine, even when you're dying of pain. So teach them to report their pain objectively. For example, personally I use numeric scale. So tell me, how is your pain today? Are we doing 1? Are we doing 10? Are we doing 9? So let them learn how to do, to report their pain objectively. I think that really helps even for a doctor. You know, knowing how well you're doing and whether you need other people. And then the other thing to tell about your patients, let them know that pain is a low-hanging fruit, as I would put it. You know, sometimes cancer, you may not be able to solve everything in cancer, for example, give cure, like in stage 4 cancer. But I tell my patients that pain is something you should not suffer. You know, the other things you may not be able to solve in cancer, but pain, let's not suffer that one. It's one of the things we can easily eliminate. So let your patients know that pain can be eliminated, that as a medical oncologist, if I give them a tablet it's not working, let them know that there's another option after that. And if it doesn't work, there's another option. And if as a medical oncologist I'm not able to solve that, there are pain specialists who have other modalities, you know, that they are there. There are radiotherapists that can help with their pain. There are anesthetists who can do, you know, procedures to kill their pain. So let the patient know, because if they know, they'll feel more comfortable and they will not, you know, despair or give up. I think that really helps improve the patient. So in summary, I educate the patients, let them voice their pain, you know, it's not complaining. It's okay to say that I'm in pain. And number two, I encourage them to voice their pain objectively, and I teach them how, and let them know that there are options, because some people suffer out of ignorance because of our fault as clinicians. Thank you.
That's lovely. So, Dr. Mamadou, you're a surgical oncologist and you've been practicing for a while. So, how do you assess the potential for postoperative pain in cancer surgeries? And how do you involve pain specialists pre and post-surgery?
You'll need a translator. En tant que chirurgien,
so as a surgeon,
yeah. Understand. Okay, thank you. En tant que chirurgien cancérologue,
as an oncology surgeon,
on est obligé, et en tant que cancérologue également, nous sommes confrontés à chaque fois à la prise en charge de la douleur.
we're faced with pain management all the time.
Maintenant, cette prise en charge, moi, en tant que chirurgien cancérologue, comment je le fais dans ma clinique?
How do I do that?
D'abord, je m'intéresse à l'état du patient.
I care for the state of the patient.
Parce que prendre en charge la douleur, ça dépend du type de cancer que tu as. Où est-ce que le cancer siège?
It depends on the location of the cancer.
Faire opérer quelqu'un du bras, par exemple un cancer de la peau, c'est différent de faire une vulvectomie radicale, par exemple.
So operating a patient for a skin problem is different from having a long surgery, for example.
Il y a aussi l'état, on en a parlé tout à l'heure, hein, l'état psychologique du malade.
The psychological state of the patient.
Un malade dépressif est différent d'un malade qui est normal, qui a juste mal.
Different from the patient who is normal.
C'est aussi, voilà. Donc, compte tenu de tout ça, je m'intéresse également à comment est-ce que le patient va pouvoir décrire sa douleur.
I care about
Donc,
how the patient describes his pain.
Chez nous, ce qu'on fait, on utilise l'échelle d'évaluation analogique.
So he used the analogical scale.
Normalement,
of pain
elle est visuelle et elle est verbale en même temps.
It's visual, it's verbal.
Donc, c'est ça qu'on a l'habitude d'utiliser.
So that's what we use.
Et en tant que chirurgien, avant également d'opérer un malade ou bien après avoir opéré un malade, on est obligé de l'envoyer voir un anesthésiste.
As a surgeon, before or after doing a surgery, I send the patient to see an anesthesiologist.
Et c'est l'anesthésiste également qui nous aide à évaluer ce patient.
And the anesthesiologist is the one who helps us to assess that
Et
patient.
avec l'aide également de l'anesthésiste,
With his help,
avant l'intervention bien sûr,
before the intervention,
il saura exactement quelle analgésie donner,
to know what type of analgesia to
comment
give,
le donner,
how to give it.
et également après avoir opéré le patient par contre,
After the surgery,
chez moi, l'anesthésiste c'est fini. Hein?
I don't involve the anesthesiologist
Il y a
anymore.
beaucoup de malades, c'est un centre hospitalier public.
It's a teaching hospital, it's a government institution.
Notre population, 18 millions d'habitants.
18 million inhabitants, our population.
Sans compter toute la sous-région, le Mali,
Not
la
talking about the
Mauritanie,
sub-region, Mali,
la Guinée, qui
Guinée.
viennent également se soigner là-bas.
They also come over for treatment.
Donc, on est obligé nous-mêmes, en tant que chirurgiens, de gérer la douleur de nos patients en post-op.
So because of the load of patients, surgeons have to, personally get involved in the care of pain of their patients.
Yeah. Maintenant, il y a plusieurs manières de le gérer. On peut utiliser des médicaments et des dérivés morphiniques les moins puissants.
So we can use weak opioids.
Utiliser les morphiniques même.
Or the stronger ones.
Donc c'est ça. Par contre, il y a quelque chose dans le département où je suis.
In my department,
Je suis aidé par un spécialiste en soins palliatifs.
I have a palliative care physician working along with me.
Donc, ce spécialiste en soins palliatifs m'aide dans la prise en charge de l'administration, des explications, des doses à prendre en hospitalisation.
So he counsels his patient, administers the drugs.
Mais par contre, vu qu'elle est seule, elle ne peut pas s'occuper de tout ça.
So she's alone, so we work, hands in hands.
Donc, ma charge de travail, à chaque fois, ça augmente parce que je n'ai pas seulement à consulter, à opérer, mais je m'occupe également des douleurs des malades en hospitalisation.
So he not only, sees the patient outpatient, does surgery, but postoperatively he has to be the one to administer the pain management.
Donc, en gros, moi, c'est comme ça que je fais pour manager la douleur de mes patients en pré et en post-op.
So globally, that's how he goes about managing his patients' pain pre and postoperatively.
Dr. Msana, you're a gyne-onco, senior gyne-onco. You've been treating these cancers, and they present to you in advanced cases, and most of them come in severe pain. So how do you integrate pain management in that? Even as you treat them, sometimes your radiotherapy, your surgeries can induce pain itself. How do you balance that? You still ensure that you give them pain, you treat the pain, but at the same time you manage the pain that you may cause as you do surgery and radiation.
Yes, so thank you very much. As you say, I usually define a specialist as somebody who knows the disease disorder, knows how to treat it, but also knows how to treat the complications of what they are using to treat. For example, if I do surgery, I'll cause complications, and pain is one of them. Generally, Uganda has a very good palliative care system for the past 30 years, and all of us through medical school have to go through that training, whether you're a nurse, a doctor, an allied health. So for the palliative care team at the hospital, I think it's a very solid one. Most of it is nurse-led. We don't have a pain specialist at the hospital, so most of the palliative care is done by the nurses, but they're quite experienced in that. Now, I will come to the complications that we cause ourselves, the complications that either of surgery or radiotherapy, that we are the ones intervening and then, of course, causing issues. So for those ones, we normally manage them individually. That said, over the past few years, the anesthesiologists have actively become involved as they get used to seeing more and more complex cases. Before, we never used to do the difficult surgeries. We never used to have the post-op radiation complications. Now that they're increasing, the other physicians, especially anesthesiology, is becoming highly involved, especially in managing acute pain. Two, at a personal level, of course, as a clinician, eventually you'll burn out if you're seeing a very heavy load of patients, and of course, burnout causes issues. So one of the things that I have chosen to do is to reduce my clinical work to 1 day a week. People ask me, why are you reducing your clinical work to 1 day a week? It's because doctors don't understand that there's a bigger impact outside than inside. And one of them is that I'm actively now involved in leading what we call the National Surgical Obstetrics and Anesthesia Plan, to include cancer care and pain management as a policy within that plan. That plan also affects, of course, how we decide on essential medicines for not only pain management, but other things. And of course, things like epidurals and the other things will come, because if it comes in the policy, then the ministry and the government is forced to pay for those supplies that will be used to manage pain outside the routine palliative care. So, because routine palliative care is focusing not on morphine, but for us as clinicians, we want the epidurals, we want the fentanyls, we want the morphine supply. And many of the patients in the government hospitals, public sector, do not receive adequate pain control. So one of the things that we are doing is influencing at that level to see that we can get into the government supply chain to produce or to supply those medications as a right for those cancer patients. Then, of course, I am also taking part in writing a pain management policy that we are using for advocacy. Some of the work I do is with legal aid. And of course, if we cannot get through to the government, sometimes we do what we call reproductive justice litigation. So we sue somebody so that the change that we need is taken over. Our country focuses heavily on maternal and child health, but because of the improvements in maternal and child health, now we are having the NCDs and cancer is among them. So of course we have sued the government for maternal and child health with some success. That included increasing the budgets, but now we are trying to write a policy and support the reproductive justice litigation processes so that we can also get pain management and cancer care high on the agenda of the government. So clinical work is about 25% of my work these days. A lot of my work is on advocacy and also empowering not just the media, but also those people involved in litigation to ensure that we can get pain management and other cancer-related policies on the table and funded by the government. Thank you.
So the next speaker will be Dr. Abdul Kadri, who's a consultant pediatrician. I know how much you love the kids. We've worked together. I've seen him. So how do you balance the need for aggressive cancer treatments with the side effects, including pain, that they cause in children? I know it's a...
Thank you. Just in our setup, actually we don't have, we have a MDT team, but we don't have a palliative care team. But we have the MDT team is handling the activities. So when we see this on the aggressive treatment, we have to see different cases and the stage and other things before we decide how to proceed for the treatment. For example, in a patient who has osteosarcoma with multiple lung disease, because such patients are not in our setup salvageable, we have to discuss with the family, and sometimes we also with the parents, and sometimes we involve also the children about the disease process, and then we decide based on the consensus with the family that the patient should go for palliation rather than being aggressively treat the patient. Those who can afford and has 2 or 3 lung mates, we offer them there is a possibility that they can even be treated abroad. So after discussion, we'll decide with the parents which type of treatment should get the patient, and based on that we'll decide. So because this one thing, the other thing which I want to mention, for example, AML patients, we treat AML patients. AML, you know, that is a severe disease, and when we treat AML patients, we discuss with the parents about the outcome, and sometimes when the patient, if the parents are not willing to go for the treatment and to go back home, just we give them metronomic treatment. We don't push them to have 7+3 or aggressive treatment. So based on the patient factor, the family, and also the setup of the hospital, we discuss on the aggressiveness of the treatment, and we decide with consensus with a family. That is how we proceed. Thank you.
He's brought up a very important point, that multidisciplinary. In many places, we do not have teams just to look at pain. Dr. Grace, tell us about multidisciplinary team. What is your experience with that? Do you have it at your place? What are the gaps that you've seen? How can we start this?
Thank you so much. As I've said, I'm working in a district, so I'm overseeing primary and secondary healthcare facilities. So to first of all answer your question on whether we have these at the district setup, I am going to say an overall no. Why do I say this? Because an example of the setup where I'm in, we have about 5 functional palliative care clinics, and we have over 33 facilities. So it means we're having patients coming from all over the district to access palliative care in these 5 or 6 places that we have. So for us to come up with a proper multidisciplinary team, even at district level, it's a little tasking, because you would find that the specialty services are not available in the district. We have days where we have the specialists come in for different areas, for example, gynae and other maternal health issues. So when you look at the oncology side, I think somebody mentioned here that there's a lot of funding out there on SRH and other things, but when you look at oncology, we don't really have much that is directed towards oncology. So even in my country, you would find that among the cancers, there are particular cancers that are very, very popular, cervical cancer and others, but you have other very difficult to manage cancers that don't have the proper management plans, or that don't have the proper funding in place. So I would say that the multidisciplinary team, from what we have discussed from the lecture and even from my colleagues, these are very necessary. And the gaps that I've seen, it's the lack of it, number one, in the secondary level, for example. They're mostly focused in the tertiary facilities. Yeah.
Thank you very much.
Yes, thank you, Grace. She's very right. Because I've worked at the Malawi, at the Central Hospital as well, and then this is one of the challenges, though they do have the department, but the district hospitals, like you said, they don't have, and then it's a challenging situation. So we'll just go to Dr. Victor King, who's going to talk to us about some of the key challenges and opportunities in coordinating pain management plans with other specialties such as anesthesiologists, palliative care physicians, and psycho-oncologists in the treatment of gynecological cancer patients.
Thank you. Well, like I said, in my introduction, I'm from Liberia. So Liberia is still struggling, with the consequences of the 14 years of civil war that we had. So that means that if you look at the entire health system, I think as compared to other African countries, because I'm listening to you and I'm quite jealous, because there are so many specialists, even at the district level, and which is very, very interesting. For Liberia, we are struggling with major issue when it comes to, workforce, infrastructures. So we don't have the luxury to, of psycho-oncologists, of palliative care physicians. For example, at the National Referral Hospital where I work, JFK, we are blessed now to have 3 gynae oncologists. I was trained with Merck Foundation, but the 2 others were trained with different other institutions. But unfortunately, we know that, and I think the doctor said it, maternal health is a major challenge, maternal mortality. So it has been a problem where the administration has demanded gynae oncologists to focus on maternal mortality, relegating somehow, the care of cancer. And so we have the overstretched effort of gynae oncologists focusing, not only on trying at your own weak level to focus on cancer patients, but having to put more emphasis on maternal mortality. So currently we have in our national referrals, we have 4 anesthesiologists. Only 1 is Liberian. The 3 others were hired from other countries. And again, only one of them have an expertise when it comes to pain management. So it's true, he's been of great help. He's from Ethiopia, by the way, and he has been of great help in helping us to, when it comes to managing severe pains using morphine. But in a day-to-day activity where you have patients coming with level of pains requiring, for example, a week, morphinic like tramadol, is very difficult for a patient to sustain, to maintain tramadol for a longer time. Why? Because we're in a country where the vast majority of the people earn less than $1 a day. And when you look at tramadol cost, it's about $10 for 10 tablets. So it's not sustainable. So pain care in Liberia is a major issue. We don't have access to, because I know that Uganda is very strong when it comes to pain management using morphine powder. We don't have that with us. And one of the major reasons is because we have a very restrictive policy when it comes to use of morphinics. Right now, Liberia is struggling with many ghettos where the young people are using, morphinics as a use of, drug addiction. So it's a major issue. I think it's a national emergency back home, and because of that, the country has put very, very strong policies in providing and making available, morphinics. So I can say that the challenge of pain care in Liberia is not only at the level of the workforce, but it's also even about, when it comes to supply chain of those drugs. So what we're trying to advocate for now is for the government to, implement some reforms when it comes to, morphinics and morphinics availability. This is something that we are talking about all the time, because it's not because few people are misusing some drugs that the weaker ones should suffer. So there's also something that we have done back home with the help of APCA, the African Palliative Care Association. We have trained over 40 healthcare workers, medical officers, nurses, midwives, into various sectors of palliative care. But these staff are mainly sent in rural areas where, because the 4 anesthesiologists that Liberia has are all in the National Referral Hospital. So the women in the rural areas don't have those benefits. So those people were trained and they were sent in rural areas to be able to help when it comes to counseling, when it comes to drug administration. And so far, these are the few things that we've been doing back home. Thank you.
Thank you, Doug. I think we share the same feeling, especially when it comes to Gambia, so I can really relate to what you're saying. We do have a palliative care department, but I've never seen them in the hospital for the palliative patients. So it's a difficult situation. So before we'll round up, I think I should ask Dr. Fori this question about psychology tells us that a human being is a psychosocial being. So you don't have to address only the physical part of the pain, but you need to address the social aspect and the emotional aspect of pain. So how do you do that?
Yeah, thank you very much. So
in 1 minute. 1 minute.
Okay. So we know what is different about palliative care is really treating the patient holistically. So which means people are much more than just bodies, but then it has to do with their mind, with their heart and everything. So if you combine all of these things, that means you're actually treating the patient holistically, taking into consideration physically what they are feeling, the pain they are feeling, emotionally and psychologically, the stress that they are going through because of the pronouncement of cancer. You can imagine how much stress they might be going through because you have cancer, now you're not able to go to work, you were the breadwinner, children are driven from school because of school fees. So all of those things can be really distressing to the patient. So it's not only the pain that you're treating, but then you're treating those other aspects that actually have effects on the pain. I think one of the presentation we had previously did mention that once you have those things, they can actually worsen your pain. And if those pains are worsened because of those other issues, those other domains of care that should have been taken care of, then you might need to use more morphine, which is not readily available, or more tramadol, which can be very expensive, rather than you actually having people to address the social issues. Okay, now you have cancer. What we can do, there is an organization that can actually help provide school fees for those children. Okay, now you're the breadwinner of the family. Now, we can link you up with an organization that can actually help provide for the family. That one can be very relieving to the patient, and you'll find out that that patient will have a very good night's sleep. So even your morphine that you're giving for the pain will be really reduced. And not underestimating the importance of the spirituality of patients, wherein somebody goes to church every Sunday, pays all of his tithe, and then develops cancer. I mean, we'll say, why me? Why did it happen to me? You have a lot of other people who are not even praying to their gods, but then they are fine, so why me? So this stress can be really troubling to the patient. So if we really want to manage the patient, then we have to consider all of those things. And that was one of the reasons why Dame Cicely Saunders actually brought the concept of total pain, wherein when you have the physical, the psychological, the social, and the spiritual distress, okay, affecting the patient, then it means that's a total pain. So you have to holistically manage all of those things with your multidisciplinary team. So one person will not do it at all. Thank you.
Yes, and to borrow what Dr. Omonde said, when we see our patients, at least we should say, you can suffer anything, but not pain. And that's my take-home message today. Please give a vote of thanks as we come to the...
So I just want to say thank you to all the panelists and then everyone here. It's been a long day, but I'm sure it is very, very fruitful. We have all learned new things.
Check our website, makefoundation.com, and also Make Foundation. Search for it. There are some scholarships that are offered, and many of these gaps that we have been discussing here can be sorted out by you applying. Please go to the website and see if you are interested in one of those things. Thank you very much. We end here.
Thank you.